Hello, and welcome to Ketamine Across the Dose Spectrum, a CE recorded on-demand educational webinar. This content was originally created for the Oregon Naturopathic Board. However, California has since adopted the approval of 6 hours of CE credits, 2 hours ethics, 4 hours of pharmacology. Please enjoy. Please note the instructions in this slide as to how to obtain your CE credits. You will need to scan the QR code listed here. It will take you to a CE quiz. Upon successful completion of the quiz, you will be emailed a CE certificate. Please also note the email address in case you have any questions or concerns. susieconsulting@gmail.com. Thank you very much.
Hello, and welcome to Ketamine Across the Dosing Spectrum, an educational webinar. It's a 6-hour CME course which has been approved by the Oregon Naturopathic Board. 2 hours of ethics, 4 hours of pharmacology. Upon completion, you will see a QR code for scanning that will take you directly to a quiz. Once the quiz is completed, you will receive a CME certificate. My name is Susie Glenn. I have the pleasure of moderating the event today. I would like to introduce you to our well-renowned board of speakers. Dr. Stephen Mandel, the founder and president of the Ketamine Clinic of Los Angeles. He is internationally recognized expert and pioneer in the use of ketamine infusion therapy to treat mental health disorders and chronic pain. Dr. Mandel has more than 40 years' experience utilizing ketamine as a board-certified anesthesiologist. Dr. Mandel is also the founder of the American Society of Ketamine Physicians, Psychotherapists, and Practitioners, ASKP3. Dr. Mandel has administered more than 15,000 ketamine infusions. Rakesh Jain, MD. Dr. Jain is a psychiatrist who completed his postdoctorate fellowship in research psychiatry at the University of Texas Mental Health Science Institute in Houston. Dr. Jain is currently involved in multiple research projects studying the effects of medication on short-term and long-term treatment of depression, anxiety, pain, mood, overlap disorders, and psychosis in adult and adolescent populations. He is the author of several articles in the issue of mood and pain conditions. He was also recently awarded the chair of the steering committee for the U.S. Psychiatric Congress. Lucinda Grande, MD, our course director. Dr. Grande is a partner at Pioneer Family Practice in Lacey, Washington, where she provides primary care, specializing in the management of chronic pain and behavioral health disorders, including addiction. In 2012, Dr. Grande began exploring the use of ketamine in the ambulatory setting for the treatment of chronic and acute pain and mental health disorders. In the course of treating over 500 patients, she developed a microdosing protocol utilizing oral and sublingual ketamine, which has been used by hundreds of new prescribers of ketamine. She has recently developed a ketamine microdosing strategy to assist people with opioid use disorder transitioning from illicit fentanyl to buprenorphine therapy. She is on the board of directors of the Washington Society of Addiction Medicine. She is an advocate for policy change on behalf of people with substance use disorder and chronic pain. David Dansky, MD. Dr. Dansky attended medical school at the University of California, San Francisco School of Medicine and subsequently specialized in both emergency medicine and internal medicine. After completing double residency at Northwestern Memorial Hospital in Chicago, he has used ketamine for procedures and pain management in the emergency department for over 30 years and is the founder and president of Monterey Integrated Therapies in Carmel, California. He also lectures regularly on the medical aspects of ketamine and co-facilitates CAP programs at the Ketamine Training Center in San Ismenlo, California. Dr. Lindsay Wilkinson is a naturopathic physician and acupuncturist who works with patients on a wide variety of mental health, gynecologic, and digestive health disorders. She is pursuing focused clinical training on non-ordinary states of consciousness and incorporated ketamine-assisted therapy as a foundational healing modality in her private practice in Portland, Oregon. Hilary Sandell is a naturopathic doctor and licensed acupuncturist who uses combination therapies including diet and nutrition, herbal remedies, acupuncture, somatic bodywork, and prescription medications to treat patients suffering from a wide variety of chronic conditions. Her areas of expertise include metabolic health, gastrointestinal disorders, mood disorders, and hormone dysregulation. Dr. Sandell has been practicing in Beaverton, Oregon since 2015. She's been using microdosing of ketamine to address mental emotional symptoms and has treated over 100 patients with ketamine since 2020. She is passionate about psychedelics and their ability to rewire our brains, reset our nervous system, and shift our stress response and change our mindset.
Good morning. Welcome to Ketamine Treatment Across the Dose Spectrum. I'm Lucinda Grandy, Course Director. We are excited to offer you a broad perspective on ketamine treatment options. This program was developed specifically to meet the needs of naturopathic physicians in Oregon. Development of this program was stimulated by recent regulation changes by the Oregon Board of Naturopathic Medicine. The course includes 4 hours of pharmacology and 2 hours of ethics. Over 500 people registered for this course today. Over 90% are naturopathic physicians from Oregon, our target audience, but many of you are from other fields of practice, hailing from across the country and almost every continent. The presenters today represent a range of medical specialties and modes of treatment, and together have many decades of ketamine experience. They are not only smart and experienced, but also open-minded. I believe that open-mindedness is the key feature of the successful ketamine practitioner and is of great importance for optimizing individual and societal benefits from this versatile medication. I hope you will be inspired by the wisdom of all of these speakers. The day's agenda can be found in the main session section. You can click there and then page down to see the details. There will be 5-minute breaks in between the presentations and a 30-minute lunch break, during which the presenters will be available for a question and answer session. I encourage you to peruse the details on the background of each of the presenters. The information is available in the Zoom lobby under Speakers tab at the top. Dr. Lindsay Wilkinson is a naturopathic physician and acupuncturist in private practice in Portland, Oregon. She will discuss the Oregon regulations in more detail in just a moment, and this afternoon will share her perspective as a naturopathic physician who provides ketamine infusions, and will discuss a range of topics, including Oregon's leadership in psychedelics legislation. Dr. David Dansky, internal medicine and emergency physician, is the founder and president of Monterey Integrated Therapies in Carmel, California. He will present on pharmacology principles with his unique wit and charm. Dr. Stephen Mandel, anesthesiologist, is founder and president of Ketamine Clinics of Los Angeles. He will present in both the pharmacology and ethics portions, sharing his intellectual breadth and business leadership acumen. I am a family physician and addiction medicine specialist at Pioneer Family Practice in Lacey, Washington. I will share practical findings primarily from my own clinical research on ketamine microdosing. Dr. Rakesh Jain, a psychiatrist, is a clinical professor of psychiatry at Texas Tech School of Medicine and a researcher, writer, and an eloquent speaker, as you will discover this afternoon in the ethics portion. His presentation has been pre-recorded as he is unable to be with us live today. Rakesh, our thoughts are with you and Sandra today. Dr. Hilary Sandell is a naturopathic physician and licensed acupuncturist in Beaverton, Oregon, who has become proficient with the microdosing strategy. She will discuss practical aspects of microdosing, particularly relevant to naturopathic physicians. And finally, I would like to offer an enormous thank you to Susie Glenn, the consultant who has done some very heavy lifting with all the logistics of this event. She is affiliated with a compounding pharmacy whose name we will not be sharing in the interest of limiting the appearance of commercial influence on this academic program. In addition, we have assistance from Megan Buffington from Zoom, who is helping to ensure smooth proceedings today. Here are some housekeeping items. During each presentation, there will be time reserved for questions and answers. You are invited to use the Q&A button at the bottom of your screen to ask questions of the presenters. Use the chat button to interact and engage with your fellow attendees. We look forward to an open and vibrant discussion. In the Q&A box, you can vote on other people's questions to raise their priority level in the queue. Today's program will be recorded, and the recording will be made available after the live event. Details will be shared with you via email once available. There is a frequently asked questions document that explains how Oregon naturopathic physicians may obtain continuing education credit. Susie has entered it into the chat box for your convenience. It's way up at the top of the chat box, and it will also be available via email after the session. Please be on the lookout at the end of the day for a brief SurveyMonkey quiz required for these credits. Finally, I would like to highlight some key messages from Dr. Jane's ethics presentation that you will see this afternoon. You are on the right track, getting educated about ketamine as you prepare to provide this valuable treatment. While you may become enthusiastic about the potential benefits of ketamine for your patients, it is extremely important to steer clear of overpromising and false advertising. What we each say and do can have a positive or a negative impact on this field and on the opportunity for the largest number of patients to have access to the benefits of this treatment. Now, Dr. Wilkinson has some words for you.
Good morning, everyone. I just want to start by saying thank you all so much for participating. This is a really exciting program. All of the presenters are really thrilled to be able to offer our expertise, our information, and answer questions to all of you. So thank you so much for coming. As you know, on January 1st, we received notification from the Oregon Naturopathic Board describing and outlining specific scope of practice requirements for naturopathic doctors who want to use ketamine, and especially specifically non-topical preparations of ketamine at sub-anesthetic doses. So the name of this presentation is Ketamine Across the Spectrum. And really what I found in my own personal practice and hearing all of these experts talk about their practice and case studies and clinical applications is there is a wide variety of clinical possibilities with ketamine dosing, all the way from very low subcognitive microdosing all the way through up to psychedelic sort of sub-anesthetic dosing. So we hope to present you with an introduction to this wide variety of applications, a wide variety of dosing strategies and routes of administration as well. You will hear some repeat information from different providers in different ways, and that just highlights the importance of some of the considerations that we need to take into account when working with ketamine. I also want to just send a really big thank you to all of those naturopathic doctors who have been in discussion over the past several months with the Oregon Naturopathic Board to create these very clear, a new scope of practice, widening our scope of practice for the use of ketamine, and creating clear guidelines for us practitioners so that we can really have a standard of care or start a conversation about creating standard protocols and procedures and sharing this information. So thank you to those doctors, big shout out, as well as to the board who's been super responsive. They've been great in getting this CE event completely certified for us. So this will fulfill all of your requirements, the 4 hours of pharmacy education and 2 hours of ethics. I will say that this is really an introduction. It's not going to be able to give you the full breadth and information on complete dosing strategies, complete medication interactions, troubleshooting complicated cases, but you should have a really clear idea by the end of the day how to start using ketamine, especially with microdosing protocols, and have a lot more information and background if you want to educate yourself further with macrodosing, psycholytic or psychedelic dosing with ketamine. So thank you again for coming, and we're excited to present to you today.
Thank you so much, Dr. Wilkinson. We appreciate you walking us through the new regulations and setting the stage for today's conversation. I'd like to introduce you to Dr. David Dansky. He's going to be walking through the ketamine pharmacology principles. We look forward to hearing his presentation. Enjoy.
Okay, so we're going to go through a whole lot of material awfully quickly. I tend to speak way too fast. Please note my email address at the bottom of this screen. Note that it's Dave Dansky. If you write David Dansky, you'll meet a very nice retired Jewish bicycle dealer in London who will take you on a tour of the Thames. That may not be what you're looking for, so just note it down. So this is quite an exceptional molecule. It was derived from PCP back in '62. Note that it's FDA approved down to the age of 3 months. You can't get Motrin, you can't get Benadryl for your child that young. I mean, this is how safe it's considered to be. If Dr. Mandel and I were 19-year-old buddies in Vietnam in the same foxhole and I got shot, he'd pull out a syringe of this stuff, put me out of my misery while he medevaced me out. I'd keep breathing, my blood pressure would stay up. I mean, it's just phenomenal for a number of things. So it's quite a Swiss Army knife. And this is a brief encapsulation of what the molecule looks like. This here is the ketone. This here is the amine. Ketone plus amine equals ketamine. But what I find when I talk to patients about it is, dude, I dissociate every time I see my ex at Trader Joe's. Why would I want to be given a dissociative anesthetic? And it's a very different type of dissociation. We could spend a week-long course just discussing the word dissociation from a psychological perspective. In this case, what you are dissociating from is physical pain, psychic pain, OCD, anxiety, PTSD. It's exactly the opposite of what they might think. Now, ketamine doesn't get a lot of great press. If you look at MDMA, there was a wonderful article in one of the most prestigious medical magazines, Nature, about how well it works for PTSD. Tony Bosses, who helped write this article on psilocybin for end-of-life care, was featured in Michael Pollan's series on Netflix, How to Change Your Mind. He was in Fantastic Fungi. But when it comes to ketamine, it's like the Rodney Dangerfield of psychedelic therapy. I don't get no respect. So what is it we're why are we taking the day to talk about ketamine? We're talking about psychedelic therapy. Now, what psychedelic, of course, is a word that's been bandied about for 50, 60 years now. What does it mean to us? Psyche is the Greek word for mind or soul. Delos is manifesting, manifester. So this is a soul manifester. Well, that sounds nice, but what does it actually look like? This is a schematic of a functional MRI. On the left, we have a brain in normal activity where everything is completely repressed except the task at hand. And this is how most of us spend our lives. And it's how we want to be most of the time. If you're driving a car, if you're operating, if you're intubating, talking with a patient, you need this kind of focus. On the right, we have the same brain when these repressing cells, certain inhibiting cells, are themselves inhibited. This sounds confusing. So what it looks like, if you can remember back to One Flew Over the Cuckoo's Nest, and yes, I'm dating myself here, think of the chandelier cell as Nurse Ratched. I mean, that look could kill you. Know, that one glance from her and you'd be carted out in the milk truck. And yet, if you think of the chandelier cells, the repressing cells that keep our brains, like the diagram on the left, we want that most of the time. I'm making a joke about Nurse Ratched. Obviously, these are not malicious cells. These are neurons that need to repress. And so the cells they tend to repress are the pyramidal cells. And when the cat's away, the mice will play, and we get the kind of image that you get on the right. And so when we talk about what ketamine or LSD or some of the other psychedelics, brain enhancers, brain manifestors, soul manifestors are doing, they're inhibiting the inhibitor. They're actually asking Nurse Ratched to go have a cigarette break so they can explore it in the right setting, like in your office. This is wonderful. Eventually, of course, we'll get back to the left diagram where everything is as it should be, and we can go drive and do all the things we need to do, but it's just a little bit lighter. So this is how, when we go to a compounding pharmacy to get ketamine for patients, this is what will pop up. We'll get lozenges or troches. It's not troche, it's troche, which dissolve in 5 minutes. You can get rapidly dissolving tablets. If you're injecting, this is just a note, you'll want a 1 cc syringe. And this is for IM injection, not, of course, not IV. I'd strongly recommend the needle at the bottom, a 1.5 inch 27 gauge. It's wide enough to draw up the ketamine, but narrow enough so that it doesn't hurt too much. And there are different places where you can get, you can find this. Henry Schein, Sunset Pharma, Empower. It's right now there's been quite a backlog, and it's been difficult to find. It's hard for compounding pharmacies to get this too. If you're not using injection, but just using troches and lozenges and sublingual liquid, it won't be much of an issue. Oops. So what has happened to ketamine is, unfortunately, as it gets to be a better and better and more appreciated drug companies want to get in on the action. You can't do it with regular old ketamine. Ketamine is a mixture of two isomers. stereoisomers, and one is called R-ketamine, the other is called S-ketamine. They are like mirror images. So one drug company, Janssen, made Spravato just by patenting S-ketamine. Another drug company is making R-ketamine, or patenting R-ketamine, and that'll be out in a couple of years. So just before we get lost, let's just take a moment to go over terminology. All of this stuff had, of course, to be in Greek. I'm sure they take the Greek medical and naturopathic students and teach them everything in English just to keep them just as confused as we are. But if you break down the word, enantios just means opposite. Mura means part, polymer. Polymers are everything from PVC pipe to nucleic acids like RNA and DNA. So when we talk about RS-ketamine or racemic ketamine, we're talking about the ketamine we're using today, just regular old ketamine that's been around for the last 50 years. Chirality just means hand. People hear that word and dissociate out of panic. I've seen this happen in conferences, just that one word. And all it means is the Greek word for hand. They looked at mirror images of hands and realized this is what we're talking about. Okay, so now you're seated in your office. It's 10 years from now. You are the MAPS endowed chair of psychology at Bastyr. And your first patient is this 64-year-old female with treatment-resistant depression on Zoloft and Wellbutrin. She's failed transcranial magnetic stimulation. She's terrified of electroconvulsive therapy, shock therapy, but she does really poorly when she stops her psych meds. What are your options? All of these are available. You can go back to the 1950s and use an MAOI. They're still useful for certain things. You can see all of the different presently legal and illegal, but soon to be legal compounds are here, including the tryptamines, including LSD. Which would you choose? And the interesting thing is, if you think about it, when she says, I'm on Zoloft and Wellbutrin, which of these will play nice with what I'm taking? You've got one major option because all of the others are serotonergic. Now, the way serotonergic molecules get along with each other would be a week-long conference in and of itself. But the easy way out is to use a glutamate modulator, GABA modulator, which would be ketamine, or in this case, in our case, Spravato as well, ashwagandha. So ketamine is like that kid that plays nice with other kids on the playground. And she wants to know, are you saying that it won't interact with anything? Well, it does a little. It'll interact with benzodiazepines. That's not necessarily a bad thing. We frequently use a low dose of a benzodiazepine before giving someone their first ketamine session in their office because it really chills things out. I'll get into that more later. Lamictal may or may not be an attenuator. If you're concerned, you can just have them take Lamictal in the evening. Lithium and Depakote are both being researched as possible synergistic medications with ketamine. I think you'll hear more about that later today. And then the last thing is not to forget good old grapefruit juice, which is a powerful cytochrome P450 CYP3A4 inhibitor. I think half the drugs in the PDR are modulated by 3A4. So it's not surprising that grapefruit juice would have a powerful effect potentially on ketamine metabolism. Example, we had a young woman who was taking just a lozenge or two and was taking no other medications, and we couldn't figure out why her sessions were just so powerful. They were really unnerving for her. We found out she was on a juice cleanse, and she was drinking a huge glass of grapefruit juice every single morning. We didn't know. Some people actually will use grapefruit juice to get a slightly heightened effect. It takes 4 hours to work, whereas often 24 hours. St. John's wort is another, of course, which modulates the 3A4 system. Okay. We've gone through two huge advantages of ketamine so far. One, it is legal. Two, plays nice with other kids. What are some other advantages? There's no QT prolongation. This is on an EKG finding, but many of our psychiatric medications, and especially the atypical antipsychotics from Seroquel to risperidone and so on, do prolong the QT interval, which of course leads to cardiac instability and arrhythmias. You don't get serotonin syndrome, which you might with multiple other medications. We see this with some frequency in the ER. There's really minimal hypoxia as long as they're otherwise healthy. And despite the fact that they're seemingly unconscious or close to it, it decreases their risk of aspiration instead of increasing it. I mean, it's phenomenal when you think about it. The other thing is dose titration. And Dr. Grande and Others will get into this later on today, but you can go as low as a dose to make a homeopath blush. I mean, it's amazing. You can get by with 2 milligrams, 4 milligrams of dosing up to 1200. Not that I recommend doing 1200 with any regularity, but I do have some patients who are on extraordinarily high doses for pain, and they'll take a massive amount like that every few days. One made a mistake with her dose. She was taking 1800 instead of 1200. This is how forgiving a drug it is. You can make massive mistakes like this and you're still breathing. So one option that we do in our office, for example, is to start off with a very low dose lozenge, maybe 50 or 100 milligrams, that gives them a sense of what it feels like. The equivalent is probably like a martini or a glass of wine, just in terms of intoxication. It doesn't feel like that, but in terms of how functional you are. And they get used to it after over a few minutes. Then we'll give them a low dose, 20 or 30 milligrams IM. And then depending on how they're doing, we'll give them a little bit more. Ketamine, I don't know how better to put this, but ketamine is one of these medications where it's not milligram per kilogram, it's milligram per vibe, it's milligram per where they are. And you really need to feel into the patient to see what's going to, what will work for them. This is where intuition really plays an important role. And you'll find that you get pretty good at it pretty quickly. Another option, so the reason I have a diver here is that it's very much like diving, for those of you who are divers, jumping off the boat and you just work your way down the anchor chain. At 5 feet down, you can stop and check out a school of fish. 10 feet down, you need to clear out an ear that's hurting. 15 feet down, there's some turtles. In other words, it's just an easy way to bring someone into the world of ketamine by the slow descent. There are other techniques. For example, Mark Cornfield and his wife, Susan McBride, they're a psychiatric pair up in Canada, and they will do couples therapy by splitting a trochee. So that's $1.50 each. So each takes 50 milligrams, and then they get into a relational space and then use intranasal puffing or puffers, rather like this atomizer that I show on the top right corner, just to maintain themselves in the same space so that they can relate around certain issues that are coming up. Okay, so back to our patient. She only wants natural substances. Well, what are we going to do? Ketamine was developed by Park Davis in Detroit. Turns out ketamine can be produced by a fungus. Turns out that it may be an antihelminthic. It seems to have the same properties as good old ivermectin, which has received some fame around COVID. But this is still being researched, but it does seem to be a natural product that Park Davis certainly didn't know about back in 1962. Okay, now your patient's beginning to get anxious. Hey, I hear they're using elephant tranquilizers in people now. How does it work? Oi, she had to ask. Let me know if you have any questions. So I have had, in previous lectures, people have come up to me afterwards and said, just seeing this slide gave them a panic attack. It's so complicated, and ketamine is an incredibly complicated medication. Needless to say, this is not what your patient is looking for. And the way we describe it is as a snow globe. That when you use ketamine, it's like shaking up a snow globe. You may or may not remember what happens during the hour or two you were under the effects of ketamine. But afterwards, all the snow will settle down and it'll look the same, but it will be so much lighter. And you'll feel a certain level of joy generally and a release of your anxiety. And it just gives them a sense of where they're headed. Okay, love the snow globe, Doug, but we get drug tested randomly at work. Is this going to get me fired? Possibly, probably not. Looks like when we worry about false positives for phencyclidine, PCP, it tends to be street ketamine that causes this, not pharmaceutical ketamine. Interestingly, you can get a false positive for PCP from several other medications, including Robitussin DM, Benadryl, and even the Wellbutrin that this patient happens to already be on. All right, now she's hitting below the belt. Doc, some of the news reports coming out on ketamine really don't look so good. Are you sure you know what you're doing? So you look at ketamine and you think, okay, this is the press. If it bleeds, it leads, right? Nothing seemed to treat their depression. Then they tried ketamine. That's a leader. I was paralyzed by severe depression. Then came ketamine. Can we stop suicides with ketamine? But then just this month, we've had two articles. The one on the right in the Washington Post, I tried ketamine to treat my depression. It was terrifying. And on the right, a fraught new frontier in telehealth, ketamine. And you can see in the bottom right, your patient doom scrolling the night before he comes to see you about what he's about to endure. And it's important to remember that these are just leading headlines. In fact, if you look a little bit critically at any of these articles, you'll think, why didn't they do this? In fact, a patient of mine wrote about the one on the right by Stephen Petro. I tried ketamine to treat my depression. Why didn't they use music? I can't believe they did this without music. The psychiatrist who was running the sessions seemed to ignore a few options that he might have chosen. Similarly, with a fraught new frontier in telehealth, ketamine is now being provided through telehealth. There are some who feel this is grossly irresponsible. There are some who feel that this is the only way to get this really important medication out to people because they are at true risk of suicide. This is one of those areas where reasonable people can reasonably disagree. And it's good to read past the headlines and delve into the issues that they're discussing and form your own thoughts. So what it feels like when people start to get really anxious on ketamine can be called emergence phenomena, which is the word from the operating room, an old anesthesia term. It was called the ketamine tiger. And I see this particularly in the ER more than in my office because the setting is so awful. Where am I? What is going on? And you can fill in your own four-letter word. This is what it sort of feels like, only without the colors. And you can imagine if the person were feeling calm, this could be lovely. If the person is feeling at all anxious and they feel their body dissolving, it could be terrifying. And so it's up to us to help with that terror. Taming the Ketamine Tiger was written about by Ed Domino, who was the first to study ketamine in the OR in humans. And look at this. This is 50 years old now, this anesthesia article. Look at this last line. The overall incidence of 21% delirium and 17% unpleasant or terrifying dreams in the absence of depressant medication, pre-medication, is quite unacceptable. So this was an issue brought up 50 years ago, and we're still talking about how best to do it. When I say talking about it, there's a divide between those of us who feel comfortable with medicines, those of us who feel comfortable more with psychotherapy. And so those who practice psychotherapy will want to use psychotherapeutic techniques to deal with the freak out. Those of us who use medications, of course, feel very comfortable using these. We're to a certain extent speaking separate languages because of our past experience. You know, it's the old saying, to a pickpocket, the whole world looks like pocket. So it really depends on your experience. But there are good arguments to be made for not either or, but rather and using therapeutic techniques along with low-dose benzodiazepines, for example. This is a picture of the ketamine tiger drawn by a patient, and you can actually see the two enantiomers with S-ketamine right in the front and center. This is Ruben Strayer, who's an ER doc who wrote about 10, 12 years ago about how to tame the ketamine tiger. His choice was midazolam, which is Versed. But what we're trying to do is to get from the roar to the purr. Medications we find useful as Klonopin, if they're accustomed to it, perhaps 0.5 milligram of Ativan 20 minutes before they start with a ketamine. It just takes the edge off. You know, we see anxiety in a patient, and some of these swear words that people used a few minutes ago as simply anxiety that needs to be tended to. This can also be a drug effect. It's worth remembering that ketamine is a distant derivative of PCP, and sometimes you still see those really strange affects. I also want to point out the importance of setting. We're talking about a drug here, but music is incredibly important. There are multiple playlists for ketamine available on Spotify, Apple, Pandora. it's important to have noise canceling headphones, a separate speaker in the room playing the same music, so that when you are playing music for them, they need to pull their headphones off, the music is still there. An eye mask which completely covers and blocks out all light. And then the rest of it is comfort: couch, pillows, blankets, and your very human presence. We'll get into the ethics of touch and handholding later today, but handholding when appropriate, your calming voice, washcloths, more blankets, everything that can make someone feel truly taken care of will be huge. Okay, so back to our patient. We do a quick pre-session blood pressure check, and she's 220/134. What do you do? She's in from out of town, and she's only got today to see you, and it'll be 6 months before she's back, et cetera, et cetera. So you might try some breathing exercises. You think, my gosh, did I miss something? No, her blood pressure was 125/65. What do we do? So there are lots of options as you turn to your armamentarium. By this point, you might want to choose the one on the far right, or you could cancel the session. You reach into your bag and you pull out 4 medications that I keep for issues like this. Nitroglycerin, which will lower her blood pressure in just a few minutes. Nifedipine, make sure it's bite and swallow, not just under the tongue. And then metoprolol tartrate, short-acting, not succinate, and clonidine. And these 4 will dramatically lower someone's blood pressure to a far more reasonable amount. Now, what if the hypertension is mostly just anxiety? Again, you could add 0.5 milligram of Ativan and cut these medications back to just giving them clonidine and metoprolol. And that works very well too. Frequently you're treating both. And you have to think, whose blood pressure are we treating? Because most of us will have a moment when we start to sweat. 180/110, 200/120. We have to be careful that we're treating the patient and not ourselves. Because really, who is likely to have problems with ketamine-induced hypertension? There are 2 case reports in the entire world literature, at least in English, in the past 30 years. One is pulmonary edema, but this woman, it had more to do with the fact that she was coming off barbiturates than anything else. And when they finally got her back on a barbiturate drip, her blood pressure resolved to normal. This one was real. That was 1993. This is 2017. This woman had a procedure done in the ER, and she was given ketamine along with other drugs, did go into pulmonary edema, but this was an incredibly complicated woman who'd had significant amount of attention to her coronary arteries and valve replacements, and she probably wouldn't be the sort of person you'd see in your office without cardiac clearance to begin with. And that's it, those 2 cases. So in someone who's hypertensive, usually we hear, blood pressure goes up 20 or 30 points systolic with ketamine. In someone who's hypertensive and not well controlled, this is just a sample screen. I saw this woman at dawn, 5:54 a.m., blood pressure 157/91. She had horrible back pain. I think I gave her 20 or 30 milligrams of IV ketamine just to see how she did with it in terms of her blood pressure. Look at the times. From 5:54 to 6:06, she goes from 157/91 to 208/119. That is quite a jump. After that, she started to resolve, of course, but she might not be your greatest ketamine patient until she really gets her blood pressure under control. In other words, people who are prone to hypertension will have a much greater response than the average bear. So this is where you have to say, trust in Allah, but tether your camel first, an old Sufi saying. You need to, even if the blood pressure the hypertension wouldn't necessarily be dangerous for them, you need to make your chart look good. It needs to pass the sniff test in case anything goes wrong. Metoprolol and clonidine are an easy way to go. Drop the blood pressure a little bit, add a troche, document that the blood pressure was at a reasonable level, 160/90 before initiating ketamine and also upon discharge. So anyway, in this particular case, we just had to pre-treat each session with clonidine and metoprolol because her blood pressure was normal, except when she came to see us. I'll skip over this case presentation, except to notice a blood pressure of 213/116. So you think, wait, 220/134? 213 over 116, aren't these blood pressures dangerous? Well, check out the weightlifting literature. I know, I didn't know there was weightlifting literature either, but there is. They put arterial lines, brachial artery lines in these weightlifters back in 1985. They routinely got pressures of 320 over 250. One guy got up to 480 over 350. Our blood pressure monitors won't even read that high, but that's what they got. And these people did just fine. And the irony is, of course, that weightlifting is actually fairly good for your cardiovascular system. When I see panic, they think, oh my God, he's going to blow a gasket. We don't have gaskets. We have arterial walls that respond to stress and shear injury month after month, year after year. So would you want her blood pressure to be 220 over 134 for years? Of course not. But you can bring it down gradually, and the transient elevations are not what get us into trouble. Ketamine and seizures, moving on to a separate subject. Blood pressure is huge. It comes up a lot, so I wanted to spend a little time on it. But seizures, this is a fellow who wanted to keep his urine toxicology clean for his parole officer, so refused morphine, accepted ketamine, and then had a brief seizure. And I thought, my God, ketamine should not cause seizures. What happened? Turns out his urine toxicology screen was positive for meth, and it was probably a combination. When you actually look at ketamine and seizures, you will occasionally see case reports and of kids. Let me just bring up the chat. Okay. And yet, if you actually look at what's been studied, if anything, ketamine tends to help seizures quite a lot. It actually suppresses them. So in this particular study, and this goes back to 75, 58% of epileptic discharges without ketamine, 31% with. So it seems to be protective. Sorry, I'm having a little issue with the chat. What about concussion? One sec. You'll often see people who get a concussion playing soccer, playing football, and the concern initially was that traumatic brain injury was a contraindication to using ketamine. In fact, it improves cerebral perfusion pressure, and if anything, it appears to be helpful. Okay, glaucoma, this has been looked at in kids. There was no effect on intraocular pressure below 6 milligrams per kilogram, so it really seems quite safe. Now, a patient will say, my niece was given ketamine and her throat closed up. I don't want it. Well, this is a concern. It's laryngospasm, and in a huge study of multiple cases of laryngospasm, nearly 12,000, only 2 actually needed intubation. So what do we do about this? This is laryngospasm. On the left, you'll see what normal vocal cords look like when we need to intubate someone. It's that upside down V that we're putting a tube through to get to safely secure an endotracheal tube. Laryngospasm looks like a Charlie horse of those 2 muscles. And you'll see this little girl demonstrating what it looks like. We have a little girl because happens to kids 4 times as often as it does to adults. So this is one, if you see this, now let me just back up for a sec. What will it sound like? For most of us, laryngospasm would sound like really intense stridor. But what does it sound like on ketamine? It might be very soft. And you might not even notice it unless you're paying attention. So you do want to pay attention for that much softer sound. Inspiration, not expiration. It's stridor. And this is one option. They frequently see this kind of problem after pulling a tube out of someone or extubating someone. And so this is a reference to this.
Laryngospasm, a common complication after extubation, can be treated by the Larsen maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalid direction. Some degree of jaw thrust may also be applied.
Okay, so that is a useful technique. It doesn't last forever, but it certainly does buy you time while the patient's waking up. And you can continue to do it for as long as you need to, including the jaw thrust. If you go to conferences, and I strongly recommend it where it's experiential, where groups of 30 or 40 people will be doing ketamine under supervision, you will see one or two hypersalivating, and you'll just see a little bit of saliva around their mouth. It's not considered particularly worrisome. You generally do not need suction. There are a couple of medications that can be helpful. We don't use them because it's not really clear they help overall. They take a while to kick in, by which point the salivation is stopped. And then they have their own side effects that need to be continued, that need to be discussed. Ketamine cystitis is popping up in the literature more and more because of ketamine abuse. I put here, we rarely see it in medical practice. That may be partly because patients aren't telling us about it. And it's good to be aware when someone has urinary bladder complaints, get a urinalysis, get the culture. If the culture is negative, it's time to start asking them what they're using. It's thought that in medical practice, we tend to see it early on, usually in the first 2 or 3 weeks of ketamine, or perhaps someone with a prior history of interstitial cystitis. But again, it's UTI symptoms, frequency, urgency, painful hematuria. And it's not really clear if this is largely due to street contaminants or congeners of ketamine, or if it's actually due to the ketamine itself. There are numerous substances and supplements that can help prophylax against this, such as N-acetylcysteine. There are options. Let's talk for a sec about ketamine addiction, because we're seeing more and more of it. Again, I should point out that this is different from ketamine dependence. When someone says, hey, I used to get by with 2 lozenges 3 times a week. Now I'm finding I need 3 or even 4 sometimes. That's just getting accustomed to ketamine, just like you might to a narcotic. The difference is you can just ask the person to take a week or 10 days off from ketamine, and they'll find that after that, they can come back and start using their regular doses again. There's no physical withdrawal from ketamine. That is different from ketamine addiction. I mean, one of our psychiatrists online said out of 3,000 patients she's treated with ketamine, maybe 4 seem to have become addicted. There's a question as to whether the route of administration is important. Lozenges are hard to get addicted to. You can't shoot them up. You can't snort them. You can't put that many in your mouth. Nasal spray is handy, maybe too handy for some people. It's just a spritz here and there. And I've inherited some patients who are doing 6 sprays every hour or 2 through the day. So whether you call that addiction or dependence or whatever, it's a little concerning. And for unclear reasons, we see a lot of this coming out of Southeast Asia and also the UK. So I just want to show you.
We're here making a documentary about ketamine, actually.
This is an English journalist who started to look at ketamine in the UK, and we'll just show a little bit of this.
You know anything about it? You have a lot of things that I've got. Anyways, thanks very much. Documentary done. Ketamine.
Okay, so think about that being your child on this video, and he looks bombed out of his mind, and you think, what a tragedy. But compared to the drugs we have now, like fentanyl, it is something so much more forgiving. And this is something that is a hard one to talk about, because obviously we don't want anyone dependent on anything. We don't want anything abused, and yet you have to look at relative rates of abuse. This is just a couple of minutes of conversation in which he's talking with these people who have masks on, obviously, so not to reveal their identity, but you get a sense of how casual this is for them.
Conscious and unconscious, it transports you to another, literally just like space and time.
So what do you guys have now?
These are 2 different types from 2 different drug dealers, because we were going to a festival tomorrow. We picked up another 6 grams.
I heard something about a spreadsheet.
The fucking spreadsheet. I'm getting out the spreadsheet. So there's about 20 of us going to this festival, and we decided to put a big order in.
So which drugs are you bringing?
So we're bringing pills, mushrooms, acid, TCB.
Would you say that ketamine is one of the staples of any British drug taker's menu?
Yeah, 100%.
I think every generation's kind of got its drug. Like 60s acid, 90s ecstasy. That's kind of become a staple of our generation, especially in the UK. It's just very versatile. I think that's one of the biggest things about it. It can be a party drug, sedative, it can be a very introspective thing.
We love to watch David Attenborough, and I bring this as well. When you have it in your ears, it literally feels like you're underwater. So when you watch like Blue Planet, it feels like you're in the documentary. I could definitely do that. I'll do like a little bump.
Do you think there's a perception in the UK that, as opposed to other drugs, ketamine is quite casual?
Definitely, because it's more of a recent thing. You see less people who have been hooked on it for years. People just think it's not that big of a deal. And you don't get a come down or anything from it. Like, you can do K, and the next day, you're completely fine. I'm now regretting not bringing them more because this is actually really fucking good. It is good.
Okay, so I'm going to stop there in the interest of time, but you get a sense of how casual this is. They just ordered 6 grams for a rave. That's 6,000 milligrams. We're talking about 2 milligrams, 4 milligrams, 100 milligrams. It's just, and of course, the intranasal is probably absorbed at quite a bit higher than the sublingual troche, maybe 40, 50%. So it's a little concerning.
So we're here making a documentary about... Actually, do you know anything about it?
So if you look at what's killing people, even though this film is really disturbing with the casual use of it, ketamine isn't what's killing people. Fentanyl is. And if you look at this data is a little bit dated. This was ending in January 2022. I believe it was 120,000 people died from drug overdoses last year in 2022. And about 3/4 of those were due to fentanyl. I personally know 2 young, wonderful people who were dead within minutes of being given fentanyl, and neither of them knew they were getting fentanyl. So it is frightening, and it's a very difficult calculus to say, gosh, I don't want people abusing any of this stuff. But at least with ketamine, there's a second chance. You wake up the next morning and maybe you're feeling some UTI symptoms, maybe you're developing some physical addiction, but at least you've got time to deal with it. So this is the other side of how forgiving ketamine can be in terms of dose management. And I just wanted to bring this up because we'll be hearing more and more about this over the next few months and years. Interestingly, ketamine has been used for the treatment of addiction. You'll notice that the third author here is Krupitsky, who did a lot of work in the USSR. Which maybe, anyway, but before 1990, of course. And he got phenomenal results. He was using it for alcoholics, and it was inpatient, so it's not quite applicable to what we do. But as opposed to 24% sobriety in the control group, I think he got 76% or 72% in the study group, which was quite impressive. And that's being looked at again. I need to move on now because it's really important to talk about hypoxia. We always use pulse oximetry on every patient because you catch things. Someone might think their asthma is a whole lot better controlled than it is. One woman had no idea she had central sleep apnea. It wasn't obstructive. There was no snorting, no snoring, nothing like that. She would just stop breathing, and her oxygen level fell to 63%. She eventually, did the right thing, got her sleep study, got her CPAP device, came back with her sleep device, or CPAP, and she did just fine on IM ketamine. But you will want a pulse oximeter. They're $25 off Amazon, an oxygen tank, and a face mask. You hardly ever need to use oxygen, but I would have it available just in case. Neuropath changes associated with ketamine. This is the damnably hard field to study. Because when we see alterations in neurocognitive status, it's hard to know how much of it is secondary to abuse. And of course, it's abuse of ketamine. When people don't get the amounts of ketamine they want from us, they'll go to the street. And so everyone's aware that to a certain extent, we're comparing apples and oranges, pharmaceutical ketamine versus street ketamine. But at least what we know so far is that ketamine at low doses appears to be neuroprotective. At really high doses during certain developmental windows, it may be damaging, but there's still much to be discussed about this because so many of the people we see really damaged have primarily used a street form of ketamine that we don't even provide. Okay, so quick review of patient concerns, and then we'll take a couple minutes to go on to Benny's. As I mentioned, it's natural. It's the street version that turns urine toxicology screen positive or PCP. Hypertension usually doesn't go up that much. It will in an uncontrolled hypertensive. It helps treat seizures or may prevent seizures. It certainly doesn't cause them. It's safe in closed head injury, safe with glaucoma. It's a very rare cause of laryngospasm. Don't forget Larson's point right between your jaw and your mastoid. Cat bladder we talked about. Hypersalivation is a non-issue. It does appear to be an increasing drug of abuse because of the casualness of it. Don't forget the emergence phenomena, which you generally don't see it much at low doses, but certainly at higher. Hypoxia, again, if a patient's got an unknown respiratory issue, such as central sleep apnea, if they've got asthma that turns out to be not that well controlled, just be careful. And then the neurodegeneration, I think probably the poster child for this was John Lilly, who took a long time to get clean. In terms of the bennies, and I'm going to go through this really quickly because we're running out of time, but this was a study where they weren't just treating PTSD, they were actually seeing if they could prevent it. These were burn victims, servicemen and women who got burned in Afghanistan, and they used ketamine during the actual operation as one of the anesthetics. Those who got ketamine in the OR had a 27% risk of PTSD. Those who did not get ketamine but were given other anesthetics, 46%. A huge shift, and not that many people had thought about using it prophylactically for PTSD, but it is an option. I stole these from Dr. Jain, who was kind enough, Rakesh Jain, who will be lecturing this afternoon. But if you look at ketamine for suicidal ideation, again, huge drop at day 3. 31% in the ketamine arm were still suicidal, 63% in the treatment arm. So it's really impressive that you can have an effect this quickly. Now, if you look at standard ketamine treatment-resistant depression studies, you'll see a table something like this. And it looks like, gee, by day 1, everything looks a lot better, doesn't it? This is compared on the y-axis, we have the Hamilton depression score. X-axis, of course, is just time. But in our offices, of course, we're not checking at day 1. We're checking it 2 hours, 3 hours out. And if you talk to these people just 2 hours after they come out of their ketamine experience, the depression is already lifting. The depression score drops dramatically. And you'll see this in your office as well. I want to say a word about neuropathic pain. You can use topical cream, combine ketamine with some DMSO and these other constituents that I've listed here in a very penetrating base like Lipoderm Plus. And the effects can be dramatic. I treat one quadriplegic who has screaming neuropathic pain. She gets relief in 10 minutes from this. And she says it works better than 150 of methadone and 4,000 of Neurontin a day. We have another patient who has 7 out of 10 pain in one of his feet every time he steps on it. And he's a very successful man, highly respected. And he was considering suicide because none of the specialists he saw, neurologists, neurosurgeons, podiatrists, could get rid of this pain. And this cream didn't work immediately. It took about 3 days for him to notice an effect. Within 3 weeks, it was down to 1 out of 10. So he has to put it on 2 or 3 times a day. It's, it's not magic. It doesn't last forever, but it does really help when used consistently. The rest of these are acute pain syndromes. I'll just give you an example. I have one nurse post-Lyme. She took a quarter tab, no second dose needed. All of a sudden, she felt that the pain that she always felt from her fibromyalgia and post-Lyme syndrome was no longer on, not like a monkey on her back, but rather across the room. She could have a relationship with the pain. Another lady with complex regional pain syndrome who took a massive amount, 500 milligrams a day before she felt anything, but she got 5 hours of relief from this, and this was huge for her. And I'll end with one last case. This is a fellow, if you've seen The Hurt Locker, the movie, this is a fellow who was a bomb diffuser, and he was blown up in Afghanistan. He was the only survivor. All of the rest of his team were completely killed. He's on multiple drugs, including an intrathecal catheter bathing his spinal cord in morphine 24/7. And he came in agony, PTSD, depression, couldn't be a father to his kids, couldn't be a husband to his wife. He was curled up in a ball most of the time. And he came out of his first ketamine experience, and this was in the ER with a horrible setting, and said, oh my God, it's all gone. My pain is gone. My depression is lifted. And I'd mentioned the Hurt Locker as he went under. He said, Doc, when you said the Hurt Locker, that should have triggered me, and it didn't. And the funny thing is with this guy that he would text me 3 or 4 days after his last ketamine experience saying, hey, Doc, I'm still 000. 000 to him meant no PTSD, no pain, and no depression. Of course, 000 to an ER doc like myself means no blood pressure, no pulse, no respiration. So it's always great to hear from a patient that they're still 000. So with that, we don't need to go into this. I want to leave you with this sense of the snow globe. It is up to us to help our patients experience this. Does it always work? No, but by and large, it can be tremendously helpful for people. And I'm delighted to welcome you all to this field. That's it. If there are any questions that we have time for, I'm delighted to take them.
Well done, Dr. Dansky. Thank you so much for your presentation. We do have a number of questions. We can go ahead and start with one of the questions that came in. Would you mind going a little deeper as to why you use benzos with patients starting your ketamine treatments?
What we have found is that patients become extremely anxious when on their first session. It depends on how you've set it up. Like, we don't have the time to see them for 6 or 8 sessions beforehand. We're seeing them for the first time. So, and we joke with them, we say, look, this is an inherently nerve-wracking experience. You're walking into an office, you're meeting 2 people for the first time, and we're going to drug you. There's nothing particularly comforting in that. And so we use a small dose of benzodiazepine to take the edge off that. It also takes the edge off the ketamine tiger. And not that many people talk about it, but ketamine does have its freak out potential at higher doses. And it's lovely just to spare them that drug effect. I think most of the time when we see anxiety, we presume it has to be psychological. There's plenty of psychological material for them to already deal with. And I don't think we need to add to it by a possible drug effect. But believe me, people feel this is a very hot topic. There are others who quite reasonably feel very differently.
Thank you for sharing. Can you talk a little bit about ketamine's effect on short-term memory loss and how it translates into adverse cognitive effects?
On short-term memory loss, we have not seen any issues. I mean, they may not remember terribly much of what happens in their actual journeys. I suppose, in that video we saw with potential for abuse, it might be an issue when people are on ketamine all the time. But it's a bit of a balance because anxiety also can cause short-term memory block, and so the fact that you're decreasing their anxiety to a certain extent may balance that out. But it's not like ECT, for example, where there's clear weeks of short-term memory loss.
Great, thank you. And then one question I think would definitely pertain to our audience, may not be your wheelhouse, but they do have some questions in regards to NAC pretreatment inhibiting ketamine's response. Do you have any insight on that?
I have not seen that at all. I'd be interested to hear if other people have. Again, inhibiting because of that going down the anchor chain if you do see less in ketamine response, you can just give a bit more ketamine. I mean, it works. If you're giving it IV, it'll kick in 30 seconds. If you're giving it IM, 4 or 5 minutes. So you can always use it as an adjunct.
What a great presentation. Thank you so much, Dr. Dansky. We look forward to Dr. David Mandel taking us through neuropharmacology of ketamine, the bioavailability via different routes of administration, and metabolism implications for drug interactions. Enjoy.
Good morning, folks. I'm Dr. Stephen Mandel. I'm an anesthesiologist. I had gone to graduate school in clinical psychology and stayed really enamored of clinical psychology while I did anesthesia. I was particularly interested in mood disorders. I became kind of an artist with ketamine when we migrated out of the operating room or out of the hospital for doing procedures into outpatient settings, and intubation wasn't always appropriate. So total intravenous anesthesia became very popular. And it usually involved propofol and a drug we're going to talk about a lot today, ketamine, because when I learned in the early zeros that, or mid zeros, that ketamine was amazing for reversing mood and suicidality, I couldn't really believe it. I used ketamine as an anesthetic. It was the most widely used anesthetic in the world for decades. I want you to see the success rate here. I'm not boasting. I just want to contrast it because we're going to talk later about routes of administration. And I think our success rate has to do not with many different factors, but that's a major one. So what is ketamine? Welcome to the ketamine, use of ketamine as a tool in your practice. It's an anesthetic and an analgesic, been around since 1970, approved by the FDA in 1970 as an anesthetic. As I said, in the 90s and early 2000s, it was shown to relieve depression and very prominently suicidality. The original study that put this on the map was Zarates in 2006. It took 28 treatment-resistant people. That's people who had tried everything and were still depressed. It gave them an infusion of ketamine, gave them 0.5 milligram per kilogram over 40 minutes. 71% of those people were relieved of their depression for up to a week. Well, these are people who had not been benefited by anything else. So this was really kind of amazing, really at that time, not credible, but it's certainly because it was double-blind, placebo-controlled, because he was at the NIH, it was in a prestigious journal. People had to pay attention. So people began to look at ketamine for suicide and depression. So pharmacology is how medicines work in the body, how the actual mechanisms occur by which the chemical exerts its effect on our mind, brain, body, spirit. So I've been doing this since 2014, over 19,000 different infusions, over 6,000 different patients with an 83% success rate. Were you able to hear what I was saying when you couldn't see my slides? Okay. Here's what ketamine is. Here is its pharmacology. So we're going to talk about the mechanism of action. Mechanism of action helps us to understand the systems that the drug is activating. It's really useful to understand mechanism of action. It helps you to be more relaxed and comfortable in using your medicine. It helps you to be aware of possible interactions. It helps you to feel comfortable with the medicine, and your comfort does get transmitted to your patient. On the other hand, your understanding of the mechanism of action doesn't affect whether or not the drug works at all. The drug works because the drug works, whether you understand its mechanism or not. It's good to understand it. It's important to realize its effect doesn't depend upon your understanding. Here's the chemical formula. You saw it last presentation. Hasn't changed since. Chirality, you see the hands behind. This is really important because if you picture the molecule as hands, the receptors are like, or can be analogized to gloves. And a left hand will fit into a right glove, but it's not going to stay there very well. All of these drugs exert their effects by stimulating receptors. The better the molecule fits into the site on the receptor, the more tenacious the bond. Remember, these are reversible bonds. So it's a matter of concentration gradient and binding affinity. The more the hand fits into the glove, the longer the receptor is stimulated. Here's a receptor. You can see, are people able to see my cursor?
Yes.
Okay, so these are vesicles. As they migrate to the cell membrane of the presynaptic axon, they merge with the membrane, and the vesicle bursts, and the medicine migrates across the cleft and into the receptors. Here's an axon with 3 different attachment points. Okay, here's a receptor. What it's actually done is sort of open a pore through which calcium can travel. This is the N-methyl D-aspartate receptor, which is the one thought to be most responsible for ketamine stimulation. It also causes AMPA stimulation. We'll get to that in a moment. So you have a cell membrane binding sites, and it's this binding that alters the shape of the pore or receptor so that there can be ion flux, and it's the ion flux that causes the downstream nerve to depolarize and transmit. More on neurotransmission. The GABA inhibitory neuron is stimulated by ketamine. So it's actually inhibiting the inhibitor, potentiating the stimulator, AMPA, which migrates across the cleft and causes downstream activation. You notice over here, BDNF is being evolved. We're going to talk more about BDNF in a few minutes. And BDNF is brain-derived neurotropic factor. Ketamine has just remarkable property of actually stimulating new growth in brains. This is pretty unusual in medicine. We can actually demonstrate in laboratory models depression involutes certain areas of the brain. Ketamine causes new growth in those areas, greater receptor density, new dendrites to form. So these are some of the known mechanisms of action. We've shown you the N-methyl D-aspartate receptor inhibition. And we've seen here AMPA activation as well. Here are some links between ketamine's antidepressant actions and downstream mechanisms which regulate the synaptic plasticity I was just talking about. You see the elaboration of brain-derived neurotropic factor, which starts a cascade, actually resulting in new growth in the brain. There are still other mechanisms, and these mechanisms, of course, are not mutually exclusive. They probably act synchronously. More on BDNF and NMDA stimulation. Here's a default mode network. Dr. Dansky showed this as a ball of yarn. And here it is as a functional MRI scan. It's showing regions in the default mode network. You see the medial prefrontal cortex, precuneus, and the cingulate gyri. The importance of this is that the default mode network is the network that's active when you're not focused, when you're not engaged, when you're not doing an activity. It's probably the site of many of your negative judgments about yourself and about others. It's particularly active in depressed people. And it's the one that's telling them that they're helpless, hopeless, worthless. It's the one that precludes any kind of pleasure. Ketamine quiets the default mode network and it turns down the volume of that constant chatter or radio station in people who suffer from depression's brain that's always denigrating whatever they're doing and their ability to do it well. You see the multiple networks involved or multiple connections within the network. There are a huge number of connections in the default mode network. It's active all the time, but much more active when one is at rest, when one is ruminating, when one is thinking, when one is not actively focused on a task. Ketamine somehow desensitizes patients with trauma in their past to visiting that trauma without being triggered. So they can revisit that trauma. They can work through those past challenges with new or more objective perspectives. Experiences of spirituality and self-discovery also become available. Reflection, realization, and resolution are facilitated. This is particularly true if ketamine is given in conjunction with a guide or therapist. This doesn't automatically happen just because people take the ketamine. They need the ketamine plus the care in order to have a good outcome. So ketamine is a psychedelic. Sometimes people say it's a dissociative and the other psychedelics, if you will, are different. Well, as Dr. Dansky's pointed out, ketamine, which was thought to be synthesized, actually does occur in nature. These other drugs use a different neurotransmitter, most of them serotonin, some of them dopamine, few of them norepinephrine. I'll show you more of that later, but the point is that the impact on the brain, the experience is virtually the same as any of the other drugs called psychedelics or mind revealing. Each drug has special properties. The connoisseurs will tell you that an acid trip is different from an MDMA trip. And I'm not going to argue with them, but there's a core similarity. Routes of administration. I think this is super important. Much of the research suggesting that ketamine isn't living up to its promise in terms of the percentage of people benefit is probably due to inadequate dosing or poor choice of route of administration. Virtually all of the studies on which ketamine effectiveness is based were done using intravenous ketamine. There are many other modes. We chose infusion, IV infusion. However, other practitioners may choose other routes. There are a variety of them. They all have their place in taking care of people. But I really hope that we will respect the differences among them. You may remember from this horrible film that we just saw a clip of that all the people using ketamine nasally had bad outcomes. Dr. Dansky didn't show the part of the film with the horses who were all getting their ketamine intravenously, but they all did very well. So route of comparison, let's talk about bioavailability. IV infusion is 100%. IM injection is 93. Intranasal is very variable, tremendous difference depending on the state of the membrane and the preparation. One of the issues with intranasal is when we use intranasal therapeutically, we're using a liquid which is aerosolized and sprayed. When people use street intranasal, they are virtually always using a powder. That powder probably has some ketamine in it. It may have many other things in it. And you just don't know, and they don't know. And an awful lot of the bad rap that ketamine gets is due from non-ketamine being used as an adulterant of the ketamine. Intranasal, as a spray, is very, very quickly absorbed. Intranasal as a powder is absorbed like a rocket ship. It's probably the most abrupt contrast from 0 to 60 or whatever your metaphor is than there is. It's even more so than IV. Ketamine powder, insufflated, hits like a hammer, like a rocket ship. Sublingual is also very important. And we have also oral. It's important to talk about oral because sublingual, some of it becomes oral. So there's some intranasal. There's been talk of ketamine bladder. There'll be more of it in my talk. One of the things to understand is when you give a gram of medicine or whatever, and I say that only 50% or 20% gets to the brain, that's the route of administration for the bioavailability to the target organ, the whole gram's in the body. The whole gram has to be cleared by the kidneys and in the bladder, particularly if it sits there concentrated in urine against the surface, the lining of the bladder for a long time, it can do quite a bit of damage. Way more damage than, or way more bioactivity, if you will, than occurred in the brain. So we chose IV because we believe that the rate of infusion is super important. The time at altitude. One of the reasons we don't like nasal is the absorption is so abrupt, even with spray, that it's almost distracting. The contrast effect, the oh wow, is so great that people tend to pay more attention to it than the more subtle things that are happening to them. With IV, you set the infusion rate. You can do so with precision. You control it so you control the level of alteration for the duration of the infusion. You can increase it or decrease it as necessary for comfort and efficacy. You can also turn it off immediately if there's a problem. Another advantage of IV is you can reproduce it precisely from session to session. Ketamine tends to work best when it's given in groups of administrations over a period of time. We find, and most of the literature suggests that 2 to 3 weeks, 6 sessions over 2 to 3 weeks seems to produce the best results. Well, if you want to know that you're giving in session 2 what you gave in session 1, or 3 what you gave in 2, IV really eliminates virtually all question about that. Also, people change in their ability to accept and make use of ketamine as you're treating them. So that a patient who got a certain amount of ketamine on the first infusion, on the second infusion, if you gave them the same amount, they'll probably say, how come you didn't give me so much this time? IV really enables you to bump it up in very graduated increments so that next time is as impactful or a little more so than last time. No first pass metabolism with IV infusion. The rate of delivery to the brain is whatever you put in the brain gets to the brain. IM, there's no first pass metabolism, but some of it goes elsewhere. About 93% gets to the brain. How fast it gets there and how steady you can maintain the brain level is highly variable. The rate of absorption can be too rapid or not rapid enough, and it changes with diffusion and with perfusion. Sublingual has no first pass metabolism, it's transmembrane. Approximately 30% gets to the brain. Again, the rate of delivery is uncontrolled, highly variable, and relatively slow. Slow used to be considered a disadvantage, but I'm wondering more and more if the fact that it's gradual over time, in a sense, gives the brain more opportunity to make use of the medicine than these more episodic means of infusions, means of administrations. Oral first pass metabolism is very high. Most of the oral dose gets metabolized into other chemicals. The portion that eventually reaches the brain has a small quantity of ketamine, and it's dwarfed by a large quantity of metabolites. The rate of delivery is uncontrolled, highly variable, and also relatively slow. Intranasal, I think we spoke about this, it's very rapid. So ketamine metabolism in humans, ketamine has a very high rate of clearance, and it's out by 2 to 4 hours. Most studies would say 180 minutes tops. Primarily done in the kidneys. Very little excreted is ketamine or norketamine and dihydroxynorketamine. Most of it. Most of it is conjugated and excreted as the glucuronic acid.
Okay, wonderful. We do have a number of questions in regards to IV infusions. One that's pretty simple and easy is, does insurance cover IV infusion in your experience?
You know, this is a moving target. The answer was definitely no until about 2018. And then it was rarely from 18 to 20. And now it's sometimes, and we've just had several Kaiser patients come to us and say, oh, what do you know? We're being covered now. Now, Kaiser was the most resistant of any that we had dealt with in approving this. I think this is a very important point because there's a lot of talk about ketamine's accessibility and availability and how important it is that we use some route of administration that's cheap or easy. Virtually all of my patients have very good medical insurance. And until recently, almost none of them were reimbursed for their ketamine care. And it's the insurance company says, well, they have all kinds of stories, it's off-label, this and that. But almost a third of all psychiatric medications, psychiatric prescriptions are written for off-label indications, and they are reimbursed. So stuff is going on here. Things are moving our way. We're happy. The answer is most of your patients in most jurisdictions with most companies are not likely to get substantial reimbursement at this time, but stay tuned. This is really a moving target.
That's very helpful. Continuing on with that topic, we do have another question asking about what the typical duration of your IV sessions are and the cost, if you don't mind sharing that information.
That's very important because I think we get better results than in the literature, partly because we are really meticulous about set and setting, partly because we use a 55-minute infusion, not a 40-minute infusion, which you see in the literature, and we dose escalate during infusions. We do assessments and increases in doses during the infusions. We charge $600 an infusion. Our intake process is also charged, and it's $300. So infusions are $600, is a $300 intake. The series is with the intake cost is $3,900.
What a great presentation. Thank you so much, Dr. Mandel. We very much enjoyed learning about neuropharmacology and the insight you shared in regards to the IV ketamine infusion success that you have at your clinic there in LA. We look forward to Dr. Lucinda Grande walking us through the microdosing protocol, the various microdosing applications ranging from pain, depression, palliative care, psychosis, and addiction. I'm pretty excited to also hear Dr. Grande speak on the Oregon Naturopathic prescription data, speaking to the dosing and routes of administration. We also look forward to hearing about diversion and risk management, which I think is definitely an area of interest amongst our audience. Take it away, Dr. Grande.
All right. Well, thank you. We've had a fantastic set of information so far, and I'm hoping everybody is enjoying the presentations. I'm going to be talking about ketamine microdosing and some of the research that I've been doing over the past 10 years or so. And I'm going to talk about the microdosing protocol that I developed a few years ago that summarizes the range of experience that I've had with the 550 or so patients that I've treated using this route of administration and technique. I'm not giving you my own email address only because I want to make sure that if there are questions that come, they don't get lost in the shuffle, because I do get a lot of email, and I want to be able to answer people individually. So please, if you have questions, and reach out to Susie at the email address listed there. And I am considering sharing my slides. I haven't completely decided whether or not to do that yet. Depending on the level of interest, I will consider sharing these slides. So I have collaborated with 3 compounding pharmacies, but I have not had a financial relationship with any of them. My research is all self-funded. All right, so I am going to be talking about some background and clinical research results with 3 projects that I did. I'll talk about microdosing applications, the protocol itself, some adverse effects and events that I've seen among my patients, And also, I recently did an analysis of Oregon prescription data, much of it from naturopathic physicians who've been doing microdosing with ketamine, and I'd love to share that information with you. Next slide, please. So these are a few photos that I think give a little bit of background on the history of ketamine, and I love the picture on the lower right because that basset hound looks like one of my own. Next slide. So I'm going to tell you a little bit about my first ketamine patient. This happened when I was in medical training, and I had an inpatient rotation where I was responsible for patients that were being treated with for pain. And please advance the slide, and I'll tell you a little bit more about this first patient. The results of our work with this patient, I ended up having this published as a case report in the journal Anesthesia and Analgesia, in which I discussed the mechanism of action of ketamine in managing this complex pain patient. I won't be getting into the details of that, but I'll just tell you about the case. Next slide, please. So this patient, as I said, it was my responsibility to take care of pain, and this man was in such excruciating pain that he could do nothing but stare up at the ceiling and not interact with his surroundings at all. He was in such distress. He had cancer pain. He had a metastasis to the spine, and he was already on high-dose opioids previous to the surgery. Then he had surgical removal of that metastasis. And post-operatively, he was just in really, really awful pain that was intolerable. We were pouring hydromorphone Dilaudid into him like water, and it was not doing anything for him. Next slide, please. So this is a graph that shows the amount of hydromorphone in milligrams per hour as a function of post-operative day. And on the first post-operative day, the amount of hydromorphone he required just skyrocketed. We couldn't get enough into him. So in the middle of the night, I went to the library and said, we got to be able to do something other than opioids. And I came upon an article talking about ketamine as a treatment for pain that isn't often used. And I begged my attending physician if he would let me try ketamine for this patient. And it happens that physician, his name is Dr. Greg Terman, who's a neurophysiologist and neuroscientist who knows quite a bit about opioid mechanisms and was quite familiar with ketamine, said, all right, we can do it, but it's got to be a really tiny dose because people have this emergence phenomenon that they get absolutely miserable with ketamine when they come out of surgery if they've been if they're not prepared for it. So he said, okay, let's do 5 milligrams per hour, which was a ridiculously small amount in comparison with what typically people have been using, 1 milligram per kilogram, 2 milligrams per kilogram for anesthesia. So that'd be what, 70 milligrams in one fell swoop. So we were giving 5 milligrams an hour. And as you can see, it was actually within 5 hours that it had a really profound effect. And the amount of hydromorphone that was required immediately dropped during the time that we had the ketamine infusion on. When we reduced the ketamine infusion, the amount of hydromorphone that he required immediately went back up again. But ultimately, over time, we were able to reduce the ketamine infusion, and he was not requiring so much extra opioids. Next slide, please. So this is what he looked like 5 hours after the ketamine infusion started. It's not the same guy, obviously. This guy looks a little bit younger than the guy in the previous picture, so it actually took years off of his life. Next slide, please. So it was years after that experience that I finally was in independent practice and able to start trying ketamine on patients that I was responsible for myself. As you can imagine, I was just blown away by this experience and how powerful this medication was. And I was anxious to do it, but didn't really have that freedom until I went into family practice and was in private practice, able to make decisions about my own treatment for my own patients. So I wanted to implement it in an outpatient setting with something other than an IV infusion, which isn't possible in the ambulatory setting. And I found a review of 22 case series and case reports discussing use of oral ketamine for chronic pain. And this was published in 2010. Next slide, please. Briefly, the key points were that there was no consistent dose-response relationship. A recommended starting dosage in ketamine-naive patients was 0.5 milligrams per kilogram orally. And that's the amount that has been used in the intravenous protocols. But obviously, intravenous, the bioavailability is about 5 times as great. So this is equivalent to like about 1/5 of the bioavailability, 1/5 of the dose that's used for in the infusion protocol. And what they found was for a continuous analgesic effect, it's usually given 3 to 4 times daily. The daily dosage, depending on clinical effect and or adverse effects, is slowly increased. So I wanted to kind of model my treatment strategy after that. But I was a little bit timid, and I didn't want to even give as high a dose as that. I wanted to start with like a really low dose in order to reduce the risk of any possible adverse effects. Next slide, please. So here's my first clinic patient in 2012. And this is a lady, 67-year-old female, who was just absolutely miserable. She had a history of heroin use and unstable housing. She was now stably housed, but she was quite miserable. She had back pain from having degenerative disc disease and several spine surgeries. She had been on high dose opioids, 200 morphine equivalents, and she was overusing her medications, losing her medications. She was irritable, miserable, and she had already been tried on buprenorphine and had not tolerated that. So this was not somebody that was a lot of fun to visit with. And I thought, it's hard to imagine actually causing any harm with this person. It's only possible to benefit her. And maybe if she gets the benefit that I saw in that patient so many years earlier, then this could actually change her life. So I decided to start with a really, really low dose, 2.5 milligrams orally every 3 hours, which was 40 milligrams a day. And I lowered her morphine. She had been on 200 morphine equivalents. I was a little bit nervous about whether she might have a morphine overdose or something. I didn't know what effect it might have on the morphine, so I reduced her morphine by half. And 4 days later, she came back into clinic and she had a bright expression. She was dancing. She showed me this exercise video that she'd started using, and she was raising her arms in the air, swinging her hips and smiling. I just got this from my documentation of my note from way back in 2012. And I remember that moment. It was like, bingo, we've got a solution here that's really a way to make use of this amazing medicine in my outpatient practice. Next slide, please. So I went ahead and offered this treatment to a lot of patients over the course of the next few years. I think I treated about 200 patients by 2015. And I wanted to start compiling this information in a way that was publishable, so that I could share these findings with other people. So I designed a randomized controlled trial, and I would encourage other people to give it a try, but beware that it is a lot of work, and not something that I would take on again very easily. There's just, if you're trying to do primary care practice, it's not very easy to run randomized controlled trials. But anyway, that's what I did. So next slide, please. So I published the abstract of this in the Journal of Pain. It was not the full study, and the results were just somewhat underwhelming. So that's why I didn't take the time to write up the full thing for publication as a full article. Next slide, please. So this study, I designed it with 32 subjects. There were 16 active subjects with receiving ketamine and 16 placebo. And this was oral, which was the first way that I was offering it. They were in capsules. and the people would swallow the capsules. And the first week, it was 16 milligrams twice a day. And the second week, it was 32 milligrams twice a day. And my experience with this had been that people respond so quickly that surely that would be enough time to show an effect. I picked those doses because I wanted to avoid side effects. But unfortunately, as we'll see, it wasn't quite a high enough dose to have the most optimal effect in this particular patient population. Okay, next slide, please. So, I should mention these were all opioid tolerant people in order for them to qualify for the study. So the best result I had was the clinical global impression of being improved or much improved was remarkably favorable to the ketamine group. 63% of people at the end of the 2 weeks said that that they were improved or much improved, and in the placebo group it was only 38%. So that is actually pretty representative of what I see in my patients. Next slide, please. Over the course of the 2 weeks, we did see a reduction in interference with activity, that the pain was not interfering with activity. It was kind of a subtle difference between the ketamine and the placebo group and not statistically significant. Next slide, please. Same with percent pain relief using the brief pain inventory and depression using the PHQ-9. The ketamine group did slightly better than the placebo group, but it was really kind of underwhelming results. Next slide, please. I did a follow-up survey between 2 and 7 months after the end of the study, and I had more than half of the patients that I ended up getting hold of. And 79% of them, the people that were in the placebo group, I offered them to do the actual active ketamine treatment afterwards. That was how I was able to lure people into participating in the study, because nobody really wants to be in a placebo group. So of all the people in both placebo and active groups, 79% of them ended up continuing ketamine by 7 months later. And the average dose in that patient population was 101 milligrams per day. So I had slowly tapered them up from 64 milligrams maximum during the study period up to an average of 101 milligrams. Next slide, please. And among those people that I followed up with, quality of life was markedly improved among the people who had continued the ketamine. Nobody who had discontinued the ketamine that I got a hold of had reported an improvement in their quality of life. The depression was much more likely to improve in the people who continued ketamine, and use of opioids had decreased in 60% of the people who continued the ketamine and only 25% of the people who had not continued the ketamine. Next slide, please. So here is one of the study patients whose experience was fairly representative of the people who did well with ketamine. It's a 62-year-old male. At the time of participating in the study, he had been recently widowed. He was stably employed as a truck mechanic. He had lumbar chronic pain from having had a back surgery with what's known as the post-laminectomy syndrome, also known as failed back surgery syndrome, kind of a derogatory term. So he has continued on 32 milligrams twice daily. This is a comment from one of my more recent visits with him. I just saw him about a month ago. I've been seeing him for that entire time. He's very happy with the ketamine. It improves his quality of life, allows him to use less Vicodin. He decreased his hydrocodone use from 130 morphine equivalents at the start of the study to 35 morphine equivalents now. That was actually, those quotes were from a few years ago, and then even now it's the same, and he's now remarried, and he's just delightful to visit with. He's just very cheerful. Next slide, please. So this is not what people look like when they're on opioids. It's not actually, it's a little bit of an exaggeration of what they look like when they're on ketamine, but it's a little closer to that when you're using ketamine than when you're not. Next slide, please. Because I was kind of discouraged about putting all that work into the randomized controlled trial and not finding information that really reflected my own observations, I thought, why don't I take a look at all the patients that I've already been treating and figure out what doses work for them, what's the rate of basically some measure of success of treatment, and what else can I learn about this patient population? So I did a retrospective analysis. Next slide, please. And I had 390 patients that I included in this, and I split them into two groups, those who continued ketamine and those who didn't continue it. And I classified those as those having been dispensed 3 or more times versus those who had been dispensed only once or twice. And the ones that continued ketamine, I described those as having perceived value because they had to pay for the ketamine themselves. It's not covered by insurance, or at least it wasn't at that time. So in order for them to continue using them, it had to have some monetary value for them, or they wouldn't have been willing to pay for it. And the people who didn't continue it felt that the value that they got from it wasn't enough to be willing to pay for it. Next slide, please. The way I figured out how many times it had been dispensed was I looked at their prescription monitoring program data. And whenever you're writing prescription for controlled substances, you really need to be checking the prescription monitoring program, the state database of prescriptions, so you know where your patients are getting their prescriptions, who they're getting them from, and how frequently, and all that kind of information. So I had this in their charts. So I was able to figure out how many times they'd been dispensed ketamine, and I was able to actually calculate their average daily use based on this also over some period of time. I looked at how many milligrams and over what period of time, so I could calculate milligrams per day. Next slide, please. So at that time, with the 390 patients, most of them I was treating for chronic pain. And there were also some that I was treating for acute pain, such as dental pain, for a very small number specifically for depression, and several other kinds of applications such as anxiety, PTSD, and just a range of other odd things that I thought, well, I wonder if this person's going to respond to ketamine. Next slide, please. So here are the results when broken down into those 4 categories. And these are very strongly statistically significant results that for patients that were prescribed ketamine for chronic pain, 60% of them were perceived the ketamine as having value and were willing to have it dispensed 3 or more times. And only 39% of those who were dispensed, 60% were dispensed 3 or more times compared to 39% who were only dispensed 1 or 2 times. So I would consider that a 60% success rate. And for depression, the numbers were actually even higher, but they were not statistically significant because it was such a small number, only 33 patients. But 67% of those patients perceived value in it. For acute pain, it was the opposite, where 80% were only prescribed it once or twice, or only dispensed it once or twice. And that, I don't really think of that as failure, because the purpose of it was just for acute pain. It was just for a single episode, for such as dental pain, and you wouldn't expect that they would have ongoing use of it. And then for the other purposes, which is a whole range of different things, that didn't consistently result in perceived value. Next slide. So here's some findings that are, I think, are illustrative of the patients who do respond to ketamine. So this is the subset of patients that were being treated primarily for chronic pain. And as many of us know, people who have chronic pain, there's a very strong overlap with depression. And the people, there was very strongly statistically significant success rate among people who had chronic pain who also had depression. 74% of those patients were dispensed ketamine 3 or more times. And also the other statistically significant subgroup were those who were using opioids chronically. And 69% of those people were dispensed 3 or more times. And the reason that that was so statistically significant was that the number was so high at the end of 108. The insomnia group also had a high N, and it was almost statistically significant. And you can see all these numbers are close to statistical significant. So bipolar, PTSD, depression, insomnia, use of buprenorphine, chronic opioid use, and anxiety are all characteristics of patients that tended to do well with ketamine. Next slide. So the average dose in milligrams per day of patients in the chronic pain group who found this treatment helpful or valuable, in other words, they were in the continued group, the average dose was about 90 milligrams overall among everybody on average. The chronic opioid group used a significantly higher average dose of about 120 milligrams. And interestingly, the bipolar patients and people on buprenorphine used a little bit less than the average dose. And I think the way that I would titrate the dose to find the lowest dose that would be effective for the patients. And so I interpret this as meaning that people who have bipolar or were using buprenorphine were more sensitive to ketamine. They just didn't require as much in order to get the benefit. Next slide, please. And this is what they all looked like when they were on ketamine. Keeps people very happy and vigorous. Next slide, please. So here are some applications. Next slide, please. One of the most powerful benefits that I have seen that is just absolutely rewarding when I'm providing this treatment is for suicidal ideation. In primary care, I do from time to time have people come in that have some kind of an awful thing going on in their life that is just pushing them over the edge. And some people are chronically depressed, and this really is a severe exacerbation of it. Some people are actually not normally depressed, but they have a situation that really changes things for them. And the next slide, I'll show you. I had this published 3 of my cases where I used this microdosing of ketamine for suicidal ideation. I've actually treated about 8 or 10 people this way now, and it works just about every single time. It's pretty amazing. It's an extremely low dose that's needed. So this was a 60-year-old male professional. He had chronic mild anxiety. I've known him for years and had never really thought of him as having significant mental health issues, but he had some really bad things happen at work that were very incredibly stressful for him. And he found himself obsessing about suicide. He had no intention of doing it, and he was horrified that things had turned to that point. But this is what he came in. He had slow, monotone speech and slouch posture. I prescribed 16 milligrams sublingual. I had him take it every 1 to 2 hours as needed, and then I also started venlafaxine at the same time. And later on, he told me that after the second dose, which was about 2 hours after the first dose, he noticed a growing sense of calm. And shortly after that, he actually walked back into the clinic, and he had a brisk gait and an upright posture. He was smiling and joking. This is more like his usual self. And he just within, this is 2-3 hours after his first dose of ketamine, he was completely transformed back to his normal state. And he continued using it intermittently over the course of 2 weeks, and his mood improved. He lost the intensity of the suicidality and didn't need the ketamine anymore. After that, he did continue the venlafaxine for a few years and ultimately discontinued that. So this actually, I have seen this pattern over and over again, and it's really, this is 16 milligrams. You do not need to have a high dose infusion in order to get this result. Next slide, please. Another very satisfying use of ketamine microdosing is in palliative care, patients in hospice, patients with cancer. There's an article I found in the Journal of Palliative Medicine that was a review article on how it's being used in palliative care. And they're picking it up much more quickly in palliative care than in, for instance, the pain management literature, and certainly more than in primary care. So this study it was 11 studies, including 5 randomized controlled trials. They were all small, with the largest N of 42. In palliative care, they look at both depression and pain, and they found that there were the strongest effects were the antidepressant effects. They found that for the depression, there were consistently positive results regardless of dosing regimen. And in this group of 11 studies, there was a wide range of dosing regimens, from a range of the low level that I've been talking about in my patients up to much higher intravenous infusions in the hospital. And the most sustained alleviation of depression occurred with a daily dosing regimen. They found that if they would give somebody a single infusion, then it would slowly taper, the benefit would taper off. And this is what people see with the infusions that are given in the common ketamine infusion clinics these days. And with the model that I use, where you give daily dosing of a very small amount, you can maintain alleviation of the symptoms. And that's what they showed in that article. Okay, next slide, please. So here's one of my cases that had a big impact on me. This was really a beautiful, wonderful young woman, 54 years old, married with a professional job, who unfortunately developed metastatic lung cancer. And I was working with her towards the very end of her life. She had chest pain, shortness of breath. And then the most bothersome symptom that she had was this intractable cough that developed right near the very end of her life. And it was so disruptive that she couldn't talk with anybody. She was just, that bothered her more than the pain. And I visited her in the hospital. And at that time, I still had hospital privileges. I don't work in the hospital anymore. But I was able to get her started on intravenous ketamine at a really low dose of 2 milligrams per hour, which is equivalent to 0.03 milligrams per kilogram per hour, in comparison with the traditional IV protocol for depression, which is 0.5 milligrams per kilogram. This is a really exquisitely small dose. And amazingly, it suppressed her cough as well as relieving her pain. And allowed her to be alert and interactive with her family during those last 2 days of her life. It was just really a very powerful impact that had on me, on her, and on her family. I actually saw her husband, who's still a patient of mine, just a few weeks ago. This happened, I don't know, 7 or 8 years ago. And he's now remarried, but I talked with him about what had happened with his wife, and he reminded me that was just the last 2 days of her life, and she never coughed again after that, after she started the ketamine. So he was quite appreciative. Next slide, please. So here's a really interesting one. It is kind of common practice to avoid giving ketamine to people who have psychosis because of the dissociative symptoms and the fact that it could cause somebody to become even more unstable if they were made to have additional psychosis in addition to their baseline psychosis. But with microdosing, if it actually has the opposite effect, at least I've done this now with 4 or 5 patients that have depression with psychotic features. And if it's the depression that's causing the psychosis to be worse, and you treat the depression, then that will reduce the psychotic features. And this is an example of this one guy, 35 years old. He was constantly plagued by derogatory voices that were just telling him he was just an awful person and didn't deserve to live. And I decided I would get him started on really low dose ketamine. I tapered him up slowly starting, I think we probably started at about 8 milligrams once a day and slowly got him up to a total of 100 milligrams in divided doses. And his mood improved and the voices became drastically decreased. They were didn't happen all the time. And when they did happen, they weren't as loud as they had been. So when I saw that with, I don't think he was my first one that I did this with. I've now done this with four or five patients, and it has to be done really carefully starting with a really low dose in order to avoid destabilizing the person, but it seems to work consistently. Next slide, please. So another of the applications that I'm exploring right now is using ketamine to transition people from illicit fentanyl onto buprenorphine for opioid use disorder. Right, as we all know, the fentanyl epidemic is just disastrous with, in last year, I believe it was over 80,000 people in the United States who died from fentanyl overdoses. And it's very difficult for people to get started on buprenorphine, also known as Suboxone. From fentanyl, it's much more challenging because of getting onto Suboxone. It causes people to have precipitated withdrawal that is way more profound than what they experience if they're transitioning from heroin or from prescription opioids. But because of theoretical reasons that it actually makes the opioid receptors more sensitive to opioids so that they're more effective, it ends up causing a reduction in the precipitated opioid withdrawal. This is, I saw an article in the emergency room literature where this was being used, an intravenous ketamine infusion, to help people resolve their precipitated opioid withdrawal. And once I saw that it was effective for that, I thought, oh my goodness, most people who are trying to make this transition are not in the emergency room, they're in the outpatient setting. And I know how to use ketamine in the outpatient setting. And you just use really, really tiny doses. So why don't I try it? And the first 4 patients that I tried actually did quite well. And 2 of them made a successful transition to buprenorphine. The other 2 had really very good relief from their withdrawal symptoms, but for various reasons, they did not complete their transition. And I've treated now another 4 or 5 people since then, and every single one of them has a relief of their withdrawal symptoms. They don't always succeed in their transition, but this is a very challenging problem for these people who have chaotic lives and multiple conflicting demands and strains. So it's not surprising that they don't all make it through the transition, but it's more comfortable for those who it makes it a little bit easier for them to make the transition. Next slide, please. So just an example of the one patient with her precipitated withdrawal, when she took 4 milligrams of buprenorphine, which is a really small dose, it caused severe withdrawal, restlessness, pain in the abdomen, back, and joints, a creepy crawly sensation, furrowed brow, feeling of heavy weight, and she was lying in bed moaning for 18 hours. And I arranged to have the ketamine mailed to her from a compounding pharmacy. And when it arrived, she took the first dose. She took 4 milligrams, which is a quarter of a 16 milligram troche. I thought she would need at least a 16 milligram troche, but they were afraid, she and her mom, and so they just decided to use a quarter of the troche. And that was all it took. And it completely resolved her withdrawal symptoms. And I talked with her on the phone within a few minutes after her dose, and she was very cheerful. She was thinking about other things besides her withdrawal and her transition, thinking that it was like completely different state of mind. Next slide, please. Okay, so then I looked at this is another research retrospective study. I don't know how much time I have here. Probably a few more minutes. Let's a retrospective study of patients. Next slide, please. That were prescribed both ketamine and buprenorphine. As I mentioned earlier, I'm do addiction medicine. I have a lot of patients that I'm treating for opioid use disorder with buprenorphine, and a lot of those patients I also prescribe ketamine and the combination of the two for a variety of different reasons, usually either chronic pain or depression or opioid use disorder or some combination. And so working with a medical student who was interested in this patient population, we looked at 45 patients. I don't have that much time, so I'm going to move on quickly because I want to get to the protocol. Anyway, we found that 55% of the patients who had been prescribed prescription opioids at the start of their use of this combination were off of their prescription opioids. So this was an effective way to get people off of prescription opioids, which is something that a lot of people in primary care are trying to figure out how to do because the prescription opioids have so many adverse effects. And this is one way to do it, this combination. Okay, next slide. Okay, I don't have that much time to tell you about the protocol. I do have that available in a form that it has a narrative that describes 7 pages of kind of a brain dump of my experiences, plus a recommendation for getting people started with the step-by-step instructions. So next slide, please. The starting dose is determined by assigning points based on patient characteristics. You use the total number of points to establish the starting dose, and then you can adjust that dose downward if you're particularly wanting to be cautious, or more aggressively upward if you feel that would be in your patient's best interest. Next slide, please. So briefly, the criteria that are used for determining the dose are age, medical frailty, history of opioid use, history of drug sensitivities, anxiety about the treatment, and severity of pain or depression. So people that are older, 75 or older, may be more sensitive and their dose should be lower. Obviously, people who are medically frail, you want to use a lower dose. People who have an opioid history, you can use a higher dose because that's what they need in order to get a benefit. History of drug sensitivities, use a lower dose. Anxiety, use a lower dose. And severity of pain or depression, use a higher dose. So using those criteria, you add up the points. Next slide. And if the score is 0, meaning they have none of the worrisome features and all of the things that would make you want to use a higher dose, you could start them off at 16 milligrams. And if you're doing syrup, which is what I was doing at the time of I wrote the protocol of sublingual syrup, you would have it made at 32 milligrams per milliliters and start them with 1/2 of a milliliter. And if somebody is very anxious or very or older, medically frail, you might start them as low as 4 milligrams or even 2 milligrams. And that way, anybody that you start at 2 milligrams, they're not going to have any side effects or probably even any positive benefit, but they're certainly not going to have any problem with it. Next slide, please. So then the protocol also specifies dosing frequency. So if somebody has suicidal ideation or severe intractable pain, you want to get them started on it really promptly and just hit them hard with it every 2 hours for suicidal ideation, like that man that I described, up to a maximum of 96 milligrams per day in that first day. Anybody else that doesn't have that kind of a severe urgent problem, you can start them at once or twice daily. I would still not start anybody on that first day up to 96 milligrams per day. That generally is only, that higher dose would only be reserved for the most urgent problems. And then I specify the upward titration schedule, how rapidly you increase the dose. What you do for follow-up, I recommend you have some contact with the patient. If it's an urgent problem, you probably want to talk with them within 24 hours. If it's less urgent, then maybe a week, and definitely see them in clinic within a month. I give people my cell phone and they can call me, or I'll call them if I'm very worried about them. Okay, next slide. And then the narrative. So am I way past my time already? Can somebody tell me how much time I
Dr.
have?
Grande, you have probably about 5 more minutes in your allotted time, but I think this subject is of high interest, so feel free to spill over a little bit and we'll adjust later on in the day.
All right, thank you for providing that input. All right, so in the 7-page narrative where it's a brain dump of my experiences, there's an abstract introduction, information on what to think about when you're starting a new patient, additional background information, risks and side effects, and there's a fair amount of detail in this document about the range of different side effects that I've observed. It's not completely symptom-free, but the side effects in general, I mean, consistently, if people have side effects, they'll go away if they just stop the medicine or reduce the dose. And there's no side effect that I have seen that was a showstopper. I mean, they would stop the medicine and some people just don't want to continue it, but nothing so harmful that it's really certainly not life-threatening. And then there are some references of published information in there, although there's way more stuff that's gotten published since I wrote this back in 2017. Next slide, please. So there's some discussion in there about preparing the patient. Patient selection is absolutely critical. You want to make sure you have somebody who's going to be responsible with this medication, and you have to use your judgment when you see somebody that you're thinking about whether they'd be a good candidate. Some people just don't have the insight to judge what to do with it or to make sense out of, observe their own experience and know whether that means that they should wait a little bit longer before the next dose, or they should increase or reduce their dose. But if the person seems to have enough insight that they can be reliable and sensible about their self-dosing, or they have a caregiver who can, then that's somebody to consider offering this treatment to. Set and setting is a concept that's used in the literature for psychedelic medicine and also for ketamine infusions when you're using at higher dose for like a psycholytic or psychedelic range. But even in the microdosing range, it's really important to prepare the patient's mindset so that they're feeling optimistic about this potential treatment, that they're hopeful, and you want to provide them reassurance that nothing terrible is going to happen. And if you're kind of worried about it yourself or unsure, and you say, well, I don't know, this might work, probably it won't, but we'll just give it a try, then the likelihood of it being successful is lower than if you say, this is something that might really make a big difference for you, and I really think it's worth a try. I can't promise it's going to solve your problems, but it's very low risk. Let's give it a try and see if this will work for you like it has for many other people. But you also have to be really careful not to overpromise. And I said this right during my introduction at the beginning of the day, that you can't tell people something that isn't true. And if you tell them this is definitely going to work for you, don't worry, you're going to feel great tomorrow, then that's going to be a recipe for disaster, because it doesn't always work. In my statistics, it shows 60 to 67% of people actually have a favorable response from it, but there's a bunch of other people who it just doesn't work for them, or they can't tolerate it. They have some kind of a side effect that makes it not worth they don't want to continue working with it. So you want to make sure that they know that it's not FDA approved for this in this formulation or for this indication. It's FDA approved as an anesthetic agent, and it's FDA approved in its intravenous formulation from that vial injected directly. And if you do it as an oral capsule or a sublingual troche or a syrup, that has to be compounded, which is not something you can get at a regular pharmacy. And that's because there's no manufacturer that will make something that doesn't have FDA approval in that formulation. And there's no large randomized controlled trials that show level of effectiveness or long-term safety. I've been treating people now for 10 years. I've had 500 patients, and there's no long-term adverse effects that I have seen. I will tell you about adverse effects, so keep on, let's see the next slide, please. Next slide. One of the most feared adverse effects is bladder pain, because people who have problems with addiction with ketamine, there are some people who use it, have been using it for decades illicitly and have developed an addiction to it. And some people are so addicted to it that they can't stop using it, even though they have terrible bladder pain, and to the point where they've had to have surgical treatment for it. In my experience, I can think of 2 people I know, that I think there was a third also, that had to stop using their ketamine because they developed bladder pain, and it just wasn't worth the benefits that they were getting wasn't worth the pain that they had, so they had to stop. And this is one example, a 38-year-old female nurse. She had a condition called arachnoiditis, which is an inflammation of the lining around the spinal cord, and that happened after spine surgery. She had a history of interstitial cystitis, which is bladder pain that feels like a urine infection, but isn't, and there's no infection. And I had tapered her up to 64 milligrams of ketamine 3 times a day with really good relief of her back pain. But after 5 months, she acutely developed onset of this bladder pain that was very much like her chronic interstitial cystitis. And ultimately, she had to stop taking the ketamine, and she was really disappointed. Ultimately, we gave her buprenorphine, which provided some relief. It wasn't quite as good as the ketamine. And there's another person that developed that was had a similar path, and he had to stop taking it, even though he liked the benefits of the ketamine. Next slide, please. Tolerance does develop, and it happens mostly with people that are on higher doses. And for me, higher doses means 200 or 250 milligrams or higher. I have not seen, what happens at really low doses is there's some degree of tolerance. Somebody starts using 4 milligrams, it doesn't work at 4 milligrams anymore. You go up to 8 milligrams. Eventually they will find a level that works for them, and they can stay on it for years. But this is an example of a guy who had titrated himself, but this was early on, and I allowed him to go up to 750 milligrams a day. And it was amazing for his depression, suicidal depression, and just really horrible chronic arthritis pain. But it stopped working for him completely. He just could not, he would take it, he would get a benefit for like a half an hour, and then his pain and depression would be just as bad as before after a half an hour. And ultimately he had to stop the ketamine. And that was really, really sad. Next slide, please. So here's another guy that developed tolerance, but he actually developed a pattern where he would take a ketamine vacation. So he would use it for several months, and it would work really well for his depression. And then it would lose its effectiveness, and he would need to take a vacation for a few weeks where he wouldn't take it at all. And it was really uncomfortable for him because he was really depressed during that time. But he knew if he would just stick it out, that he could get back on the ketamine and everything would be fine. And he's been doing this pattern for several years now. And it just, so development of tolerance does not necessarily mean they're not ever going to be able to use ketamine again. But I use it to advise people to keep their dose as low as they can possibly tolerate, because if you push it too high, then you may develop this ketamine tolerance and you lose the benefit of the medicine. I can't guarantee you're going to have results like this guy did, where you can keep on using it anyway. Next slide. And then there's an example of, here's a guy who was on really high dose. He's on 400 milligrams a day, and he's been on that level for 7 years. That's kind of unusual, but he's 400 pounds. He's got really severe arthritis pain and suicidal depression. I think the weight has something to do with it. I've only had a couple people that are really morbidly obese that seem to, that the weight actually seems to influence their dosing. They need a higher dose just because of the drug distribution in their body. Okay, next slide, please. Activating adverse effects of other medications. Okay, the guy that had the depression with psychotic features, he was also on an antipsychotic and developed dystonic reactions he'd had those before he started the ketamine related to the antipsychotic. But when he started the ketamine and he'd been on it for a little while, those dystonic reactions got way out of control. And it was really scary. I thought, well, the ketamine is causing these jerking movements and seizure-like episodes. But we determined, he said, well, this is just what he had before, it's just worse. So we went up on his benztropine, which is a medicine that's used for dampening dystonic reactions from antipsychotics. And I reduced his paliperidone, the antipsychotic, way down to a much lower dose. And that combination seems to be working, and he gets the benefit of the ketamine without those reactions. So if you have somebody that you're treating with ketamine and they develop some weird kind of a reaction, it could be something unique to them, but it also could be that there's another medication that they're on that it's activating the side effects of that. Next slide, please. Okay, and that's particularly important with opioids because opioids will cause drowsiness or sedation. And if you're taking ketamine, you don't need as much of the opioid. And if you don't lower the opioid dose, then you can get sedated. I have not seen anybody reach a point of respiratory depression, which is what I was really worried about at first. And it has not been an issue, but maybe it's because I tell people to make sure that they don't take their opioid. If they're feeling sedated, it's not the ketamine that's doing it, it's the opioid. So continue the ketamine, reduce your opioid dose. And that is the best way to deal with the sedation. Next slide, please. Okay, so then there's this issue of biliary dyskinesia or sphincter of Oddi spasm, which was mentioned earlier in the day today. And I've seen this a few times where people that were on a relatively high dose for a prolonged period, and they also had a predisposing gastrointestinal condition. And one person had a partial colectomy and the other one had achalasia, which is a phenomenon of the esophagus that's a kind of like a hardening and straightening of the esophagus. And those are the two people that had this really profound right upper quadrant pain that when one person had to stop her ketamine completely, or she chose to stop it. The other one couldn't stop it because she had such terrible migraine, and this was the only thing that would help. So she lowered her ketamine dose and reached a happy medium where she had some of the right upper quadrant pain, but also had relief of her migraine. Next slide, please. Oh yeah, so this one is somebody has an underlying disease that wasn't evident until they got onto the ketamine. In this case, there were two men, and this happened within a course of a few months, that were both in their 70s that were on ketamine, and they felt great, and they went out and started exercising. They hadn't been exercising for years. And suddenly they had chest pain when they were out walking, and it was like, oh my God, is the ketamine causing a heart attack? But they had ended up having angiography that found that they had almost complete blockage of the left anterior descending artery in the heart and had stents. And this happened to two guys, both in their 70s, within a few months of each other. And I almost quit using ketamine at that time completely because I was so terrified that I was killing people. But ultimately realized that you just got to be watching for things like this and thinking about what else might it be besides the ketamine. And it was just that they were active and they hadn't been active before, and activated this, became the underlying thing, became unmasked. Okay, next slide. Other things, hyperglycemia. If somebody has diabetes, they can develop hyperglycemia, so watch that. You don't have to stop the ketamine. You can, you might have to stop the ketamine in some cases, but sometimes it can be managed. Go up on their insulin, go down on the ketamine, something like that. Hypomania with bipolar, that can happen, and watch for that. You might want to have the person on a mood stabilizer in advance if they're very volatile with their bipolar. People liking ketamine too much, that can be known as addiction. It's not something that I've seen a lot of, but yes, it does happen, and you need to watch for that. And if you see somebody asking for early refills or losing their ketamine or dropping, if you have syrup and they spill the syrup accidentally, and that happens too many times, it's like, maybe this isn't the right medicine for them, or they need to be using a lower amount or monitored really closely. Psychosis, that's a very rare occurrence. If somebody uses too much in a very short period of time. I had 2 guys that did that. They both had a history of addiction to other medicines, and they couldn't figure out when to stop using it. And they used like a whole 2-week supply in 2 days, and they just went bonkers. And that was disturbing. And you have to, kind of use your judgment about how closely to monitor somebody like that. Confusion in elderly people, yes, that can happen. If people have a low reserve for cognitive impairment, and they have ketamine can really put them over the edge and make them have really severe cognitive impairment. So somebody like that maybe could tolerate 2 milligrams, but not 8 milligrams. So you gotta, don't give up on the ketamine, just really think carefully about how you're using it. I've seen withdrawal symptoms a couple of times, very, very rare. And diversion, I was supposed to talk about that in this presentation. Honestly, I have not seen it, and it's possible it's happening, but my patients really value this medicine and they're not particularly wanting to share it or give it away. And it's possible that's happening, but it's not been a major issue for me. Okay, next slide. Oh, idiopathic reactions, all kinds of little weird things that you can't predict. Facial flushing, itching, headache. One lady had a crazy personality change. And all of them, if you stop the ketamine, all those things go away. Muscle pain due to increased activity, that happens all the time. U-shaped pain curve, where if they get pain relief when they increase the dose to a certain level, but if they increase the dose further, the pain actually can get worse. So you have to then reduce your dose. And denial of the benefit. Sometimes people get better, but they don't recognize it. They say, well, I just felt like getting out and doing stuff, and it had nothing to do with the ketamine. And that's kind of interesting. It happens fairly often. Next slide, please. Okay, so if things happen like that, be on the lookout, think critically, but don't be discouraged. You don't have to give up giving ketamine even to that specific person. You just have to think about whether you need to lower the dose or watch the person more closely, guide them more carefully, or maybe discontinue. And there's so many people that can benefit that you need to really think about. Don't give up on all the other people because this one person had an undesirable effect. Okay, I'm almost done here. I better stop. I could go on for a lot longer. Next slide. Next slide. Yeah, the compounding pharmacy data. All right, I'm just going to keep on going here. We may not get to have lunch, I'm sorry, but next slide, please. So I got data from a local compounding pharmacy that I've been doing some work with. And it represented all their prescriptions of ketamine from 2018 to 2022 from Oregon and Washington. It was a total of 8,000 prescriptions from 145 different prescribers. Next slide. This is probably the most important research that I've done, actually. And naturopathic physicians represented 47 of the prescribers in Oregon, representing 2,500 of the prescriptions. So this is a group of a group of prescribers, and that's you guys who are listening, that are able to use this medicine and have found it very useful for their patients. Okay, next slide. The specialties were broad range: anesthesiology, family medicine, internal medicine, pain medicine. Noticeably, there's no psychiatrists in this group. I just think that's fascinating, that depression, those are the ones whose patients can have the most benefit from it, and yet they're not using it. Next slide, please. Route of administration, most of them are using prescribing it sublingually. There's a fair amount prescribing it nasally, oral, and then one person prescribed it per rectum for, I'm sure that there was a good reason for that. Next slide, please. Okay, so this is really important. I broke it down by dosing, and the people in Oregon that I looked at, the prescribers in Oregon, are being very cautious, and you can see that the majority of them are prescribing it at less than 50 milligrams per day. and certainly less than 100 milligrams per day. And I compared it with myself. I'm in this database and I'm prescriber number 53. I'm like way more than anybody else in this database. And so I could tell because prescriber number 53, and my distribution was broader, and I have people in all different dose ranges. So that is, I think the people in Oregon, next slide, and you'll see whether the implications of that are, oh, next slide, this isn't that interesting. So this is the thing, I looked at that perceived value measure where people who have been dispensed 3 or more times, and my success rate based using that measure was about 60% in this population from this pharmacy. And the people in Oregon who were prescribing it did not have as high a success rate. And there's a lot of reasons for that. I don't know what they are, but I think one of them may be that people are being a little too cautious and not treading carefully. They're treading very carefully above the 100 milligram level. So next slide. So these are the things that I've learned, and I want to explore more. I think I need to interview the prescribers and see if I can understand how are they using it, what kind of challenges are they having. I want to find out, are they being cautious at the higher doses and why, and maybe educate people about how to get the most benefit out of this treatment. For example, I'm thinking about offering a monthly case conference series to hear people talk about their cases and talk through them, see if we can figure out how to help them do a better job. And maybe I'll be writing some short articles on various topics. And I would love to have people reach out to me and let me know if you're interested in participating in one of these things. If you want to learn more, if you want to work with me on this, I'd really like to help. I think it's such an amazing treatment. You need to be aware of the challenges with it and be very careful, but there's huge potential. And I'd like to help people along and get this treatment out to more patients. So thank you very much.
Thank you so much, Dr. Grande. It's always a pleasure to learn from you. We very much enjoyed learning about your microdosing protocol and the specific applications that you've had great success with. I also found it very intriguing, your new application in regards to addiction. I think there's much more exciting news to come on that front as well. Thank you for also doing a deep dive in regards to the Oregon Naturopathic prescription data. I'm sure that was very intriguing for our audience. We look forward to Dr. Hilary Sandell walking us through the application of microdosing within her naturopathic practice. She will also be touching on ketamine's effects on hormones and stress response and speak to her microdosing titration approach and also talk about reducing risk and addiction in your practice. Thank you so much, Dr. Sandell. We look forward to hearing what you have to share with us this afternoon.
Okay. Hello, everyone. I'm Dr. Sandell. I'm a naturopath and an acupuncturist. I'm currently practicing in Beaverton, Oregon. And today I'm going to be discussing microdosing ketamine in a clinical naturopathic practice. All right, so our discussion topics today include microdosing titrations and routes of administration, reducing risk of addiction, abuse, misuse, and ketamine's effect on hormones and the stress response. There's a lot to cover in less than an hour. And if I'm being honest, this presentation is over an hour of content. So I'm really going to try not to rush through it too quickly, but you guys have the presentation. So hopefully you can reference that. A little bit about myself. I have a functional medicine and naturopathic practice with a focus on digestive disorders, endocrine imbalances, and mental health. I've been working with ketamine for about 3 years, exclusively with microdosing, and I prescribed for about 100 patients in that time. Ketamine microdosing has been a really valuable tool in my practice, and the goal of this lecture is for you to be able to walk away feeling comfortable prescribing microdosing in a safe, intentional way with the idea of which patients might actually benefit from this tool. So I'm excited to share with you my clinical experience. So a microdose is a very low subperceptual dose of a psychedelic substance. So there should be no dissociative changes or cognitive changes when you take a microdose. The goal in this case is not to feel it. Some patients will feel a body sensation or a relaxation effect, and some patients feel nothing. I thought this was a little fun Google Trend search of microdosing over the last 5 years. You can see the line is moving upward with Oregon at the top of the list of interested individuals. So if you are in Oregon, you might just be in the right place to add this to your practice. Microdosing has some unique benefits over macrodosing. It allows for the treatment of acute symptoms. So it's available as needed for acute anxiety, pain, or suicidal ideation. It's affordable for patients. It's convenient, easy tool for patients to use in the safety of their own home. Still creates benefits on the brain without that psychedelic experience. Additionally, microdosing allows the patients to interact with the psychedelic substances in a way that feels a little bit more safe, especially if they're overwhelmed by the idea of that psychedelic experience. So let's start by discussing the routes and microdosing titrations. Before we jump into microdoses, here's a quick review on the dose equivalents. So as you can see, the IV is our gold standard for bioavailability and effect. The dose equivalents at 0.5 to 1 milligram per kilogram are above that microdose range, but the bioavailability and the peak effect are still going to be relevant and helpful for when you're for microdosing purposes. So I took that information, I created a little cheat sheet here for you with the microdosing routes and their bioavailability, onset, microdosing range, plus a few advantages and disadvantages. This chart is in order of most bioavailable to least, and then fastest onset to slowest onset. We'll go into these in a little bit more detail each here. So the nasal spray is going to be 50, the microdose range is 50 milligrams, about 50 milligrams. The nasal spray is the most bioavailable and the fastest onset of the microdose routes. It's great for acute symptoms, but it can also burn. I would talk to your pharmacy about this. It's possible they can change the acidity to reduce some of the burning, but I've had a lot of patients complain or basically just not use the nasal spray because of the burning effect. Also, the effects are a little bit shorter lived. So I would argue that there are better forms of microdosing for the treatments of depression and pain. Additionally, it can crystallize and needs to be shaken well. So this is my typical instruction for the nasal spray titration. At a 25 milligram per milliliter solution, you're going to start with one spray in one nostril, wait 10 minutes, and then try additional sprays every 10 minutes until they reach that desired effect. Resolution of panic, reduction of acute pain, suicidal ideation, or whatever symptom you're trying to address. The max dose in this case for that first round is going to be 12 sprays of the 25 milligram per milliliter solution. I like to start with 25 milligram per milliliter just to see how they're going to respond to it. You really just never know how a patient's gonna feel. So each spray is going to equate to 1/10 of the concentration dose, which means that one spray of the 25 milligram per milliliter is 2.5 milligrams. At the 25 milligram per milliliter dose, 12 sprays a day is going to get you 30 milligrams. So if someone's going to use the entire allotted sprays, they're going to be still under that microdose range. So if you needed to increase or do additional sprays, that's okay. But I personally like to check in and see how they're responding before I'm allowing higher doses. Lastly, if they're taking it during the day, you really want to warn patients about being in a safe place. You don't want them to be driving or doing something that could be dangerous. An important note, if you're prescribing a nasal spray for acute symptoms, you need to be prepared that they may end up going above that microdose range on occasion to address the acute symptoms. So for patients that I've used, I've treated with like suicidal ideation, for example, in acute states, the dose may also cause some dissociative effect in order to kind of resolve their symptom. This is obviously a cost-benefit analysis in these situations, and having this as a tool is really valuable for someone who's dealing with those symptoms. Obviously, you're also going to be wanting to address other layers like the trauma that's contributing to the state of mind, and we'll get more into that a little bit later. Another disclaimer about the nasal spray. As mentioned kind of in previous lectures, I know providers who don't feel comfortable using the nasal spray because they are concerned about the risk of abuse and addiction because it's faster onset and it's more bioavailable. It is potentially easier to abuse. I can't say with certainty that nasal spray has a higher rate of abuse, but I will say that most cases I've heard of clinically do involve a nasal spray. So including a case of mine that I'll touch on later. So for all the sublingual forms, they're going to be the same in terms of bioavailability and peak onset. Although the rapidly dissolving tablets may be a slightly faster onset. These are new to the pharmacy I'm working with, so I admit I don't have a lot of experience with them. But basically, like I said, the sublinguals all have that 96 milligram range for microdosing, 25 to 45% bioavailable, and peak onset within 30 minutes. The tablets are really convenient and they tolerate heat well. They can also be split into quarters for easy titration or divided doses throughout the day. However, these are going to absorb humidity and they can disintegrate, so that's just something to take into consideration. These will be dissolved sublingually and not chewed or swallowed. So if they are chewed or swallowed, it's going to result in potentially digestive absorption, which is going to be the least bioavailable. So we want to remind our patients that it's going to be a sublingual onset. Starting titration about 16 milligrams or 32 milligrams, and then you're going to increase by a fourth a tab nightly until reaching a steady state. I'm going to get more into titration in a bit. The sublingual troches, again, similar profile. In this case, they're going to melt more easily and tolerate humidity, so they're kind of the opposite in terms of the tablet. One thing to note, I put this in front of the sublingual solution because my patients report that it is a faster onset than the solution, but that's not really indicated in this chart. So just a side note. Sublingual solution. So this is same in terms of the info. This is my preferred method of titration because I feel like it's nice to have a little bit more control. I work with a lot of patients with complex illness. So often my patients with mold illness or chronic infections tend to be way more sensitive and need much lower doses. So this allows for small alterations in dose to accommodate that hypersensitive system. Additionally, it's the most cost effective, especially when titrating. The disadvantage is that as they titrate, the liquid can become excessive in their like sublingually. So I tend to increase the concentration halfway through as they titrate. Instructions for the solution. So you're holding on your tongue for 90 plus seconds. There will be some additional absorption when swallowed, but it's not always necessary to swallow. So if someone has GI upset from this, for any form of ketamine, you can just have them spit out the solution after they've held it under the tongue, which I've seen work well. And it's a solution. Obviously, they won't get that digestive absorption as well, but again, that you'll just kind of base their the bioavailability off of what they're and the dose dependent, obviously, of what they've been able to tolerate. So my titration is 1/4 ml, so that's 4 milligrams nightly, increased by 1/4 ml nightly as tolerated to a steady state of ease or until they achieve have side effects. The max dose on this is going to be the 6 mLs daily, and that's 96 milligrams. It's also important to shake this before use. The rectal suppositories are also a 96 milligram range. Bioavailability is the same. Peak onset can be a little bit longer. This is likely affected by bowel function and absorption in the gut. This can't really be titrated, so you can't split the suppository up. You just have to use the one dose and insert it rectally. So yeah, I don't think your patients will really appreciate it here trying to titrate them on rectal suppositories. But because of the digestive function, it tends to be more unpredictable. So you may, you have to try it out to see how people respond. People with constipation may not be the best candidates for something like rectal suppositories. However, I think it's probably a great application in palliative care and also possibly for ketamine-assisted psychotherapy, because then you don't have to hold the troches under your tongue, which can become cumbersome for people. Oral capsules. So this is our least bioavailable and our longest onset. Microdose range is about 200 in this case, up to 200. And the peak onset is 1 to 2 hours, which I feel like is a pretty large range. So again, it's not as predictable, kind of similar to the rectal suppositories. It is the most shelf stable. You don't have to worry about heat, humidity, refrigeration. But again, the absorption of your patient's ability to absorb may affect kind of how well this is going to be tolerated or how well it's going to improve symptoms. So let's see. I haven't used the oral capsules personally, so I don't really have a ton of experience. What I will say is my experience on it. I've inherited a few patients that were on oral ketamine for pain management, and I actually changed them over to sublingual dosing for that. And it was a pretty significant improvement in their pain. One of my chronic pain patients actually felt like the sublingual dosing lasted longer for her, and it was more effective for her pain management. So she was able to wake up in the morning without pain versus the oral capsules every morning. She just felt pretty bad. So that was really nice to kind of see the length of time that the sublingual actually seems to be longer than oral. I didn't include in any of this, I didn't include kind of how long these last because I couldn't really find absolute information on that. But the nasal spray is going to be shorter and versus the sublingual. And it seems like the oral is also shorter, but it doesn't really make sense. You'd think it would be a little bit longer, but I think that may depend on digestive absorbability. Okay. So this is a chart dosing based on condition. I would say this is kind of general guideline. So how frequently you're going to dose something based on what they present with. I admit I typically always start with 1 dose at night, and then I add additional doses as needed for anxiety, pain, or other acute symptoms. But I find that a lot of my patients with anxiety as their main complaint, for example, will find significant relief with just that single dose. Otherwise, I'll add, I'll divide doses or I'll add a dose as needed in the morning or something like that. Divided doses are probably more relevant for the suicidal ideation and pain management. So if you're seeing that a lot in your practice, just something to consider. Yeah, in these cases, I might have the patient add an additional dose in the morning, and usually I'm doing about 1/4 of the high dose that they're taking, assuming it's still within that microdose range. If not, I might split that dose up to 1/4 in the morning and 3/4 at night to kind of see if we can get full benefit from that. Typically, I find for the nighttime bolus is tolerated well and without any type of sensation or drowsiness or perceptual changes. But when adding the doses, always remember, daytime doses, you really want to advise them to make sure they're in a safe place to test it out. You have to kind of be flexible with this medicine. Like it's really not a one-size-fits-all dosing, and there isn't really a standard of care protocol. So, I just want to advise, don't be afraid to try something different if a patient has a unique presentation. Some dosing considerations. More ketamine is more bitter. So some people complain like as the dose gets higher, it becomes more bitter. Obviously they'll tolerate it if they can, but in some cases, you might try to find a different form. Patients with a history, so the tolerance, let's start with this. Patients can build tolerance over time. So I like to start with the lowest effective dose. If I have to increase over time, I'll do that. But if we're getting to a point where it's not really, they have to increase regularly, it's just, again, probably not the medication for them. Just because I'm, again, trying to reduce the risk of abuse or potential for addiction. When you combine forms of ketamine, so if you're using a sublingual and a nasal spray, ideally you're still within that microdose range. Obviously, it depends on the individual. And my next point being that some individuals are going to tolerate higher than that 96 milligram dose without any psychoactive effect. So it would still be considered a microdose for them. a lot of times it's patients with opiate use history. I mean, that can be, they were using opiates 10 years ago, 5 years ago, currently. They tend to need higher doses of ketamine. Let's see. You also may need to adjust the dose if patient is tapering off an SSRI, so that's something to note. And low doses of low-dose naltrexone should be titrated prior to ketamine. I use a lot of low-dose naltrexone in my practice. A lot of you probably do as well. It can augment the ketamine, and so I recommend adding it first, and then you may end up having lower doses of ketamine in that regard. If you do it the other way around, you may end up needing to lower the ketamine dose, or they may have a poor reaction to it. So I just do it first. You can also separate the dose by a few hours, and that should help as well. Different forms have different shelf lives. FDA, according to FDA, once the substance is mixed with liquid, it expires in 30 days. So anything that's a liquid, the nasal spray and the sublingual solution are considered a 30-day expiration. I would say that you can increase the shelf life by refrigerating it. And then the 180 days is anything solid. Other titration notes. Don't combine with medications unless they talk to you. You know, they need to tell you what they're taking and make sure that you're on the same page. Don't want them to combine with alcohol or other drugs, and remind them not to take prior to driving or operating machinery when titrating. I mean, again, you really don't know how they're going to act. You don't want to put them in a dangerous situation. Here are my titration instructions. So when I learned microdosing, the titration I learned felt a little bit too fast for me. So I modified my titration in order to kind of fit my comfort level. And this is kind of the result of that. So the sublingual solution, again, I'll just repeat it, starting at 1/4 ml, that's 4 milligrams, increasing by 1/4 ml nightly as tolerated until they hit that steady state of ease or until a side effect occurs. That max dose is 6 milligrams per day, milliliters, excuse me, per day at 96 milligrams. Advise them to stop when they feel a side effect the morning after, like drowsiness the morning after, or nausea or hallucinations. So, you know, my titration instructions are meant to keep people from feeling a psychoactive effect. I really want to keep it in a microdose range. That is the goal. So, you know, you just remember that when you're explaining to patients, like, how are we, you know, communicating the goal of this treatment. You may need to increase the concentration while titrating. So, you know, the multiple syringes can become very cumbersome. So I will, I'll often, you know, have them come in 3 weeks into the titration, and then we'll modify that dose depending on where they are. You really need to make sure to communicate that to your patients, that the dose change, you know, that you change their dose, and then what that new amount that they're going to take is, right? So if they came in, they were taking 3 milliliters of that 16 milligram per milliliter solution. Now they're going to take 1 milliliter of a 48 milligram per milliliter solution. I can't emphasize this enough. And at the same time, the amount of times I've had this conversation, I've still had people get that new bottle and take 3 mLs. So, you know, I'm working with the pharmacy on kind of figuring out a good way to basically help the patient realize that their dose has changed, maybe a red note that says dose change or whatever, so that they're not aware, or they're not just becoming, you know, complacent and like, okay, now I'm doing 3 milliliters and now I'm doing, you know, so just something to note. Okay. At that point, I will add additional doses in the morning or afternoon as needed for the anxiety management or other acute symptoms. But again, I try to wait and see if some of those symptoms will resolve with just the bolus dose at night. And a lot of times it will. Excuse me. Once the dose is established, you're going to just increase the concentration to a 1 ml per day dose, and then they will, you know, they'll use that ongoing, whatever that is, either in divided doses or all at once, or you can change to a troche or a tablet per, you know, 1 per day. Okay. some final notes on microdosing, titration, and routes. Every patient is unique in what dose they're going to benefit from. Based on my clinical practice, about 25% of patients don't respond or have negative side effects, which is more rare. Those side effects can be like fatigue or extreme emotional liability, stomach pain, and nausea, even at really low doses, and occasional the urinary frequency or nocturia. Usually lowering the dose will resolve that, but you know, I've had some patients discontinue because of some of these symptoms. So yeah, find a process that works for you and modify it. We're going to jump into reducing risk of misuse, abuse, and addiction. Ketamine is a great medication if used safely, but it doesn't come without risk. So if you do plan on adding this in your practice, I think it's important for you to set yourself up and your patients up for success. Here's a reminder of where ketamine lives in that controlled substance schedule. It's a Schedule 3N. It lives in this category with other medications like testosterone, for example. A Schedule 3 drug is defined as having a potential for abuse less than substances in Schedule 1 or 2, and abuse may lead to moderate or low physical dependence or high psychological dependence. I really like this graph. I think it really helps to illustrate the addictive potential of ketamine, especially in comparison to other psychoactive drugs. I think it gives a nice visual for the abuse potential. It's there, but it's much less likely than other substances. A few quick notes on abuse and addiction. So a majority of abuse addiction cases are not in medically supervised settings. I think I like this study headline because I think it sums it up pretty well. The focus on tolerance and ketamine's antidepressant response and the development on ketamine addiction, right? So I think that the point here is that as you develop tolerance, increase the dose, develop tolerance, increase the dose, that's what really ends up creating this addictive potential and, you know, an abuse potential. So often cases of addiction and abuse are seen in recreational use with really frequent and high doses, or in self-medicated situations rather than under the care of a provider. In these cases, tolerance builds up to individuals, like they can be on doses of upwards of 1,000 milligrams a day in order to achieve that same effect that they originally had. So, and then these two articles I listed here actually were both published this year. So the reality of ketamine addiction and abuse is something to take note of. You know, the second one isn't really correlated to our clinical practices, but the first one does talk about that telehealth, telehealth ketamine clinics that are basically just sending ketamine to patients. I wouldn't personally do that, and I'll talk about ways that I try to reduce abuse. And for that reason, I think a full integrated plan is important, but we'll get into that in a minute here. As just a side note, I think naturopathic providers actually can help people keep people safe and with an appropriate medical monitoring. We actually see patients more frequently. We spend more time with them. We develop strong relationships with them. So this itself is going to be a huge reduction of risk of in abuse and addiction potential. So, I think if you're not monitoring someone and you're just letting them go off on their own, the abuse potential is going to be a lot higher. So let's jump into ways to reduce abuse and addiction and misuse. First, we're going to pre-screen our patients. Is there family history of abuse, personal history of abuse, tendency for addiction? What kind of substances? Are they currently abusing substances? Is there a desire for abuse addiction treatment? Do they have support systems, working with other providers? Are they in counseling? Another thing to note, as I mentioned earlier, checking that prescription drug monitoring program. If you have this set up in your EHR, it's well worth the money if you're going to be prescribing controlled substances of any kind, but especially ketamine. The pharmacy mentioned to me that they actually had a case where a patient was getting ketamine from 2 providers. So I think it's important to check because it will show you who they're getting the substances from. The pharmacies are required to check Schedule 2 medications, but they're not required to check Schedule 3. So it's important that you are doing this as the provider. If you're interested in prescribing ketamine in any dose, I think it's important to stay within your comfort zone, at least while starting off. Start with microdosing forms of ketamine and get comfortable with prescribing it, understanding how people are responding to it, and then making sure you're setting limits to the dosing, the refills, the frequency of dosing. If you have boundaries in place, you're less likely to get into questionable situations with patients. I've had, to Cindy's point, patients who really like ketamine, I will take them off, right? If patients are like, oh, I really want that again, or it's not a comfortable place for me, right? I mean, my job is to protect a patient, and so at some point we have to make decisions that the patient doesn't like. So again, having good boundaries is important. Let's see. Consider trying out doses that you plan to prescribe, if applicable, to become more comfortable with the ketamine's versatility. Partner with a trusted pharmacy who has experience with ketamine and compounding specifically. They can help with those decision-making. Clear instructions and education. I talk a lot. I give very clear instructions and education. As mentioned earlier, my titration instructions are meant to keep people from feeling that psychoactive effect. So I titrate really slowly. I'm fine with patients having to wait a couple weeks to feel the benefit. That's the case with a lot of medications they're taking anyway, like SSRIs. This might not be as feasible or appropriate in your practice if you're treating a lot of pain or suicidal ideation. So you kind of may have to modify depending on what's going on, but that's really what works for me in my practice. Warn patients about side effects if they take too much, as we talked about. Do not combine with sedatives or sleep medications, illicit drugs, high doses of alcohol. You want to make sure that whatever they do is consistent. So, if they're taking a sleep medication at night, when they build up on that that ketamine with the medication in place, they're going to have, that's the dose that is tolerated. If they are going to be inconsistent with the medication, it's possible that it could augment the ketamine and then, cause some side effects. So just things to consider. Additionally, sometimes this can't be helped, right? So I had a patient who had an allergic reaction. She took a Benadryl after, environmental allergic reaction to something. It was too close to her nighttime bolus, which is her larger dose, and it caused hallucinations. That's the only case of hallucinations that I've had, but something to warn patients about. I'm not really worried about a patient drinking a couple glasses of alcohol with dinner when they're taking ketamine before bed, but you don't want patients drinking heavily on the weekends and then adding a dose of ketamine to that. I would advise them to skip the dose in those cases. And then some repeated information, just for its importance. No driving when titrating, and counsel the patient on dose changes. Lastly, chart your instructions, your possible side effects, and discuss the addiction and abuse potential, et cetera. Just chart all of it, right? I mean, we're taught to chart everything. And again, I can't emphasize that enough, just to keep yourself out of litigation situations potentially, if something comes up. Consider a handout to just give patients and reference that. Here's a litigation case, a misuse case. So this is a March 2018. An OHSU doctor prescribed nasal ketamine for pain management. The dose was 150 milligrams per milliliter, which is kind of the highest dose you can go with nasal spray, I believe. And it was to be dispensed 5 to 10 sprays every 3 hours. So if we do the math on that, that's 75 to 150 milligrams every 3 hours. It's obviously, we're out of a microdose range at some point, especially after like maybe even the first nasal spray route. So, that's a possibility of 750 milligrams a day of nasal spray in the very first month of use. So a few days after his second dose or his second prescription refill, he experienced severe episode of dissociative behavior. He attacks his wife of 20 years. The police are called. He's found naked. He struggles with police, is arrested, charged with attempted rape and multiple counts of assault. He has no memory of this. He goes to jail for 45 days. And then, his family loses their home and, money due to legal fees. It's a bad situation. Then he's evaluated by a doctor, summarizes that the amount of ketamine was a gross overdose. So his criminal charges are dropped. And OHSU and the pharmacy are considered negligent for the following reasons: prescribing nasal spray when it's not approved for nasal use, prescribing excessive and dangerous dose, failing to warn the plaintiff of potential side effects of hallucination and dissociative behavior, and failing to administer a test dose in a monitored setting. So again, educating your patients, titrate slow, create a max dose when prescribing. I think these are all kind of take-home messages. And remembering, like 750 milligrams in the first month of use is too much. Okay, check in frequently. So my program, I follow up at 3 weeks after starting the titration. And then I follow up every 3 weeks until we found their effective microdose. Then about every 8 to 10 weeks through the 8 to 12 month program. So I consider this a short-term therapy. I'll talk about that a little bit more in a minute. Additionally, I'll follow up for unexpected dose changes and early refills. Ketamine is a controlled substance, and we need to treat it as such. Recognizing pain clinics require follow-ups every month for additional medication, right? The same goes for some ADHD medication providers. So I think it's important that these controlled substances are being monitored appropriately. Counseling. So this one gets a gold star for me. In the last couple of years, I have actually changed my protocol to require counseling during that 8 to 12 month treatment, especially if I'm using the ketamine for mood disorders. And I would say that's probably majority of my practice is mood disorders. As we know, the combination of therapy and medications have improved efficacy in patients with depression. I included a few meta-analyses here to just kind of hit that point hard home for you there. Additionally, this creates another layer of protection for you, right? So you're adding another support provider that, to your patient's team, and that other provider is also able to monitor and watch for suspicious behavior. Which brings us to our next point, watching for suspicious behavior. You want to look for early refills. Some of this was discussed already with Dr. Grande. One thing to note, always check in at this point, because it could be that their dose is not quite high enough, or it could mean that they're overusing. Claims that they spilled or lost their medication, or that bottles are leaking, or attitude or mood changes, signs of paranoia, significant reactions to accusation of overuse. So out of the about 90 cases of ketamine that I prescribed, I've had one abuse case. It was with higher dose nasal spray. There was some suspicious behaviors and red flags that I probably overlooked due to what I now realize was manipulation. She had the container bottle would leak in her purse and in the fridge. She stated at points that she was afraid to ask her psychiatrist for more Xanax because she didn't want anyone to think she was abusing it. I would argue that if you're not abusing something, that wouldn't be something you would be afraid of. In an ER visit, she was diagnosed with acute pancreatitis and accused of being an alcoholic. When I confronted her about this, she was highly emotional, sobbing and crying in complete denial that she had ever, she was drinking at all. It was, looking back now, I realized that it was an act, right? Because it turns out that she had been drinking. I found this out later after a psychotic episode where she had overused her nasal spray, and her husband had to contact me about concern. So, these are just things to pay attention to. But, you learn from these situations, and then hopefully don't make the same mistake moving forward. Consent forms. Consider making your patients sign consent forms for your expectations. So that can include whatever makes sense for your practice and protocols. I included here a few things just to note, right? Take as prescribed, sharing medications not allowed, store away from children and pets, just to avoid any risk of that. Dose changes have to be discussed, no combination with pharmaceuticals, especially controlled substances, unless discussed with a provider. Early refills limited to one, or maybe you're just requiring appointments to do any refills, and then therapy during treatment. And creating an integrated plan. So this is probably my best protection against abuse. I very rarely am using ketamine as my only treatment. As a naturopath, as naturopaths, we have incredible tools, right? We're already using amazing things to benefit our patients. So often when I introduce ketamine into a treatment plan, I've already been working with the patient for months and months to years. So I've established dietary changes, blood sugar balance, nutritional supplements. We're addressing gut health, hormonal regulation, whatever. I found that ketamine helps remove some of the psychological barriers and improves compliance. I've had about 3 or 4 patients actually remove themselves from really toxic work environments while on microdosing ketamine protocol. So, I think this is a very difficult and brave thing to do, but it was something that they were able to accomplish once they kind of got that confidence that they didn't need to be in this environment anymore. So, yeah, I think it's a beautiful tool to add to patients that you feel could benefit from it. For me, the goal is short-term therapy, and that's typically true for my setting. I really believe that ketamine microdosing can be a corrective therapy by resetting the brain, resetting the stress response. That is what I've seen clinically. I set the expectation that the treatment should be about 8 to 12 months. And I would say my practice average duration is actually around 13 months. As a disclaimer, I'm not working with many chronic pain or addiction patients in my practice. So that can change the treatment length. And, those patients may need more time. And in some pain patients, maybe are on it for many years, or maybe that is their pain medication ongoing. I really like to take advantage of this year timeframe with patients by working on kind of all the layers of health. The cool thing about ketamine is that because it, take some of that stress layer away from the patient's presentation, you're able to kind of see some of those underlying factors. Stress plays such a huge role in our health, and the ability to remove that barrier is really valuable for us as practitioners. Benefits to ketamine. So I'm going to jump into some of my clinical, some research and some of my clinical cases. I'll discuss a few cases. I'll link them to research. I've highlighted those here. This is a huge list of benefits that I've seen with ketamine, but I tried to highlight a few that I'll discuss in a little bit more detail. So, clinical benefits on hormones and stress response. Ketamine can shift reactivity to stressors. It rewires the brain, increases neural connections that diminish in chronic stress. Influences the autonomic nervous system, resets the stress response, and it works as a prophylactic against stress. So that latter point, here's a study that showed that mice were administered with a single dose of saline or ketamine. 1 week later, they were subject to stress for 2 weeks, or corticosterone for 3 weeks. And basically the results showed that the mice treated prophylactically with ketamine were protected against the deleterious effects of stress and blocked the stress-induced behavior when injected with corticosterone. So I find this to be really incredibly valuable information. I think about what this means for patients who are currently in stressful or traumatic situations that they can't really get out of. This article also discusses the possible implications of military settings. But additionally, one precursor to depression is that chronic stress. So maybe preventing depression in some of our patients' issues. Here's a case that relates to that. So 45-year-old female returned to clinic. I'd seen her a couple years before. She comes back during a very difficult divorce. Her husband, previously kind man, suddenly becomes very abusive toward her during the abuse. Took advantage of the fact they have to communicate about their kids to just verbally abuse her. She's in counseling as well, but she's just really not handling the situation, and it's a very messy divorce. There's going to be a case, a legal situation, case, court stuff, whatever, right? So he's making it very difficult. So I put her on a 60 milligram sublingual solution in January 2021 and a nasal spray. I advised her to use a nasal spray, prior to the conversations with her ex-husband, in anticipation that she would kind of be in a calmer state and not overwhelmed. January to April, she's on a 64 milligram milliliter solution, a bolus at night, and then from May to February, I put her on 100 milligrams per milliliter nightly. The nasal spray was a 100 milligram per milliliter solution. I changed that dose because she had needed 4 sprays in order to manage the anxiety and panic associated with talking to her husband. So we increased it to 100 milligram per milliliter, and I had her do 1 spray, max of 3 sprays per day. She discontinued this after her divorce trial was finalized. That was February 2022. So again, 13-month time range. I didn't know about the prophylactic effects of ketamine at the time, but it's really exciting to think about how we might have the potential to prevent deleterious effects of stress. Divorce and all these types of things are very common in our society. So they're very stressful for our patients. Here's a small proof of concept study, but I thought it was really interesting. It had a great p-value. They were able to measure with 90% accuracy whether someone suffered from depression. This was based on the heart rate and heart rate variability. Patients suffering from depression had higher baseline heart rate and lower heart rate variability compared to healthy controls. After the ketamine treatment, both heart rate and heart rate variability changed to become more similar to the controls. And those, interestingly enough, those with higher heart rates responded better to the ketamine treatment. With this study, we're seeing that ketamine has that influence over our autonomic nervous system. Here's another similar study on heart rate and HRV. Notes the underlying malfunction of the ANS in major depressive disorder. And then here's a case that I consider an autonomic reset. So I had a 46-year-old male diagnosed with asthma. He's on 2 inhalers. COPD stage 3 with spirometry result of an FEV1 of 41%. Chronic pain syndrome from a previous groin injury. He's on opiates before bed for pain management. He's got diabetes type 2. He's on medication. He's got hypertension. He was on 3 medications and still not totally controlled on that. He's got hyperlipidemia. He's on a statin. Sleep apnea. He's on a CPAP. He also has this significant chest pain that it's caused him to go to the ER like 2 times in 2020. Still happening often, but he's just not going to the ER because they couldn't do anything for him. Difficult breathing, pain with breathing. He's got high heart rate, insomnia from pain, and then he's on polypharmacy. So ketamine, I started ketamine treatment. He was told, let's talk about the treatment first. So September 21, I started him on that 60 milligram per milliliter solution. Within a month, he was up to the 96 milligrams. And then in November, I had him on 100 milligrams 3 to 4 times a day, and then a bolus dose at night. And then by December, I just kind of switched him over to 100 milligrams 4 to 6 times a day. So up to 600 milligrams in a day. This is a large dose. And, he is on opiates. So the other thing is he's going to tolerate higher doses of that medication. Other thoughts on this, he was told that the COPD was a progressive disease and he would eventually die from it. So he was in the process of applying for disability. He was in what he described as unbelievable pain and couldn't even really leave his house. He couldn't engage in activities or exercise. His social life he couldn't visit his his mom and his daughter, who lived about an hour away, driving was just basically not an option for him because he would just feel, he'd be bedridden for several days after driving. And, he pretty much just laid around all day due to fatigue and pain. He'd been suffering like this for about maybe 3 or 4 years before our first visit. So I like this visual. I think it really relates to this case. As you can see, like the ANS and the HPA dysfunction leads to a metabolic syndrome, right? And then onward to actual disease state. But so and another note about the amount of ketamine, I would say I had probably 10 conversations with the pharmacy regarding this case, because I will say the dose is it is intimidating. It's not a comfortable dose level for me. In general, this is the highest dose I have on any patient. However, given the situation, it was really hard to justify discontinuing his medication when it was so life-changing for him. His response, he had his chest pain reduced. He no longer had that, feeling like he was having a heart attack. He had better pain management. He was still in chronic pain, but that unbelievable pain that is like, he called it like a death pain, really improved on the ketamine. He could sleep more hours, and his blood pressure was managed on the ketamine. He actually said, before he was not managed on 3 medications, and now with the ketamine, his blood pressure is in the right range. His shortness of breath improved. He could take fuller breaths. It's still hard to breathe, and definitely in the summers during smoke season, I'll call it, he had issues with breathing, but for the most part, he had an improvement in shortness of breath. And then that repeat spirometry in April 2022 showed that his FEV1 was 94, which was a completely, normal result. So we went from having a COPD stage 3 to not having COPD at all, which is an unusual progression. So let me think here. I have a lot of things to say about this. I think it was hard for me to justify discontinuing him when it was just such a valuable treatment. And there were times when he would, run out, or the pharmacy didn't get the medication to him in time, and he would run out, and, the symptoms worsened, and his blood pressure wasn't as controlled and all of that. So, it was hard for me to justify not having him on this dose that's working so well for him. But with that being said, ketamine is not our only treatment. So since working with him, he's had acupuncture, chiropractic, physical therapy, injection therapies, to some improvement, but not enough to really get off the opiate at this point. I avoid using ketamine therapy as a passive treatment in general. So I think it's important to note, we're not just using this for forever, ideally. I mean, in some cases that might be true, but it is hopefully a short-term therapy to provide relief and resolve underlying issues that you can, find the root cause of disease or pain or whatever. One unfortunate aspect of this case is that he actually lost his disability case because the spirometry results were normalized. His stage 3 COPD was part of his case for why he needed the disability. And in my opinion, he still needs it because he's not really functioning great, but his life is much improved in terms of how he feels. Anyway, it's a very fascinating case. Here is a little bit of research, a research article on suicidality in patients with premenstrual dysphoric disorder. I have several patients who have had this and improved with ketamine. I chose this case because I thought it was the most interesting of my cases. I use progesterone a lot in PMDD, and I actually have discontinued progesterone with several patients after starting the microdose ketamine. So I can't say with certainty, but I really think that there's an abnormal stress response in the PMDD. So that's why I think ketamine has been so useful. So quickly, the research article is a meta-analysis of suicidality in patients with PMDD. They found the diagnosis of PMDD was associated with increased risk of suicidal ideation, greater risk of attempting suicide, and increased risk of a plan. So rough symptoms to have. My case was a 22-year-old female with PMDD. She had depression, anxiety, during the luteal phase, it increased, and acts of self-harm and suicidal ideation. And we were like about 2 weeks prior to her period. And then, progesterone was helpful for her and for periods in general, but they were, they weren't really changing that self-harm symptom. So the ketamine microdosing at 4 milligrams nightly, yeah, she was on a super low dose for a year and a half. And now she reports she no longer has the urge of self-harm, also improved her body dysmorphia and some disordered eating habits that she had. So it was pretty fantastic result for 4 milligrams for over a year and a half, and suddenly not have any self-harm. I think is a pretty successful case. I added this one in there because I think it's a cool application. And there's a little bit of research on it, not a whole lot, but maybe, we have smoking, patients who smoke, so it might be relevant to the practice. 44-year-old male with depression, chronic fatigue. I've been seeing him since 2018. He had wanted to quit smoking twice before we started ketamine. And prior to that, about a dozen unsuccessful attempts. The first 2 times we used Chantix, acupuncture, kava, other naturopathic modalities. But, he just really couldn't tolerate the irritability and mood changes, excessive eating, that kind of came along with quitting. So we started ketamine in October 2020 for depression. And our third attempt in October 2022, he's been cigarette-free for 5 months with minimal cravings, no mood alterations or excessive eating. So, and he's also using the varenicline, which is like the generic Chantix for smoking cessation as well, in combination with the ketamine. And again, we weren't using ketamine for smoking cessation, but this has been his most successful, and he feels great. So it's kind of exciting. So quickly, I'm over time, aren't I? I have a couple of research things. It's just take a couple minutes, so you can cut me off if it's not, if you want me to stop. Thoughts?
How's about 5 more minutes, Dr. Sandell? Is
Okay,
that good?
that sounds good. Okay.
Perfect.
So I wanted to end with a few studies using actual microdose ketamine. These are study areas that I think will be relevant to your practice as naturopaths. So here's the first one on depression. This was a very low dose. They started at 10 milligrams of sublingual ketamine and increased by 5 milligrams as tolerated by the patient. And they dosed it every 2 to 3 days or weekly. It was really patient dependent. They found that 20 out of 26 patients achieved remission or clear response from depression. And they also noted no manic or psychotic or dissociative symptoms were observed. So it was a true microdose. Here is a kind of a visual from that study, which I just wanted to include. There was a couple more pages of this, but I've highlighted here. There's three 36, 35-year-old females here, all had kind of a different range of dosing. The first one had 12 doses, which is 120 milligrams every 3 days. The 35-year-old had 180 milligrams every 2 days. And she actually had a sustained response after stopping ketamine. And then the last one here, 180 milligrams every 40 milligrams every 3 days. So again, the range is quite dramatic for patients. I think it was pretty cool to see this microdosing study because, a lot of the studies are going to be on high doses of IV or IM. So it was great to see that there were statements of remission and sustained response, because I definitely see that in my practice. Again, I think the short-term treatment protocols are successful, especially for mood disorders. In this study, they did 50 milligrams of nasal spray, which to me is borderline, maybe not a microdose. And they actually kind of mentioned that there was minimal psychotic or dissociative effect. So, again, probably not a microdose, but, depending on the patient, maybe some of them were tolerating it without any symptoms. But it had such a great p-value that I just wanted to include it because, the study showed that significant improvements in depression. Here is a migraine study. 25 milligrams of nasal ketamine for migraines with prolonged aura. I actually personally not thought to use ketamine for acute migraines, but I think it's an interesting idea. The p-value wasn't awesome. It did reduce the severity, but not really the duration in this case, but something to think about. Ketamine in pediatric bipolar disorder. So this is a clinical study using intranatal ketamine in pediatric population. So that was an age of 6 to 19 with bipolar and fear of harm phenotypes. They used 100 milligrams of milligram per milliliter nasal spray. That's 10 milligrams per each spray. And they used that every 3 to 6 days. So the dose range for them was about 30 to 120 milligrams every 3 to 7 days. They noted a rapid therapeutic response that lasted 72 to 96 hours, followed by return in fear of harm symptoms. I personally do not treat children generally, so I don't have any experience with ketamine in patients under 21 years old. But this made me think of children in, pandas and pans and, that population that's just really struggling and really hard to treat. It's possible that some of you out there are working with this population and might be an area to investigate. So I did want to include this. And also, I don't treat children, but I would personally think using a daily dose might be interesting rather than kind of every 3 to 7 days, because I don't know why they would want the symptoms to return. I would think just keeping those symptoms at bay would make more sense. But anyway, maybe applicable to your practice. And here's my last slide. So we're almost done. And I just wanted to mention some optional applications of additional applications of ketamine. This is from LoneStarInfusion.com. I thought it was a really great source. It's kind of, or he, I guess I don't know who it is. They included large clinical data and large research on these, specific symptoms or diagnoses. There was good clinical data and few research on fibromyalgia, trigeminal neuralgia, OCD, and then some clinical data and limited research on this area of Lyme disease, through hearing loss and tinnitus. They mentioned Parkinson's and Alzheimer's, and I think there were some questions about that in the Q&A or the chat. So, again, I think I just wanted to include this so that, maybe there's some more clinical implications that, might be relevant to your practices. I have plenty of patients with Lyme disease, and I do think that the ketamine, again, does shift some of that pain and the depression and a lot of the, just a lot of aspects of what's going on with them. So I found, again, it wasn't for Lyme disease, but I found it to be successful for some of the other symptoms that they were experiencing. Okay, that's it for me. Thank you.
And we'll do our best to make our way through this list of questions. And while we're doing that, I'll go ahead and start with a quick question. I know that we had addressed having the patient titrate in a controlled setting and not having them drive during that titration process, but we do have a number of people asking about just driving in general while they're microdosing in an ambulatory setting. Does anybody want to address that one?
Sure, I can. So it's just more during the titration, just because you don't know how you're going to respond to the medication. Some people feel completely fine. Once they've established their dose and they're doing daytime doses, I have patients drive. I actually have patients who use it before driving if they have driving anxiety, right? So it's not really a problem unless you're titrating because you just don't want to put yourself in a dangerous situation.
Perfect. Thank you. That's very helpful. And another question is, how long can patients safely continue microdosing? More than a year or indefinitely? Does anybody have any insight?
So that one I can answer because I have patients who've been on it for 10 years. I just did an analysis of that. The 45 patients that were on both ketamine and buprenorphine, the average length of time that they'd been on both of those medicines was 5 years, and the range was like a couple months up to 10 years.
I have a patient who's not microdosing. I have we use troches or sublingual lozenges quite frequently. We always have well over 100 patients on troches and have for since 2016. And we go dosage ranges from 100 twice a week, 100 milligrams in a lozenge twice a week, to 800 milligrams a day. And my staff is extremely trepidatious about this, and I get an email every month with those who are on 400 or more. And I have to write a little note about why it's still okay. I respect that. It's important to start slowly and to go to start low and go slowly. But this is a man who we started taking care of when he was 18 because he was failing his freshman year in college, and his very prominent and prosperous family was just beside themselves, and they had tried everything. And he had infusions, and they were very helpful, but they didn't sustain. So we put him on lozenges, and no amount of lozenge would help him until we got to 800. He's finished college now. He's dating and he has a job. Whenever, as a result of these monthly notes from my staff, I drop him back to 700 or even 750, he starts to decompensate. So I go back to 800.
That's great. Thank you for sharing, Dr. Mandel. We do have quite a bit of interest in regards to using ketamine for teenagers and younger kids for depression, anxiety, and PTSD, and how that might be dosed.
I dose them intravenously the same way I dose adults. We have a lot of adolescents with PTSD. We have a lot of adolescents with depression. We have a number of adolescents with gender dysphoria. And I dose them a little lower. And there's been a lot of talk about psycholytic doses and microdoses. I'm not expert on the very low dose range. I certainly admire what Cindy has done tremendous, and I really like what I learned from Hillary. But kids really respond to ketamine, and it's cruel, in my opinion, to not offer people ketamine because their age doesn't qualify them. 17-year-old suicidal people, 16-year-old suicidal people deserve a trial of ketamine. It reverses suicidality better than anything.
Wonderful.
My experience, I just have one patient who was under 18 that I treated, and it's not because I wouldn't treat somebody else younger. I just haven't had that patient population. But if you start people at a really low dose, 2-4 milligrams, then you work your way up. I don't know why you couldn't do that with children as well as adults.
With all of these things, the patient is part of the conversation, not something or someone you're doing something to. It's a, if you will, a colleague in the treatment. And if you approach it that way and are fully consenting and keeping informed, and with an adolescent, that includes the family. And when there's a divorce involved and one parent is blaming the other for the condition of the child, it's a nightmare tightrope kind of deal. But the results you get are worth the effort.
Thank you for sharing. The next question, with PMDD cases, do you just dose the ketamine in the luteal phase or throughout the whole cycle?
So I just do ongoing every day. I haven't really played around with luteal versus follicular phase, and it's definitely something to experiment with. But at this point, I find that it's that, most of my titration, and my my maintenance dosing is daily. So I guess I just don't really have experience with kind of on and off dosing in that way. But it's definitely something to play around with.
Wonderful. And Dr. Grande, we have a question targeted specifically for you. A lot of folks would like to know if you keep sublingual ketamine in your office to give to patients for in-office administration.
The answer is no. And I thought about that a long time ago, and it's mostly a few different reasons, but documentation and DEA scrutiny and liability, all those kinds of things. I don't see any reason. There's sometimes that I wish I did because somebody needs it right now, And sometimes I have a local compounding pharmacist that is sometimes able to produce something within a few hours, but not always, and especially like Friday afternoon. And they're not going to get it until Monday. That's just like really frustrating. But all things equal, I've just decided not to have it in my office.
Great.
I wanted to address one of the chat questions that just came up, because the question was any experience with pregnancy and or lactation, such as postpartum depression. And I actually had a whole another section of my presentation about this. I obviously did not have enough time to go through it, so I decided to remove it. But there's some really fascinating research on postpartum depression and working with women, in that population. I think, pregnancy isn't necessarily contraindicated, but nobody's going to do studies on pregnant women. But the reality is that ketamine is used safely for cesarean sections and for, surgeries that need to be done after tubal ligations or whatever they're doing post pregnant, birth of your child. So, again, I think it's a hard area because, no one's really doing studies on this population, but I'm super interested in the postpartum depression idea because maybe not so much in the microdosing, because I think it's hard to predict, how one of the studies, I should say, had the dosing, they were actually measuring the breast milk of women, after using high infusion of ketamine. And they found that, a 3 hours, 6 hours, 12 hours post ketamine infusion, obviously lower and lower levels. But, whether you want to expose that to your infant is kind of, I think, a cost benefit analysis, depending on how severe the patient's postpartum depression is and whether or not it makes sense to go with another form. And with that being said, they kind of recommended basically just withholding and pumping and dumping breast milk for about 12 hours and then continuing breastfeeding. So in the microdose population, I haven't attempted it because I think it's just not enough information for me, but I think it makes sense maybe with a higher dose and then with pumping after to consider something like that.
I respect your concerns and your cautions. We do infusions on postpartum patients all the time. And we've strongly advocated because we get so much gratification, not just from benefiting the patient, but what happens with the partner and the newborn is really important. That's when the bonding's happening, and you want a fully functional and attentive person able to be there. We used to pump and dump. We used to advocate pumping and dumping. The recent research suggests that the concentration is extraordinarily low in breast milk within a few hours. It's not nil, but it's very, very low. Now, in perspective, and this is not exactly analogous, we give ketamine in quite substantial doses to infants having anesthesia. In fact, it's the safest anesthetic we can give them. And they do just fine. Now, that's not the same as chronic, I understand. But we treat that, and we treat antepartum suicidal patients with infusions. After reading a very tragic story in the New York Times several years ago about a woman in Seattle with everything to live for who just could not get through. She'd stopped their SSRIs because they were going to harm her baby, and she stepped off the 16th floor of her parents' building. I think the risks of antepartum ketamine are much better than the risks of stepping off the 16th story building.
Thank you for sharing, Dr. Mandel. I think this question is probably pretty popular. Does microdosing of ketamine help with benzo withdrawals?
That is $1 million question, and I want to give it a try. I never thought of it. It's a really hard problem, benzo withdrawal. I mean, it's really, really hard to get somebody that's been stabilized on benzos. So it's a really interesting question. I might look into that. Thank you for the question.
And there is some interest about ketamine for POTS. Has anybody have an experience with that? All right, more to come.
Again, that's
Sorry.
another one that's worth exploring. Thank you for these questions. Keep them
Yeah.
So,
coming.
I mean, I personally had a patient who I didn't officially diagnose with POTS, but I'm pretty sure had it. And the ketamine was aggravating for her. It would drop her blood pressure and she would have, really dizzy, so I think it really is a case by case basis on that. Yeah. So I had to advise her to kind of use it only in certain situations, or, obviously not be walking around or active or going out right during those times. So,
Great. And there does seem to be some interest in regards to how long you can actually dose microdosing and the duration of that and what's considered safe. Does anybody want to speak to that?
Well, so that one I already answered, and I said I have people that have been doing it for 10 years, and I don't see any reason to limit it to anything shorter than that, as long as it's working. And there's some people who don't need it anymore after a certain period of time for all kinds of reasons.
Perfect.
Yeah, that's my
6 years macrodosing, and there are some people who don't need it. And we, maybe I get a chance to show you a slide. We do a daily mood monitor check-in. It's an encrypted text message. And we graph people's moods, and we don't do boosters by the calendar. We do them by the need. And by doing PHQ-9s and BECs and the daily mood monitor, we know when our patients need, and sometimes they don't ever need, and that's fine.
And then Dr. Sandell, people would like to know if you're willing to share your informed consent and other patient information.
I think if somebody wants to, if they want to email me separately, that's okay. So yeah, that's in my emails on the end of my lecture.
Perfect. And are there indications for long-term ketamine microdosing, and what is the safety profile for long-term ketamine microdosing? I know we've kind of talked about it, but seems to keep popping up. Is there anything specific you guys want to say around that?
Long-term high dose, that's, it can, sometimes people can tolerate high doses for a short period of time, but if you do it for a long time, then sometimes problems start popping up. And they're not like life-threatening permanent problems. There are things that, the worst that happens is that they become tolerant and they're no longer able to benefit from ketamine. That's the worst that I've seen.
Yeah, I think that sorry, I was going to say, I just think that like some of the, risks of like bladder issues and stuff like that are typically really dose dependent and also aren't going to really show up in the lower doses. And if they are showing up, discontinuing ketamine is usually the what you would do to resolve those issues. So I think that, and there was that one article I mentioned that just came out about ketamine. It was a really interesting article, so you should read it. But one of the people that he interviewed was using a 35-year-old woman who was using diapers because the ketamine was so beneficial for her that it was worth having bladder issues, which, I think is obviously you get to make your own decision as a human being. But, so I think it just depends on the person, what they're willing to tolerate in terms of side effects.
I don't think we understand why ketamine bladder develops, because I've been doing this for 9 years now, and I've done 6,000 patients. And I've had 3 or 4 people with what might have been ketamine bladder. Ketamine bladder is actually a histologic diagnosis. It can be differentiated from chronic interstitial cystitis, which it very much mimics. And even where I've had depressives who have chronic bladder problems but feel the need to have ketamine, giving 600 or 1200 of N-acetylcysteine starting about 36 hours before infusion, having them hyperhydrate before void. You must have a void before the infusion, or they'll need to go, because it does kind of provoke a need to go. And then having them drink and void like crazy that afternoon. They don't get provoked. They just don't. Very high maintenance, who has a devoted carriage tray urologist And she gets an installation in her bladder of a proprietary mixture the day before her infusions. And that seems to work too. But I love the N-acetyl-16. It does not always work, but it always diminishes the discomfort. Sometimes it eliminates it. It's so important that we first not do harm. And I hope I don't sound disrespectful of people who are trepidatious. You should be. But you should also proceed with eliminating suffering in the face of being uncomfortable. Get comfortable with the medicine. The medicine is going to help your patients, and that's all for the good. When you give ketamine sublingually or orally, only a small portion goes to the brain. A great deal of it, all of it that you give, ends up going to the bladder. If it sits there, particularly in people who are reluctant to void away from home, it sits there for a long time, and it's just not good for them. That's my 2 cents.
Thank you, panel, for a very informative Q&A session. We look forward to Dr. Lindsay Wilkinson taking us through the ND considerations for IV ketamine administration, using herbs and supplements to complement ketamine effects, and medication storage and sourcing, safety and legal issues. Thank you so much, Dr. Wilkinson. We look forward to your presentation.
Everyone, thanks again for tuning in. I'm so excited to be presenting in front of all of you. It's been great to see some really familiar names in the chat, even though I don't get to see your faces. Thanks for coming, and I really welcome feedback, questions, engagement as we go along. Megan's going to be advancing my slides for me, and that way I can kind of view my notes as well. And let's go ahead to the next slide, please. So the topics of discussion for today are considerations for IV intravenous ketamine, synergistic use of herbal medicine in ketamine. And this is really just sort of the tip of the iceberg. There's so much that we can do, so many other types of tools that we have in our box that can be synergistic with the use of ketamine treatment. So I really encourage you to explore those and use those as well. And finally, we'll talk about medication sourcing and storage issues. Next slide, please. I don't have any financial conflicts or other conflicts of interest to disclose. Okay, and we're going to move right into it. So intravenous ketamine. So why would we do intravenous ketamine infusions? There's a lot of possible indications for IV ketamine or oral ketamine and microdosing, as we've seen with earlier presentations. For intravenous ketamine in the general community of providers who are administering these treatments, there's 2 main dosing protocols. One is for mood disorders, namely treatment-resistant depression, major depressive disorder, generalized anxiety disorder. There's others as well, of course, acute suicidal ideation. We're thinking OCD, PTSD, bipolar depression, not bipolar mania. So lots of mood disorder dosing. And the second reason we might do an IV ketamine treatment is for chronic pain. And then we want to break down what kind of pain we're treating. Is it neuropathic pain, non-neuropathic pain, and or migraine headaches? So being really clear on what it is, what's the goal of the treatment for your patients is step number 1. And remembering that there's these 2 main pathways for IV ketamine treatment, mood disorders and chronic pain. Dr. Hillary also did discuss, there's a blog post on the Lone Star ketamine infusion. It's a blog post from a provider who does ketamine, but it's a really nice comprehensive list of all of the possible indications. And she breaks it down by which ones have the most research, which ones have some research, which ones are possibly beneficial. And some of the applications that I think are noteworthy for naturopathic doctors in particular are things like chronic Lyme disease. We're always looking for possible interventions that might be helpful or supportive for patients with longstanding chronic conditions that really change their quality of life and ability to function normally. Although we don't have a lot of robust evidence at this point for those implications or for those applications. Next slide, please. Okay, so let's talk a little bit more in depth about mood disorder dosing for IV ketamine. In my practice, my area of expertise is using psycholytic and psychedelic doses of ketamine, which are all sub-anesthetic. Remember, as naturopaths in the state of Oregon, we're staying below that threshold of anesthesia. We're working with this microdosing and these other dosages that can help with talk therapy or have a full psychedelic effect for your patients. So the mood disorder dosing, patients are going to experience some level of cognitive or dissociative changes. In my vernacular, that's a psychedelic experience. So patients who are doing IV ketamine treatments for mood disorders will have a psychedelic experience unless you reduce their dosage. If that's not tolerable, that's not something that they want, they're considering that a side effect and are really focusing on the biomedical changes that are happening in the brain or biophysiologic changes that are happening in the brain, you can always change your rate of infusion or reduce the dose so that it's not so intense. Conversely, some patients are really there for the psychedelic experience, in which case you can upregulate the dose depending on what's needed to create a level of intensity in that psychedelic experience that a patient is looking for or that's beneficial for the patient. With mood disorder dosing, both the literature, the available research, as well as what's commonly practiced for ketamine clinics across the US is that you always want to do a loading series first. So it's a bolus dose, and then you can do maintenance doses and spread those out over time based on how a patient is responding to treatment. I would also argue that one of the things that we can do for patients to provide additional benefit is to be doing that loading dose series and start doing booster infusion doses, but maybe considering doing a very low dosage of a nasal spray or of an oral lozenge or a troche in between maintenance doses in order to, again, reduce the number of other kind of medications that they need to take possibly, or stretch out the amount of time between their infusions. As for a lot of people, it is cost prohibitive. Okay, so the loading dose series is typically 6 treatments over a course of 3 weeks. So it's easy to remember. Twice a week for 3 weeks is the initial loading dose. And what we're really trying to do there is maximize the synaptogenesis that is happening in the brain. So if patients are struggling with anxiety and depression, they have these railroad tracks of some old rigid thought patterns or negative thinking. And so we really want to create a loading dose experience so that new neural connections can be made. And then we use talk therapy, we use somatic-based healing techniques, other tools and tricks to help them deepen these new neural connections that are being made with the ketamine treatment. Your first booster dose after that loading series, which is 6 treatments over 3 weeks, is 2 weeks after the last loading dose. So you do your 6 treatments, wait 2 weeks, do another IV infusion, wait another 2 weeks, and do a second booster dose. After that, you can push it out to a month. I will say that this is sort of a general guideline and recommendation. It's really all over the map. Some patients need it sooner. Some patients don't need it for 2 or 3 or more months. And like I said, I really think we can use microdosing of ketamine synergistically to push out how many infusions and how frequently patients will need them. Just as an FYI, there's 3 studies from where this sort of protocol comes from. So in the first study, it was an infusion over 40 minutes. The peak benefit was within 24 hours. It improved mood symptoms for 12 days. And it had an 85% reduction in depressive symptoms. The second study had a 71% efficacy, and the reduction in symptom was seen for 18 days. The third study was looking at 2 versus 3 infusions per week, and there was no significant difference between doing 2 doses of IV ketamine for mood disorders in a week versus 3. So 2 is kind of where people have landed. And I have a lot of resources and studies at the end of the presentation, so those should be available for you to take a look at as well.
Dr. Wilkinson, I think your slides are not keeping up with you. Are you seeing?
I'm on slide number 6 right now. I just changed to slide number 6. It says, for chronic pain, why are we using ketamine? Is everybody there?
You're supposed to be telling them to advance the slide, I think.
Okay, I'm sorry if I haven't been doing that. Hopefully you have those slides in front of you as well. So I'm on slide number 6 right now, intravenous ketamine. For chronic pain, why are we using ketamine? There's 3 main reasons that we've seen sort of in the literature and in the community. We want to improve quality of life. We want to reduce more dangerous or difficult medications such as opiates, so we can reduce the frequency and the dosage of consumption. And we also want to reduce hyperalgesia, or the sensitivity to pain for patients. Chronic pain dosing with IV ketamine is much more variable than mood dosing. in terms of actual per treatment ketamine dose, as well as the number of infusions that should be done in the loading series. And the reason for that is that chronic pain patients are often on a lot of polypharmacy. Some of that polypharmacy is going to impact how the ketamine is metabolized, whether it's more or less effective. And so the typical dosing range that I could find in the literature was 1 milligram per kilogram per hour of ketamine, all the way up to 7 milligrams per kilogram per hour. So that's a whopping dose. That's a very high dose of IV ketamine. So I do not treat chronic pain in my practice. It's not a big part of my practice. I'm sticking more to the mood dosing protocols, but I wanted to give you that as something to think about. Let's go to the next slide. Slide number 7. So we're still talking about pain infusions. These infusions are also much longer. They're given over a 4 to 6 hour period. That's a long time to be hooked up to an IV. For non-neuropathic pain, you might want to consider 3 to 4 consecutive daily infusions. So this is 3 to 4 days in a row during 1 week. This might be for post-surgical pain, like the example that was given in the literature was post-multiple back surgeries for low back pain. Or fibromyalgia might be a non-neuropathic pain where you could use that 3 to 4 consecutive daily infusion dosing. For neuropathic pain, 5 consecutive daily infusions. So that would be a Monday through Friday, 4 to 6 hour treatment, treating something like complex regional pain syndrome or small fiber sensory neuropathy. Again, this is not my area of expertise. I'm sure Dr. Mandel could answer additional questions maybe regarding chronic pain treatment with IV ketamine. I'm mostly doing mood dosing in my practice. And you can also use IV ketamine for migraine pain. This is a single infusion for an acute migraine headache. You can do this over a 2 to 4 hour period. This might be a better place to start if you're thinking about using IV ketamine for chronic pain. Let's go to the next slide. Okay, so one clinical pearl that I think we should talk about are the cognitive or dissociative changes. If you're doing an intravenous treatment over 4 to 6 hours for a chronic pain patient, the cognitive or dissociative effects or psychedelic effects, depending on how you look at it, is not required. That would be a really long time to be having a psychedelic journey and hooked up to an IV. So you can do a sub-psychedelic dose for pain over time. And for chronic pain dosing, we're looking more at the total dosage of ketamine administered over 4 to 6 hours versus the milligram per kilogram per hour. For mood dosing, it is common practice and expected that there should be some level of cognitive or dissociative changes, but the infusion time is 40 minutes, so it's much more tolerable. And this is something that you can really create a psychedelic journey around. So you can have a 2-hour visit where you spend some time setting intentions, preparing the patient, doing the infusion, and then at the end do a little bit of that setting up for integration work as well. So there will be a psychedelic level or some cognitive changes with mood dosing for IV ketamine. Let's go ahead and advance the slide. Okay, another clinical pearl. Always ask your patient if they're working with a pain clinic and make sure you know what their pain management plan is. If a patient comes to you and you're considering doing any kind of ketamine treatment, including IV ketamine, it's important to know what the plan is and who is on the patient's care team. There's also some reports that ketamine can work synergistically with opiate medications to reduce the frequency and high dosing of chronic opioid users. Okay, let's advance the slide. For IV ketamine, this is brand new territory for naturopathic doctors starting in January. So there's lots of considerations. I've been spending a huge amount of time doing lots of research, deep diving, lots of training to figure out how to do this safely and effectively as a naturopathic doctor in the state of Oregon. A few things to consider would be that it is recommended that you should do ACLS or Advanced Cardiac Life Support Training. We're all required to do BLS, but ACLS is going to give you a better understanding on how to protect a patient's airway in the case of laryngospasm or in case of any kind of cardiorespiratory emergency. There's also a lot of other medications you want to have on hand if you're doing intravenous ketamine in office. You want to have IV Phenergan, which is an antihistamine medication used to control nausea. It's preferred over IV Zofran because Zofran can have an SSRI interaction. You want to have IV Versed. So Versed, this is in order to help patients who are in an acute panic attack or anxiety during their IV treatment. Lots of things to consider. So don't take these precautions lightly. Even though ketamine is safe in and of itself, there's lots of supportive measures that should be in place around that before you start offering this treatment in office. Just a note too, that in Oregon, you will need to have your regular IV training and certification submitted to the board. You have to have your ketamine training hours, which is what we're doing now. Think about malpractice considerations, have a crash cart, or at least some supplies for airway management on site as well. Okay, let's advance the slide. Clinical Pearl. So if you're doing mood dosing for patients or anything above a microdose, you may want to start building your network of good mental health providers now. And the reason for that is if you're doing psycholytic or psychedelic dosing of ketamine, these patients are going to have things that come up that need to be processed. And so you'll want to have that as something you think about ahead of time, or something that you're having a conversation with the patient about. It is within our scope of practice as naturopathic doctors to do some of that counseling work, but it has to be in the context of you getting continuing education for mental health, and for you being able to understand your limits in terms of where the cutoff is between being a mental health provider and a medical provider. I also really recommend that you have a network of folks who are well-trained in working with patients who go into non-ordinary states of consciousness. So there's lots of wonderful therapists and mental health providers here in Portland area who are really seeking out training in non-ordinary states of consciousness, partially because of Measure 109, partially of their own interest. And so if you need some recommendations around like who to go to, the easiest one for you to take a look at is the Portland Integration Network. This was created by a mental health provider in our local area and has a lot of mental health providers who are doing some level of non-ordinary states or psychedelic work. A lot of them have ketamine training as well, so you can talk to them about that. Okay, let's advance the slide to number 12. In addition, for IV ketamine, there are some requirements by the DEA and Oregon State, usually through the Board of Pharmacy, on appropriate handling, tracking, and disposal of controlled substances. So because an IV, you're going to have the IV ketamine vials on hand. You're going to need to know how to store them, where to store them, and who those regulations are through. I did check, so mostly we have these easily found through the DEA website. They have specific information around storing controlled substances. I also did check with the Board of Pharmacy. They have a special form about becoming a dispensing physician if you're dispensing controlled substances, but the application explicitly states that dispensing does not include distribution of free samples. It does not include drugs, vaccines, or other para-enterals administered in the office. So that would include IM and IV. And it does not include writing prescriptions that would be filled by a pharmacy. I also checked with the Naturopathic Oregon Board on this requirement specifically, and they said to just go through the Oregon Board of Pharmacy. So we should be good to go there. There's no additional requirement for that application. Let's go ahead and go to the next slide. So just to review the requirements from the Oregon Naturopathic Board starting this year, the requirements to prescribe non-topical ketamine include 4 hours of additional pharmacy and 2 hours of ethics education. You will also need to make sure that you have your IV requirements completed and submitted to the board before you think about administering IV ketamine in office. Okay, it is within our scope of practice to administer sub-anesthetic doses of ketamine. Let's go ahead and advance to the next slide. And what does a sub-anesthetic dose of ketamine look like? What does that mean? So what I found in the literature was, and I have the citation there, is a dose of 2 milligrams per kilogram of body weight is the average amount required to produce approximately 5 to 10 minutes of anesthesia or dissociation. So typically when I was looking at the protocols for anesthesiologists, and maybe Dr. Mandel or another provider can chime in on this too afterward, is that for an anesthetic procedural sedation, there's a bolus of ketamine that's administered and then a lower maintenance dose to maintain that level of anesthesia over time. But you want to be below the threshold of 2 milligrams per kilogram body weight. Let's go to the next slide. So, okay, clinical pearl. Patients using a psychedelic dose of ketamine should be able to speak, move, and respond to your questions throughout the treatment session. And so I have never had an issue doing ketamine-assisted psychotherapy in office where a patient was not able to, they might feel a little out of it, or they might, their voice might sound different, but they can tell me if they're uncomfortable. They can ask if they can change the music, if they need to get up and use the restroom. So it is a very internal and quiet psychedelic type journey, but they are able to interact with you, especially if you're doing the dosing correctly. It should not be above that threshold. Okay, next slide. Each state has a different scope of practice for controlled substance administration. There is a document which is really clearly outlines. It's from the DEA. It's not a naturopathic board document. It's a resource from the DEA that has it outlined for naturopathic doctors in our scope of practice state by state. And I do have that also in the ethics presentation at the end of the day. Let's go to the next slide. So this is really a fun topic, is herbal synergy and ketamine treatment. I do this all the time, and I think that I'm still really just like using the tip of the iceberg. There's so many tools that we have that can work synergistically as we're helping patients to come out of severe depression, anxiety, PTSD, OCD, etc. So let's talk about that. Next slide, please. And I don't think any presentation for naturopaths would be complete without reminding ourselves that nature itself is the best medicine. And so as much as we're using ketamine as a tool, we are also doing all of the groundwork for diet, lifestyle, movement practices, optimizing nutrient deficiencies, et cetera, et cetera. Okay, next slide. First thing we want to talk about is blood pressure control. Dr. David did discuss this, and you know, I'm pretty careful about blood pressure control in my clinical practice. I really want my patients to be safe. So during the medical intake process, I'm doing full vital signs, a physical exam. I'm asking patients about recent labs within the last year or two, and I'm checking on their blood pressure. We know that ketamine will transiently increase heart rate and blood pressure during treatment. Many patients come to us with medications already on board, and some don't even know they have a blood pressure issue until we do their vitals, treat the patient where they're at, and we have lots of good tools to help reduce patients' blood pressure so they can access this medicine. I did find in the study that a typical heart rate increase would be 14 to 22 beats per minute during ketamine treatment. A systolic blood pressure increase may be 10 to 15 points. A diastolic blood pressure increase could be 15 to 19 points, and that's pretty significant. And the mean arterial pressure could increase with 10 to 12 points. This was in a study that was done with a procedural sedation. So it's going to be a higher dose than we're doing in office, certainly higher than microdosing, and certainly higher than psycholytic or psychedelic dosing. But it's important to keep those blood pressure and heart rate increases in mind. Okay, next slide. I love beetroot juice. I just love it. The literature is great. It's pretty easy for patients to get this on board. I will say that patients have much better compliance if you use the beetroot powder or capsules versus the raw beetroot juice, which is typically where the studies are out at. And so I am extrapolating a little bit, but I love beetroot juice. Just have your patients eat beets all the time, have them do beetroot juice if they're into that, or do the powder. It's really effective. So there's a systematic review from 2018. I also found a great study on using beetroot juice for endurance athletes and how it really promotes, through the nitric oxide pathway, it really promotes improved cardiovascular endurance. Yeah, so it's amazing. There's a huge dosing range that's been seen in the studies, 70 to 500 mils per day. It says there's no significant difference between volumes administered, but there's a newer study that suggests higher volumes is going to be better blood pressure control. And again, this is just one intervention that I'm using. There's so many other herbs that we can use synergistically as well, but this really does tend to be my go-to. It's pretty safe. Nitric oxide pathway is going to help vasodilate, really helpful. And so there is a protocol down here. I tend to use 1 tablespoon of beetroot powder mixed into water, juice, tea, whatever, however they'll take it, twice a day for 2 weeks prior to the CAP session. And then you can do it ongoing if you're doing ketamine-assisted therapy in office. If you're microdosing, you can use it. If patients are on blood pressure medications and they need additional blood pressure support, you can also use it synergistically there. It's not contraindicated. Okay, next slide, please. So clinical Pearl patients will often come to you on blood pressure medications already. For a session in office, if you're doing ketamine-assisted therapy, which is typically what I'm doing, or an IV treatment, you can try to optimize the benefit of their blood pressure medication by scheduling your CAP session accordingly. Typically, there's about a 2-hour window after they take their blood pressure medication of its highest level of potency and efficacy in the body. So if you can have them hold off their blood pressure medication if you're doing an afternoon session and take it 2 hours before, or I do a lot of morning sessions with patients, so I have them take it their normal morning dose of blood pressure and we get the CAP started within 2 hours of that. Alternatively, you can provide them a prescription for an as-needed blood pressure medication like propranolol. This can be used really easily. They can take their regular blood pressure dose or medication at its regular dose and timing, and then you can ask them to take propranolol. Usually it's like a peak maximum effect 60 to 90 minutes after administration. So you might have them come to the office and take it right when they get there, so that by the time you're doing your ketamine-assisted therapy session in office, that propranolol is working. It also has the additional benefit of helping some patients with anxiety, works on that sympathetic pathway. So really easy to use. If you're doing intravenous ketamine, you're going to want to use labetalol instead of propranolol. It's been hard to find these days, I will say that. Okay, next slide, please. Other blood pressure control herbal treatments. So hawthorn solid extract. I love this. Everybody should be on this. It's great heart medicine. It's a super antioxidant. It helps emotionally regulate the heart. You can do 1/4 teaspoon dosing, half teaspoon dosing. You can have patients do a syrup, a tincture, a tea, whatever you like. Get them on hawthorn. It's the best. Let's talk about grapeseed extract. There's lots of good studies on this. This is Vitis vinifera. 300 milligrams is one of the doses that I've seen be effective for studies. And the mechanism of action with grapeseed extract is through the antioxidant pathway. It's high in polyphenols, high in proanthocyanidins. So it's really helpful for blood pressure control. Can also do olive leaf extract. 500 milligrams is what the study showed that I have at the end. And this one works on a slightly different mechanism of action. It reduces LDL cholesterol, so reducing that atherogenesis within the blood vessels, and great for patients to use long-term. There's lots of vitamin and mineral considerations as well. Magnesium taurate has been studied as helpful and effective for controlling hypertension. Potassium for sure, but the general consensus and recommendation in the research around potassium is to try to get that through your diet. I don't typically tend to put patients on extra potassium unless they really need it for some reason. Examples might be patients who have electrolyte disturbances from eating disorder behavior, et cetera. But doing the daily recommended intake, making sure they're not potassium deficient, is a good idea. Vitamin K2 has an inverse association with coronary artery disease, although it hasn't been directly studied for blood pressure management or blood pressure control. Vitamin B6 is really important in so many pathways. In addition to blood pressure, it's also going to help with neurotransmitter regulation and modulation. Vitamin D is interesting. We do know that low levels of vitamin D are correlated with higher blood pressures. I also think vitamin D is really important for mood regulation. We know that for sure with seasonal affective disorder. There's a million reasons that your patient should be taking vitamin D if they're low. So check it and then supplement accordingly. Let's go to the next slide, please. Hawthorn also has a wonderful energetic emotional effect on the heart. I find that for patients who are entering altered states of consciousness and working with resolving trauma, this medicine can really help welcome people to the ketamine experience. It allows them to release grief, self-loathing, and enhances a sense of self-compassion and self-love from the heart. So you can feel free, if you're not doing Hawthorn solid extract or something like that at a physiologic dose, you can do drop dosing for its energetic or emotional qualities, which people will also really appreciate. Okay, next slide, please. Let's talk about liver and kidney support. Dr. David did talk about, and I think Dr. Mandel also, that ketamine is typically undergoes significant hepatic or liver biotransformation through two main enzymes in the liver, and that's CYP3A4 and 2B6. So and it also is transformed and excreted through the renal system, kidneys, and bladder. So liver support and kidney support can be really helpful. I do like to think about patients who are in special populations, for example, substance use disorder, alcohol use disorder, who might need additional liver support, or patients with non-alcoholic fatty liver disease. So we want to be thinking about what are the other conditions patients are coming in with, and what herbs or other tools can we use to support them synergistically. We talk about special populations such as over age 65, history of chronic kidney disease, bladder, kidney stones. I'm doing all of this legwork in the medical intake where I'm asking the patient about any of these conditions now or in the past. Doing labs ahead of time is really a great way for you to know exactly what you're getting into with a patient to ensure safety and reduce your liability before initiating treatment with ketamine. Okay, next slide, please. So with alcohol use disorder, we know that ketamine can be important and helpful, supportive for patients who are trying to come off of substances. It may not always be safe to ask patients to discontinue alcohol prior to their ketamine treatment. If they go into a dangerous withdrawal situation. So I did find an interesting study that was talking about zinc supplementation for patients with chronic and current alcohol use disorder to increase first pass metabolism and alcohol dehydrogenase activity. So you could do some zinc supplementation prior to their CAP session so that the ketamine works more effectively, so that there's less likelihood of a negative alcohol ketamine interaction from those metabolites. You can use 60 milligrams a day. You can split that into 2 doses or do less than that if a patient has nausea or any issues taking zinc. Okay, let's go to the next slide. Other super helpful liver support, milk thistle. We love milk thistle seed. We use it all the time for support. And there are so many mechanisms of action that I found in the studies for milk thistle. It has an antioxidant effect. It says it's a toxin blockade at the membrane level, enhanced protein synthesis for liver enzymes. It's anti-inflammatory, it's immune modulating. It has a lot of really great indications. You can do a tincture, you can do capsules. I really like milk thistle seed capsules. They're pretty easy in terms of patient compliance, and they're supportive for a wide range of liver conditions. You can use glutathione, liposomal glutathione, if you're worried about this patient's detox pathway, or you know that these patients tend to be poor metabolizers. Glutathione is a really strong and helpful support for that. You could do a push if you like glutathione pushes, or you can do the liposomal gel caps are my other favorite. Artichoke is wonderful liver support, and I find this to be especially helpful if they also have elevated cholesterol. So patients who are seeking ketamine treatment, need support with the liver, and also have high cholesterol in the background, use artichoke. There's a wide dosing range, 200 to 750 milligrams of the extract. You want to have at least 5% of the active ingredient, even though we know that whole leaf is going to have lots of active ingredients there. Let's go to the next slide. Okay, an absolute contraindication for me and my comfort level working with ketamine is interstitial cystitis. I just have seen too many patients who are coming to me for support with interstitial cystitis. It really reduces a patient's quality of life. It's hard to treat and manage. I don't want to be contributing to that in any way, shape, or form. So that for me is an absolute no. If there's other bladder or kidney issues, like they might have a history of lots of UTIs in their 20s or something like that, not a problem. If they've had a history of kidney or bladder stones, not a problem. I do love marshmallow root powder. And if any patient is telling me about a history of kidney or bladder issues, I'm usually getting that on board right away because it's so safe and gentle. It's a urinary and digestive demulcent. So it soothes and reduces irritation to mucous membranes. I love this. The powder is really mild. It's got a sweet flavor. It's easy to mix into a tea or just, into a little bit of water. I did have trouble finding a lot of studies on this, but I will say, in the Clinician's Handbook of Natural Medicine from 2016, it said it was also beneficial for pain in the bladder. When the seed is used, you can mix it with fenugreek or other medicines as well. And I did also print out a huge European pharmacopoeia document that talks about all the indications for marshmallow root powder. I'm happy to send that to you if you're interested, but I love marshmallow root. And I typically dose 1/4 to 1/2 teaspoon once a day to twice a day. You can increase that if needed. It's really gentle. Next slide, please. Other possible considerations for herbal support for the kidney and the bladder: corn silk, which is a mild diuretic. It also is a urinary demulcent. So you could do a tincture for that, 30 to 60 drops, 2 to 4 times a day. The next 3, chondroitin sulfate, NAG, and MSM, these are straight from Dr. Kimberly Winstar's notes regarding treatment of interstitial cystitis. And so these are all designed to increase, repair, and heal the GAG, the glycosaminoglycan layer within the bladder lining. And so these are the appropriate dosages based on that document. I also looked up studies. There's studies at the end of this PowerPoint as well. The only thing that I'll note is that the MSM powder or caps is 1 to 12 grams. That's a huge dosing range. Most people are not going to comply with higher doses of MSM alone. And so I start them with 1 and then increase it slowly from there. I sometimes notice that people will get headaches from taking too high of MSM powder doses. But again, these are preventative. These are treatments for bladder irritation, interstitial cystitis, which is very similar to the ketamine cystitis that we've seen in studies. Okay, let's go to the next slide. All right, so let's talk about enhancing the cognitive benefits of ketamine. Like if we're treating mood disorders, we're treating chronic anxiety and depression, we want to enhance those benefits as much as we can, and we have tools to do that. So we know that ketamine itself rapidly crosses the blood-brain barrier, which is what we want to lay down those new synaptic connections in the neurons themselves. And so we can use my top favorite is ginkgo. Ginkgo enhances, according to studies, enhances global cerebral blood flow in the brain. You can use it in a tincture, capsules, liquid, phytocaps. However you can get a patient to take ginkgo is a great idea. And we'll talk a little bit about how ginkgo is metabolized later on, because that is something to consider as well. But when I learned ginkgo as an herbal medicine treatment, it enhances microcirculation in the brain, which is exactly what we want. We want that ketamine to get as far as possible, to be as far reaching as possible within the brain. So we give the patient the best chance to improve their mood. Also love lion's mane. So we know that lion's mane increases NGF, or nerve growth factor, and stimulates neurite outgrowth as well. I typically use the whole mushroom, like powdered whole mushroom capsules. 1 to 2 grams is the studied dose. There's a brand on Fullscript that I use all the time. It's really great. So lion's mane mushroom is awesome. Bacopa is another neurotropic medication that herbal supplement that we use all the time. Also has been studied to increase cerebral blood flow, memory enhancement, and neurotransmitter modulation. There's a dose range there of 200 to 600 milligrams per day. Let's go to the next slide. Okay, so we know that ginkgo, this is a clinical pearl, is a CYP3A4 inducer, meaning it makes that enzyme work a little bit more effectively. So this is going to upregulate the enzyme efficiency. Ketamine is largely metabolized by this particular enzyme. So you may need to slightly increase or alter your ketamine dosage if you also have your patient taking high doses of ginkgo at the same time. I haven't really done this. I'm thinking about my dosing more from what our overall goals are for the patient, but I do take this into account. It's something that's sort of in the background if I'm giving a patient ginkgo at the same time as their ketamine treatment. Okay, let's go to the next slide. Anxiety management, this is really important. I found, especially when working with patients with macro doses of ketamine, so either psycholytic or psychedelic dosing, that there's a lot of anxiety about going into an altered state of consciousness. For patients with anxiety, it's a lot about letting go of control, loosening that sense of control. So anything that we can do to reduce that initial threshold or barrier to them being able to access ketamine treatment at these dose ranges is worth doing. Also, patients are often taking benzodiazepines. And so how can we use our medicine to help reduce the frequency and levels of dosing for those benzos, which we know are addictive and hard to come off of? So here's a few ideas. I love Leonoris. It has a cardiovascular benefit. It's anti-anginal and anti-arrhythmic. It's also a potent antioxidant. And there's a potential neurological mechanism for Leonoris, or motherwort, which is based on the GABA A-type receptor. So not totally well understood or well studied why this has the anxiolytic effect, but we think it has something to do with GABA. Lemon balm, also the mood and anxiolytic effects of lemon balm may be attributable to the GABA A-type receptors. Also, another proposed mechanism of action is the cholinergic, nicotinic, and muscarinic receptor binding. So it calms, reduces anxiety, but there's not a lot of consistent findings in that in terms of the studies. Chamomile, a number of animal and human studies suggest that chamomile has several flavonoids that may exert their psychotropic effects via neuromodulation. So we know from hundreds, thousands of years of clinical experience by healers who've used chamomile that this is effective for anxiety. We use it in children, we use it in adults, and they don't really have a clear mechanism of action, but that's sort of the flavonoids are what's thought to be the main source of action at this point. Finally, we have passion flower. Love this medicine also, especially helpful for patients with anxiety around sleep. I use this a lot for patients to relax in the evening or at night. You can do a tincture, you can do a tea, you can do gel caps as well. And the main mechanism of action for passion flower, passiflora, is also the GABA A receptor. Okay, next slide, please. So chamomile, passion flower, motherwort, and lemon balm are all very gentle medicines. They can be used the day of a ketamine session to help reduce or minimize anxiety, anticipatory anxiety about going into an altered state of consciousness. You can also use benzos. There's a lot of discussion from different providers about whether or not that's a good idea or bad idea. They call ketamine with benzos like ketamine with floaties. I think that I've definitely had the experience of a patient maybe using that for the first time, using a benzodiazepine just to really get the lay of the land in an altered state of consciousness. But if we can avoid it, I think that it's better in terms of their clinical outcomes with ketamine. Sometimes these herbal medicines can take the place of benzos on the day of treatment, so feel free to use these. Next slide, please. How are we doing on time?
We have about 4 more minutes. If we can wrap it up in 4 minutes, that would be great.
Got it. Okay. All right. So herb drug interactions. There is limited evidence or information available on potential drug herb interactions with ketamine. There's a lot of great information about drug interactions with ketamine from 50 plus years of clinical experience for it being used as an anesthetic. So I did some research. We do see that there are some herbs which have been studied to induce CYP3A4. Common valerian and ginkgo are two of those. If they're inducers, it means they're going to make that enzyme work a little more efficiently. You might want to slightly increase your dose of ketamine in order to compensate for that effect. Next slide, please. Okay. There is limited information available on, okay, we already talked about that. Sorry about that. So bicolin has been studied. So this would be like Scutellaria bicolensis or Scutellaria lateriflora. Both have this active ingredient, and it's known to induce the CYP2B6 enzyme. So again, this is an inducer. You might want to slightly increase your dose of ketamine in order to compensate for that. And the study is below right there. Let's go to the next slide. We want to be more careful with drugs that inhibit CYP3A4. We know that grapefruit does that. And then there was a really interesting article that looked at all different kinds of herbal medicines, and 3 herbs that are largely known to inhibit CYP3A4 are horse chestnut, echinacea, and common sage. Let's go to the next slide, please. Okay, St. John's wort. This is such a tricky medicine. We know that at some dosage ranges, it will induce CYP3A4, but at higher doses, it may also inhibit. There are a million reasons why I don't use St. John's wort at physiologic doses in patients with mood disorders in general. I think we should just use this medicine in drop dosing for its emotional and energetic qualities, use a homeopathic of St. John's wort instead. But doing physiologic dosing, it gets complicated and messy, and we want to make this as clean and effective for your patients as possible. Let's go to the next slide, please. Okay, so let's talk about potential drug supplement interactions. There is a possible synergistic effect of ketamine with lithium carbonate, so pharmaceutical grade lithium. This is being studied for possible synergistic effects with the NMDA receptor mechanism of action. It's complicated, there's not a lot, but let's go to the next slide. But what I want to say about this is that some practitioners are using lithium orotate to treat anxiety. This is the kind of lithium that we find in hot springs and things like that. Some patients are using it for bipolar treatment or for anxiety. It's much lower and less potent and less concentrated than pharmaceutical lithium. So all I can say definitively is that it does not appear that the supplementation of lithium orotate for anxiety or bipolar disorder is contraindicated with ketamine at this time. I can't say that there's a synergistic effect. There's just not enough research that's been done to support that, but I did want to bring that up. Let's go to the next slide. Okay, medication sourcing and storage. We can kind of like tear through these slides because we've already gone over quite a bit of it. But for troches, rapid dissolve tablets, nasal spray, or topical, go through a compounding pharmacy. Not all of the compounding pharmacies will offer all of these options. It's typically inexpensive, $40 to $60 per treatment pack, depending on how you're dosing and what is the route of administration. Some compounding pharmacies will price match, so always ask about that. Some compounding pharmacies will ship directly to patients, which is really convenient. Let's go to the next slide. So I think this is one of the most important clinical pearls that I can present to you all, which is to try and really remember what role you are taking on for this patient. Are you solely a prescribing physician for microdosing of ketamine? Are you a prescribing physician for moderate psychedelic or psycholytic dosing? If so, does the patient have a counselor that's doing some of that deep process work or integration work? Knowing your role in the provider process is going to change how you prescribe. Are you seeing them every 2 weeks or once every 2 months? This is because this is a controlled substance and we know there's abuse potential. It's important to be thinking about that ahead of time. What role are you taking on? And if you take on a role but want to switch, and let's say you start with microdosing and then move to psychedelic dosing, how is that going to change your overall treatment plan for this patient? Okay, next slide, please. I think it's really important to develop a relationship with a trusted pharmacist and or pharmacy so that you can ask them all of the questions. They can really help you troubleshoot challenging patient cases. They add an additional layer of protection to your practice, because if they get used to how you typically do things or prescribe things or call things in, and something that's out of the ordinary comes up, they're going to call you and let you know. And so you definitely want to make sure that you have a really strong relationship that you can call anytime. And if their customer service isn't great, find a new pharmacy, because there are really good ones out there. Okay, next slide, please. Sourcing for IM and IV ketamine, this is really tricky right now. This is not available at your local compounding pharmacy typically. It has to go through usually a large online supplier of ketamine, like Henry Schein or McKesson or McGuff Medical. Right now, there is a shortage of IV and IM ketamine, and so it's kind of spotty if you're able to access it or not. Typically, it costs between $120 and $200 for a tray of ketamine vials, and some trays are 10 vials, some trays are 25, but you'll need to get a different source for that medication. Let's go to the next slide. More than anything, the storage considerations are very important. Dr. Cindy alluded to this, where if you decide to have a controlled substance in your office, you need to make sure that you're tracking when that medication comes in, how much you're carrying, how much is being used. It has to be locked up appropriately. There's specific guidelines from the DEA on how to do that. If you're giving patients a microdose or having them use ketamine at home, you want to have a really clear discussion about them locking it away from children and pets in the home to reduce the potential for abuse and the potential for access or harm to other people. Okay, next slide, please. Okay, a clinical pearl. Try to create handouts that provide specific instructions for how patients should store and use their medication at home. The pharmacy is also wonderful about this too. They'll give the patient very clear instructions about whether it should be refrigerated or how to reconstitute it if it gets crystallized, things like that. But make sure you know what you're telling patients. You have a handout in their chart. You have something you can give them in office or email them. And just document that you are having this conversation about safety and harm reduction with your patients. Okay, next slide, please. DEA requires controlled substances have at least 2 differently keyed locks at all times. If your medication lockbox weighs less than 750 pounds, it must be bolted to the wall or to the floor. If they're combination locks versus key locks, you have to have as few people with access to that combination as possible. And you have to have a controlled substance log maintained at all times. Next slide, please. Nobody is going to have a 750-pound lockbox in their regular office setting. I think that's really just geared towards hospitals that are going to be storing a lot of medications. So what you need to do is you need to find a small medical lockbox. You can find them online that has 2 different locks with 2 different keys, and then you need to bolt it to the door, preferably somewhere out of sight where it's not super obvious. If someone were to come into your clinic or break in or something like that, where it wouldn't be the first thing that they see. It should be hidden away if possible. Then you can purchase an additional small mobile lockbox, and you keep the keys for the lockbox that's bolted to the door in that little one. And that one has a combination or a different lock. So you have 2 levels of protection in addition to the lock that you just have on your regular office door. So that provides 3 levels of locked protection for your controlled substances in an office setting. Okay, next slide. Okay, let's see. This just talks about diversion control. So it's meant to prevent, detect, and investigate diversion of controlled substances, basically to reduce any loss or abuse potential for medications. There's nothing too important on that slide. Let's go to the next slide, please. Diversion control means anything that you can do to help reduce the possibility of misuse, theft, or loss of the controlled substance. So you minimize the amount of medicine you keep in office, you reduce the number of troches or rapid dissolve tablets that each patient has and each refill, and you write down the date of each refill or track with the pharmacy to make sure that they're not being refilled too soon. Okay, whew, we made it. I know that was super, super fast. I have lots of resources. So if you just scroll through, there's links and links and links and links and links all day long. Lots of additional resources for you. If you want to reach out to me, I would absolutely love to collaborate, to communicate, to answer questions. I have 2 of my websites here, and you can just reach out via the contact page, or you'll see an email address on there as well. Thank you so much, everybody.
What a detailed presentation, Dr. Wilkinson. Thank you for sharing some very practical insight to help naturopaths embrace ketamine within their practice. We are now entering the ethics portion of our presentation today. Dr. Rakesh Jain will be walking us through protecting the emotional safety of the patient. He will also be touching on the Kyra Institute ethical guidelines for ketamine practitioners and continuing education for ketamine therapy and the importance of that role. Thank you so much, Dr. Jain. We look forward to your presentation.
Hello, dear colleagues. It's a genuine pleasure to be with you today to talk about several things that I have collated into special topics in ketamine therapy. Who am I? My name is Rakesh Jain, and I'm a clinical professor of psychiatry at the Texas Tech University School of Medicine in Permian Basin. I am also in private practice. And just like you, I have a profound and deep interest, not just in ketamine therapy, but for the betterment of our fellow human beings who suffer from a variety of psychiatric disorders. But ketamine therapy has some extra complexities to it, and that is the reason why I'm looking forward to having this conversation with you. The topics I will briefly cover today start from the basics of bioethics. We will then focus on the Kriya Institute ethical guidelines for ketamine practitioners. And then we will have a pretty deep conversation about how to protect the emotional safety of patients, focusing on preparation, conducting of the session, integration, thinking about what is this issue about the power dynamics being so specific in non-ordinary states of consciousness therapy, which includes ketamine. And then, of course, we will talk about how to continue our education in ketamine sciences and ketamine therapy. Pretty good agenda, don't you think? We'll spend about 45 minutes together. But before we can go any further, it would be very important for me to remind you that all of us practitioners, all of us licensed practitioners, do work in the context of the legal system. And laws, in the very first place, get created because of tensions or conflicts that have occurred or other challenges that have occurred in society, and they are societal rules. And all of us are guided by our societal rules, both at the federal level, the state level, the local level, and they are obligatory. And we should, of course, be observing them. We should also be reminiscent and remind ourselves that laws are there to protect the welfare and safety of lots of important constituents, such as society, of course, patients, but patients are part of society, but they also are there to help us deal with conflicts, and these laws are constantly evolving. And because ketamine therapies are relatively new, these laws are rapidly evolving, and laws have governed the practice of medicine, not forever, but for about 100 years or so. And when it comes to ketamine, the evolution is actually rapid. There is, however, a difference between law and ethics and morality, and we should perhaps talk about that very briefly. Ethics are a set of moral principles and a code for behavior that's governed by an individual's action. But the action between individuals and within society, morality is something different. Morality is what people believe to be right and good, while ethics is a critical reflection about morality. So a good human being, a good clinician, knows the laws of the land, has strong ethics and strong morality, obviously. Bioethics, slightly different again. It refers to the moral issues and problems that have arisen as a result of the major advances in modern medicine and medical research. Ketamine would be a very good example. All of these changes with ketamine have occurred in the very recent past. And these ethical, bioethical principles apply upon us through societies. So it could be a professional society, could be the legal system, but it can also be an organizational, institutional set of bioethics. And comparing law and ethics, what we need to remember, there are differences, but there are also overlapping areas of interest. Laws are mandatory. They're pretty clearly written out, and all citizens, including healthcare providers, should adhere to them or face consequences. Ethics are a bit different. They relate to morals and help us organize complex information and competing values and interests so that we can formulate consistent and coherent decisions. Now, this can change over time. With ketamine, for example, it's been very rapidly changing. But we should not use the fact that it's rapidly changing to obviously overpressure the system or conduct ourselves in such a way that others can rightfully accuse us of having violated laws or ethics or morality. In terms of cultural diversity and ethics, there is thankfully a greater recognition and a societal and personal interest for better understanding of cultural diversity and how that applies to ethics. So we really have to be mindful in all work we do, including non-ordinary states of consciousness, which is what ketamine often is, not always, but often is, to be aware of such issues. And contemporary bioethical principles are all derived from, directly or indirectly, from the principle that governs the American society of autonomy. Within the world, no two people are exactly alike. Therefore, the values of both the clinician, the patient, the system under which they operate really may be different, but at the core of it, making sure that we're addressing the legal aspects, the bioethical aspects of all decisions we make is, of course, the right way to practice anything that relates to ketamine. So let's talk about ethical principles. This will be a brief review for us because most of us have been exposed to this. We do know and accept that conflict is inevitable. It is. Ethical principles, however, do provide the framework and the tools which facilitate individuals and societies to resolve conflict in a fair, just, and moral manner. And needless to say, the better prepared we are, of course, the less likelihood of ethical conflicts occurring. So there are 6 ethical principles for us to consider, and let me lay them out for you, and then we will discuss them briefly because these really do apply to us as ketamine practitioners. The first one is autonomy and freedom. Veracity is the second one. Privacy, confidentiality, followed by beneficence, followed by fidelity, and followed by justice. What are we talking about here? And do these 6 ethical principles apply to you? You might be in California, you might be in Texas, you might be a therapist, you might be a prescriber, you might be whatever the case might be, you might be an MD, you might be a nurse practitioner, you might be a naturopath, you might be whatever. Do these principles apply? And the upshot is they apply to all of us. So the first is remembering ethical principle number 1, which is autonomy. It is the right to participate and decide on a course of action without undue influence. And this applies to both our patients and to us. If we're not comfortable with a certain procedure, certain intervention, we have the right to autonomy. But patients really have the true right for self-determination, which is the freedom to act independently. Individual actions are directed towards goals that are exclusive their own. Now, in terms of veracity, this is something that applies to us, of course to patients, but primarily to us, the practitioners. There is a true duty to tell the truth. Now, what is the truth? And the truth is a combination of 3 things, I think. What the literature says, so the science tells us. Number 2 would be guidelines and principles. And the third would be our clinical experience. And in the world of ketamine therapies, there is some concern that veracity is being sacrificed, particularly by some commercial entities. And it is important that we healthcare providers be aware that over advertising, inappropriate advertising, over promising, this is the fix for everything, that kind of stuff, it kind of violates the principle of veracity that applies to the ethical principles all healthcare providers must follow. Regarding privacy and confidentiality, I think by now we are extremely familiar with the concept of patient privacy. This must be protected information in every circumstance. But, in non-ordinary states of consciousness, there might be even more things that come up. As a result, privacy and confidentiality, the respecting of the self of others, is crucially important. And needless to say, the principle of beneficence, is this good for the patient? Is this in the patient's best interests? Or am I just doing it because I think it's the right thing for the patient? But maybe what I'm thinking about is my experience or my expertise, or I'm thinking about just doing a procedure without putting the patient's best interests at heart. That would not be acceptable. The principle of beneficence is crucial because there is an obligation on the clinician to do good and to avoid harm. And that balance between those two is something that not only professional bodies will look at should a complaint be filed against us, but the legal system is also very interested in assessing, did the clinician think about the beneficence of the patient? The principle counsels as a provider to relate to clients in a way that will always be in the best interest of one person, one party only, and that is the client. Fidelity. Fidelity to what? It's a beautiful word, isn't it? Strict observation of the promises and duties that we have, what we have agreed to with the patient, are we executing it? And this principle, as well as other principles, should be honored by both parties, provider and client, but the primary responsibility genuinely falls on the shoulders of the clinician. And that is an agreement we make with our patients. And then finally, we should talk about justice, the principle that deals with fairness, equity, and equality, and provides for an individual to claim that to which they are entitled. So what is a clinician entitled to? What is a patient entitled to? What they're entitled to is what has been agreed to by the clinician and the patient. What they are entitled to is the full-on attention and respect from the clinician. And the principle of justice genuinely is one of the foundational principles of the ethical principles that should guide every clinician, no matter what we do. But if anything, it may apply even more so to that clinician who wants to practice with ketamine. But why must we employ ethical principles beyond the simple obvious? Number one is because we respect the individual. In our healthcare system, patients are the whole reason for our existence. That's actually not true in every country, but in ours it most certainly is. We do have a pluralistic society, but individuals can often misunderstand each other. So having this guiding principle that this is really about your needs, dear patient, really is helpful in lots of contexts. And while there may be disagreement, there's no disagreement about that particular issue. And how do we go about creating an understanding and agreement with the patient and with the system under which we work? So first of all, we have to create a set of rules that we might call common ground rules. This is most often done with informed consent. And informed consent should, of course, be written, but often there are elements of informed consent that simply cannot be written. They're however, discussed. But that discussion must be documented. It's really important that documentation in the work we do with ketamine be appreciated as highly important for the protection of the patient, but also the protection of the clinician. So as a function of ethics in our society, making agreements, as I just described to you, both the formal, the informal, but still documented, is very important. And as healthcare professionals and patients meet, they meet really in the very beginning as strangers from different backgrounds. They may be speaking very different languages. And I don't mean this language. I mean the contextual language, the understanding language. Therefore, coming to a unified agreement is very, very important in everything we do. But I'll say this again. With ketamine work, all our responsibilities, all of them, are still present, but they're heightened. We have to perhaps be even better at obtaining informed consent, perhaps even better at offering psychoeducation, perhaps be even better at every single element of the ethical world that we live in, because I can't think of a more scrutinized area of work I do, and I'm a psychiatrist, than the work I do with ketamine. So creating harmony, it's difficult sometimes, but it is crucial. And the harmonization is between the clinician, the patient, but sometimes it's between clinician, patient, and the support system. If there's an active support system, to have them understand what we're doing is crucial. But sometimes it's also the setting we work in. For example, I know of emergency room clinicians who are true believers in ketamine work, and they want to give ketamine to every patient who walks into their doors who has suicidality or chronic pain in an emergency room. However, the emergency room perhaps may not see the use of ketamine in that context as appropriate. And it would be inappropriate for the clinician to go against the wishes of the organization, because that's, the shortest way to end your career and to get into perhaps ethical trouble, perhaps disciplinary trouble. Now you see why this creation of harmony within a system, within a society, between patients and their clinicians is of crucial importance. And I'll lay out for you some items to consider. There are sometimes differences in power and self-esteem and communication and personality and attitude that can really create trouble with harmony. Education level can be very different. For example, the context I just used, the emergency room may be under the guidance of an internist. The disciplinary committee of the hospital may be under the guidance of an internist. Now, the emergency room itself may be run by emergency room doctors and nurse practitioners, etc., etc. But even though they all have similar education, they may have very dissimilar education about, say, non-ordinary states of consciousness. Therefore, being cognizant of that and giving that attention is, of course, important. Culture. In some cultures, for example, having a non-ordinary state of consciousness may potentially be seen as a challenging experience and to be avoided. It's possible. It's also possible that a patient may not really desire that, even though you think it's the best thing for them in the context of the disease they suffer. So again, harmonization is crucial with everything you and I will do as it relates to ketamine work. So how may harmony be achieved in our context? And I think if we just go back to the basics, think about the ethical principles and behaviors we just talked about. If we follow that, if we follow those particular rules, it actually is a beautiful roadmap to get into the process of harmonization. Which doesn't mean we will get exactly what we want, or it'll be exactly what we think is right, but it will be, if we go through the process of harmonization, the best that could be achieved in that particular context. So it serves to make it possible for us professionals to deal with each other at a human level with respect across all disciplines, helps us interact with our patients of all types in a manner that is best serving to their needs. And finally, I will remind you that to make it possible for professionals and clients to deal with each other at a human level, these ethical principles really make it possible. They make it possible no matter which environment we are in. It could be an outpatient practice, inpatient practice. It could be a naturopath's clinic. It could be a family practitioner's clinic. It could be an addiction clinic. It doesn't matter. These are basic human principles, and it makes it possible for strangers, and we are strangers when we meet our patients for the very first time. It is possible for us to achieve understanding, and if full agreement is not reached, at least tolerance for each other's beliefs is achievable before a final agreement is hammered out. I do want to remind you, just because we're doing ketamine work, obviously doesn't in any ways negate the great importance of HIPAA. HIPAA fully applies, obviously. If anything, if you are at a grade 1, you're the top level HIPAA rule follower, it's not a bad idea for you to become a 1+ level HIPAA compliant clinician. Ketamine work is incredibly valuable. It's very fulfilling. It can also be a situation where a clinician who's not protective of themselves could potentially run into significant trouble, because non-ordinary states of consciousness can lead to certain sets of challenges. And if you followed the rules, all rules, and that HIPAA is, of course, one of the rules that you and I are mandated to follow, it just protects us. So just one strong plug that HIPAA rules apply and must be followed, and must be followed very, very thoroughly. This applies to all healthcare providers. We're all accountable for non-consented release of medical information. Let's be very careful. Documentation, documentation, documentation. And healthcare providers are responsible. So if you are a ketamine prescribing clinician, you, and by the same corollary, I am responsible for hiring and educating other folks who are involved in the care of the patient, and they are required to be knowledgeable about HIPAA rules and regulations that govern the privacy and security of the medical records. Let's put this all together before we leave this section, okay? So there's a wonderful model called the Husted's Formal Ethical Decision-Making Model, and I very much encourage you to please consider this as your North Star as you embark on this journey towards becoming a top-flight ketamine provider, which is to please remember the principles of autonomy, freedom, privacy, fidelity, beneficence, veracity must all be applied at all times when we work with our patients. Now, context, situation knowledge may alter some of the decision making, but almost none of us online today, connected today, are going to be using ketamine in a life or death emergency room situation. I think primarily our use will be in the context of the treatment of patients with specific psychiatric disorders, specific chronic pain disorders, or a combination thereof. In those situations, you and I have zero excuses, zero that I can think of, where we would not leverage the power of the ethical principles given to us by following the principles of autonomy, patient freedom, patient privacy, our responsibilities for full fidelity, beneficence, and honesty. Over-promising, sadly, has become part of the nomenclature of perhaps over-enthusiastic ketamine providers. I have no trouble with enthusiasm. In fact, I think enthusiasm is the missing catalyst of what we do in clinical practice, but over-enthusiasm, not based in logic, not based in data, but just wishful thinking or our own personal belief, based perhaps on our own psychedelic experiences, is not veracity. It can be construed by the world as overpromising and false advertising. And at the end of the day, it not only will harm you in terms of your relationship with future patients, it will harm the entire field. So if I make mistakes, you, no matter how many hundreds of miles you're sitting away from me, one way or another, you could also face the consequences of that. That's just the way it is, right? And the same is true if you don't follow these particular rules. And of course, context, situation, knowledge ultimately does help us get to the right decision. And sometimes the right decision is to not agree to do ketamine work. And that's okay. That's okay in the right context. There are situations where you would say no. Though, of course, in the majority of situations, when you follow these principles, your diagnostic process has been solid, the patient is appropriate, you have full trust in the patient has trust in you, all the stars have aligned, and of course, that is indeed the way to go. So with that, I would like to transition a little bit. I want to talk about the KRIA guidelines. Now, you might wonder what the heck KRIA is. And KRIA is an organization created by a psychologist, Raquel Bennett. And she's a well-known figure in the world of ketamine. Quite likely you know her. She has, over the years, had a regular meeting of experts in ketamine and also non-experts, people who want to become experts. And she and Dr. Ryan's a psychiatrist, Dr. Bennett's a psychologist, they came together and they've created a set of very useful guidelines. They're called the KRIA Ketamine Practitioner Guidelines. They were published in the Journal of Psychedelic Psychiatry in 2020, and I'll briefly cover it in the next couple of minutes. There's some good pearls of wisdom here. So first things first, the ethical ketamine clinician recognizes that it's a psychoactive medicine. It's powerful. Not always. If you dose it low, it's not a psychoactive medicine. It can be used without its psychoactive properties, but just keep that in mind. It can have prominent dissociative and psychedelic properties, and we must appreciate this requires specialized psychological care before, during, and after receiving ketamine. Very, very important. We'll talk more about how, if you don't have a great deal of training or expertise in psychological sciences, how you still can be a very effective ketamine provider. The KRIA guidelines are very critical, as they should be, about a minority of clinics. And folks, you never want to be one of those where you offer these package deals that almost sounds like a deal more than a package. You never want to overrepresent or grossly misrepresent treatment. Ketamine is not effective for everybody. Even in the best of situations, it's effective for 2 out of 3 human beings with a well-defined psychiatric diagnosis. And there's no shame in admitting to that. But unsubstantiated, exaggerated claims about efficacy are not supported by any guidelines, including the KRIA guidelines. And such abuses are actually quite prevalent. I urge you, you do not need to go down that road. It's not necessary for you to build a very successful ketamine practice that helps the patients, and it is something that you wish to do. Here's the third thing that we need to keep in mind, that the ethical ketamine clinician recognizes there are many different approaches to ketamine treatment. Some of it may be fairly high dose, middle dose, low dose. There might be zero psychedelic experiences by the patient because that's what you're aiming for. You might be giving it once every 5 weeks. You might be giving it once a day. There are multiple ways to do it. But the ketamine clinician needs to know that this is a potentially abusable medication. It's actually Schedule 3, and therefore this clinician is extremely aware of different routes of administration, different dosing strategies, different conceptual paradigms. Must be. And you do not want to learn this on the fly. You want to know it before you get to your very first patient. Additionally, the integrative care of this patient is very important. We'll be talking about that more in detail in a second or two. That the psychiatric and psychological care of the patients must be addressed. Not just because they came in with those challenges, but sometimes because ketamine itself can be the provocateur of memories that were suppressed for very long, or emergence of suicidality. I know we often think about ketamine as an anti-suicide agent because it is. In many situations, there's plenty of data to support that. But some patients, it can actually rebound. We'll be again talking about that a little bit. It's very important, really important, that you and I not see ourselves as the only system the patient has in order to get better. We are nothing but one part of the entire panel of experts a patient should have the right to access if that's what's necessary. And I think this is one of the best things about the KRIA guidelines. The ethical ketamine clinician practices within the scope of their professional license. Stay in your lane, and your lane is plenty wide. Do not go outside your lane. That's the recommendation, and I wholeheartedly support it. Now, does that mean an emergency room clinician cannot give ketamine. No, that's not what I'm saying at all. What I'm saying is, if your lane is, say, to not be a prescriber, to be involved in the prescribing would be inappropriate. If you are a prescriber, and for example, you do not have the training, like me, I don't have the training on, I used to, but I've forgotten most of it, about how to manage a compromised airway. So for me to use ketamine in a way that could lead to respiratory difficulties is straying out of my lane. That would be inappropriate, right? So you will have to kind of know, based on the standards that are set in your community, by your organization, what is your lane? What does your state say? What are the guidelines say? And stay in that lane, because the lane is plenty wide enough. And if there are things the patient needs that are not within your lane, there are plenty of people who can help that particular individual. Don't stray outside your lane. It's not because I'm asking you not to be brave. That's not what I'm saying. I think I'm asking you to be wise. And wisdom requires knowing what our lanes are. And we all, by the way, have lanes, all of us. And to stick to them is what the KRIA guidelines are recommending. And of course, we have lots of responsibilities towards our professional license, and ketamine doesn't change any of that. So getting good informed consent, good record keeping, professional boundaries. There have already been some situations, you know them, about patients while they're under the effects of a psychedelic experience and clinicians taking advantage of that. That would lead to, understandably and appropriately, a lot of trouble with the clinician who does that. So we'll have to be very cautious about that. Confidentiality must be maintained, and of course, general professional conduct. I know you're saying, oh my God, this is all basic, but you'd be surprised how many people are forgetting these basics when it comes to ketamine work. And you and I don't want to go down that road whatsoever. Let's be honest, let's be transparent in all things we do, which includes marketing, but also includes conversation with patients and with colleagues. If you are talking about your ketamine services to, I don't know, your closest 5 practitioners in the community you live in, I so hope you don't say it's the next miraculous thing, because all that'll lead to is challenges. As I said, and that's what the KRIA guidelines say, let's be ethical. And ethical requires us to follow the rules of truthfulness and veracity. Okay, so those are the guidelines. I hope I didn't come across as lectury on it. That was not my goal at all. I'm hoping the way I come across to you is offering you good advice and hopefully lots of enthusiasm. You are on the right track. You're doing the right thing by wanting to get educated about ketamine and therapies that surround it. But it's really important to be careful and follow quite a few guidelines. And non-ordinary states of consciousness can expand the risks for the patient and for us. Hence, even more cautiousness would be a terrific thing. Okay, in the next 20 minutes, I'm going to talk to you about how to protect the emotional safety of the patient. That is always the case with any treatments we offer, but I gotta tell you, ketamine just exaggerates these issues. So we'll talk about preparation, conducting the session, integration. We'll talk about the power dynamics do change vastly during a ketamine session. Patient often is psychologically and physically far more vulnerable than they are in a typical interaction with a patient. And that needs to be kept in mind. And of course, coordination of care with other specialties. I do want to tell you, working with non-ordinary states of consciousness is like nothing else I do in my professional life. It just is very different. It just is. Is it a wonderful experience? Yeah, it is. But it does require me to be absolutely on top of my game. And if I was you, draw on multiple models of care. What did you train in? And the odds are you were trained in some model or some models. Medical model? Absolutely. Biopsychosocial model? By all means. But there are probably other models that you're a believer in. Mindfulness-based interventions, maybe MBCT. maybe Buddhist philosophies that are very close to you. That's fine. Bring that to the game when you're dealing with non-ordinary states of consciousness. Psychodynamic therapy, internal family systems. This has become extremely popular for all the right reasons, as well as acceptance and commitment therapy. All appropriate. But if I was you, get some training. You probably already have, but you haven't. Please seek some training. Now, my colleagues and you will be having a live Q&A. I won't be with you. This is a recorded presentation primarily because, well, my mother-in-law is under hospice care and expected to transition maybe today or tomorrow. And this is sometime in the middle of February, so I just could not commit to physically being with you live. But having said that, the questions that I'm raising and the issues I'm raising, if you have questions, make sure you ask of my colleagues. It'll be very important for you to know which highly rated psychedelic assisted psychotherapy programs exist, and should you take part in them or not. And the answer I think you're going to hear from them is you gotta do it. And even with all the years of experience I have, I'm kind of considered, just because I've been doing it for a while, perhaps as an established therapist, but I don't feel that way. And I'm glad I don't feel that way. What I feel like is I am in a learner's mind. This is a non-ordinary states of consciousness is an absolutely ridiculously amazing experience from the other end as a clinician. So I guess what I'm saying is get more training, and whatever you brought to the table based on your own personal and professional experiences, it's going to serve you well. It is very important to have a attitudinal orientation towards non-ordinary states of consciousness. And this is quite different than, say, for example, CBT, cognitive behavior therapy. It's very different from interpersonal therapy or other forms of therapy, where having a judgment about what the patient's thinking and saying is actually required so that you can move the patient in the right direction. But with non-ordinary states of consciousness, you really want to have an attitude of non-judgmentalness, open curiosity to whatever the patient experiences. If they took a trip around the moon, that's fine. Open attitude. If they were buried under the ground 6 feet and worms were eating them, if that's what happened in the non-ordinary states of consciousness, guess what? Non-judgmental attitude, open curiosity is what we have, and we request that. We educate our patients to have exactly the same. This is absolutely different from anything else, any other kind of therapeutic modality that I've been trained in. So if you want to put it into a bullet form, there's 3 things that I think are very helpful when working with patients with non-ordinary states of consciousness, and actually does protect them, which is to have a non-directive approach. Don't tell them, did you die? Did you have a life-changing experience? Those would be not non-directive. They'd be incredibly directive. Having a non-directive, gentle approach of inquiry, followed by a real strong recommendation to the patient, follow the inner directive approach. So in terms of preparation and conducting the session and integration, those are indeed the 3 steps. It's very useful to conceptualize it that way, that I am with my patient, and maybe even educate the patient that we will follow 3 steps. We'll go through a preparation stage, there will be an experience stage. Now, I will contextualize this by reminding you, much of ketamine therapy is designed not to be psychedelic. And very likely, Dr. Lucinda Grande will be talking with you in depth about that approach. Psychedelic experiences don't happen with that particular approach, which doesn't diminish whatsoever the value of ketamine. It just is a different way to do it. And then, of course, integration. So what is preparation? Here, we proactively discuss with the patient the meaning. What might be the meaning of psychedelic experiences? Which approach we're going to be taking? What is the attitudinal approach we will have? What is this gentle inquiry? What is this inner work? And patients may be completely unused to that. They may be so used to, in fact, they may think you're going to tell them what they should experience and how that's going to benefit them. So judging how the patient reacts to is very important. Getting a sense of motivation and knowledge of the patient. And here I gotta caution you, sometimes it's in a very different direction. They may have read Michael Pollan's book and come in so enthused that it's almost false information. So sometimes it's not elevating the patient's motivation and knowledge. Sometimes it's also putting it into the right context. Sometimes that can be as important too. So customized to each client and the support system. I will keep saying support system because often when we ignore the support system's importance, we end up harming the patient. Because now the patient has to deal with their own support system, a supportive or non-supportive spouse, a supportive or non-supportive circle of friends, whatever the case might be. It's really important we know the patient's social environment. And don't hurry the step. Don't. If you don't feel the patient is ready for ketamine therapy, don't start it. You want to make sure the patient is prepared. Gentle, slow down, be present is a good way to do it. And then, as I've said before, please do consider, I do that all the time. And every time I stray, I really have to kind of have a talk with myself. Why don't you stay in your own lane, Rakesh? Your lane is plenty wide. Why do you have to go outside it? So please do consider working within the scope of your own practice, your own knowledge, and your own comfort zone. Don't overdo it. Don't overdo it. Don't expose yourself to regulatory action. It usually takes one single regulatory action before the clinician will completely say, I'm not doing this again. And then the whole community suffers as a result. So our lane, may I say that for a third time? No matter which lane you have, it's pretty wide. You do not need to stray. And keep a person-centered and a non-judgmental approach. Easier said than done. Let me be truthful. But knowing that's our guiding principle, that's our North Star, that is what we are aiming for, really does help. Give me, if I'm your patient, ample information about potential risks or benefits. You do not need to sell this to me. You do not need to, under-report the potential problems I may have. There's no reason for it. I have every right, and you actually have an obligation to be fair balanced. Remember, beneficence, fidelity, veracity are our guiding principles. And psychedelics are non-specific amplifiers. So if you have brought the patient in very well prepared, maybe a little afraid but prepared, maybe a little bit afraid but ready to surrender, maybe a little bit afraid but has a non-judgmental attitude, maybe a little bit afraid but curious and trusting of you, guess what ketamine will do at psychedelic doses? Amplify it. What if it's the other way around? The patient feels they were not prepared, not educated, you are distracted, you are hurried, whatever it might be. Whatever it is, patients are very good at reading us. That's also amplified. So please remember, we are important, probably more important in the context of non-ordinary states of consciousness therapy than if I was just to give you a prescription of Prozac. So please keep that in mind. And the importance of set and setting is incredible. Also, tool up the patient. This is a great phrase I've just learned recently. What the heck is tooling up? So this is a wonderful paper. If I was you, read this paper. This is Gorman and colleagues. It is freely available. You do not have, there's no paywall. You can access it immediately. And you will see me quote this paper extensively for the next several slides because it's so incredible. So Ingmar, Gorman, Elizabeth Nielsen, and their colleagues write the following. As with any trauma, equipping the patient with appropriate self-regulatory tools in advance can make all the difference. Now, this is not to say, patient, fix yourself before you come to ketamine therapy, but to know that there are tools. The tools could be breath work. The tools could be, surrender. The tools could be an attitude of inquiry, could be the tools of observation without reaction, which of course is mindfulness. All of these tools will profoundly help us serve our patient. before and after. Please remember this one. And manage expectations, which is not to say let's lower their expectations or raise their expectations. It only means manage their expectations. Teach them. Open, continuous dialogue is necessary. Ketamine is, at the moment, highly overhyped. You know this because you've opened up your computer and checked out what your colleagues are saying. There's a little too much. There's a certain part of the press, Vice News, for example, regularly has articles about ketamine changed my life. Next issue is ketamine. I've become addicted to it. I can't get off it. It's the press. It's its job to overhype issues. Our job is to be aware of it and to take the middle road. Managing expectations is very crucially important. Please keep in mind patients are vulnerable during treatment sessions. During treatment sessions, good preparation, good setting. How beautiful is your office? How calm is your office? How does your front office look like? How welcoming are you? How welcoming is the staff? Are you rushing the patient? Is the patient allowed time to recover? That active, calm presence, gorgeous. Any clinician who's able to execute that is a clinician who should be worthy, if you will, of doing non-ordinary states of consciousness work. And of course, having a conversation proactively about therapeutic touch. Therapeutic touch is crucial, and it's a good idea to discuss it. It's not a good idea. I think it's a mandatory idea to discuss it, to say, if you do feel like you want to hold my hand, will you just reach out? If I see you under distress, may I touch your right foot? Things of that sort. And also discussing that certain kinds of touch would not be appropriate during the session, though that conversation needs to happen. And the ability to compassionately handle emergence of strong emotions. If you have a patient who is crying, rocking, screaming, thrashing, better have those skills thought out before you go into it, because the first 2 or 3 sessions with ketamine you've had with your patients may be this most serene, peaceful event you've ever encountered. The 4th one may not be. So it's a good idea, in order to reduce the vulnerability of the patient, for you and I as clinicians to know that may happen, and that I'm emotionally prepared and otherwise prepared to manage that and handle that. Please have a conversation about therapeutic touch before you start the session, and have flight instructions ready. This has been amazingly helpful. What the heck are flight instructions? Well, when you get on an airplane, what happens? Well, put your seat there and lower blah, 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 and put your seat belt on. These are flight instructions. If you're going to use ketamine in psychedelic doses, please have flight instructions. Have them prepared. May want to write it down or borrow from already written reports on flight instructions. They're easily available on the internet. If you have specific questions on which ones, during Q&A, ask any of my colleagues. They'll be well prepared to be able to answer that. And if you have a ritual, if, for example, you like using a bell, if you like using sage, if you like reciting a particular poem, whatever the ritual may be, make sure you're very comfortable with it, that this is not the first time you're using it, but those rituals can help. It can be very helpful. I have seen one particular psychedelic practitioner almost always put her hand on a patient's shoulder and say something like, surrender. I will take care of your body. You have a wonderful journey, or you have an experience that is your own. Don't worry, I have your body. Now, that may sound like, that is so trite. Of course you have my body. But during non-ordinary states of consciousness, a patient who's experiencing unusual loss of disconnect from the ego, to be somewhat be aware that they are taken care of, their body's taken care of, while they are engaging in a non-ordinary state of consciousness, can be very helpful. So please do consider having flight instructions that work for you. And music, don't you forget about music. Music often has been called a second therapist. Invest in learning more about its use. There are actually formal classes. Use a prepared playlist. There's lots of playlists on Spotify and other places that are specifically geared towards ketamine work, some of them towards sublingual, some of them towards IM, some of them towards IV. It's the most beautiful thing. Invest in equipment, but you don't have to spend much money at all. With just a very few $100s, maybe not even that, you can get a wonderful sound system that works for you and your patient. When discomforts do arise, and they will arise, I promise you this, please don't be anxious. Have your set of competencies. You are a clinician. Have a set of competencies, and those competencies include how to deal with such strong emotions that will emerge with non-judgmental approaches. And here, developing this skill set requires a lifetime. But having said that, the way to start out with is not to be frightened when they emerge and be ready to handle them. And of course, integration work. Be sure to remind the patient and yourself the real work in many ways starts after the ketamine experience. And this integration can emerge in an unfolding, undulating course. It's not immediate. For some it is. For some it can be over days, weeks, and for some it can be over years. And please do not go into the night alone. Do not go into the night alone. If you, for example, are not experiencing EMDR, don't try and do it. If you're not experienced with psychopharmacology or panic attacks, I'm just making that up. Do your ketamine work, but have experts to help you. If you're someone who's not comfortable with doing body work with trauma patients, it's okay. Practice within your own scope and comfort, but do not do it alone. When you bring in other experts, beautiful things can happen. And again, one more time, do not let the distress of a patient be a direct indicator that, oh my God, things did not go well. Sometimes those distressing events is exactly what was necessary at that time. Just be prepared for it to emerge, and please be prepared to manage it as you need to. And then making sure the patient's integration work also addresses it. So it's the mismatch between expectations and the actual psychedelic experience that leads to challenges. When there is a match, and the expectation is openness and acceptance, then as you can imagine, the mismatch is much less reduced. Some patients do have this phenomenon called the afterglow. And the afterglow is a wonderful thing. It's heightened mood and psychological flexibility. There's neuroplasticity, we think, biologically that happens. Encourage the patient that during this afterglow, adopt habits of thinking and doing that ultimately help you. But please be watchful of this concept of sudden wellness and its potential pitfalls. Some people after ketamine therapy may feel such an emergence of knowledge and wisdom that they want to take very abrupt steps to end a marriage, for example, or to fire an employee, or be fired from a job, or quit a job, or move from one state to the other, or I want to move now to Bali and open up a center or a retreat. All of those are wonderful ideas, but what we should do is discourage abrupt shifts. Tell them if this is really what you're called to, it'll still be here in a week or two. Be gentle with yourself. Don't hurry and make changes that possibly you may regret. So the sudden wellness is, while wonderful, you and I as clinicians, as ethical and moral clinicians, need to encourage the patient to watch out a bit. And let's start wrapping up our conversation. Continuing education on ketamine is incredibly important. On a pretty regular basis, I am learning more, and so will you. You're welcome to do at least 3 things I can think of. You can join ASKP, a wonderful organization with a great annual meeting. You might want to start your own special interest group in your professional organization. That's a great idea. And you can, of course, attend CME activities like you are right now. And I'm having the pleasure of talking with you. So finally, in conclusion, practice ethically. Always practice ethically. And not your ethics. It's a combination of your ethics and the ethics that surround each one of us, that society and our organizations tell us. That's the totality of the ethics that we operate under. Always protect the patient, but might as well protect yourself fully too, and enjoy the often awe-inspiring experience of helping people get better with the help of ketamine. With that, thank you very much all for your attention, and I wish you the very best. Goodbye.
Thank you, Dr. Rakesh. What a great presentation. I very much enjoyed learning about the important role of ethics within the world of ketamine in clinical practice. We now look forward to Dr. Stephen Mendel once again touching on the role of ethics and the business of clinical care. Take it away, Dr. Mendel.
Okay, so I think Dr. Jane did a great job, and he really covered a lot of ground, and we really talked about so many different things in terms of, as really appropriate in a session that's talking about everything from microdosing to psychedelic dosing. It's a huge range, and what he says and what I'm about to say is more and more important as you start to enter the psycholytic and the psychedelic dose ranges. So this is the ethics of the business of clinical care, but it's also just the ethics of providing clinical care to people as a profession. So what is ethics? It's examining the rational justification for our moral judgments. Ethics studies what's morally right or wrong, just or unjust. In a broader sense, it reflects on human beings and how we interact with nature and other humans, on our freedom and our responsibility and on justice. So one of the oldest ethical principles, you see it in virtually all traditions, faith traditions, whether it's Buddhism, Christianity, Confucianism, Islam, you'll see Judaism, that whatever is something to you, don't do unto others. There's a more kind of nuanced update. This is what you do to others, what you would have them do unto you. And here we have treat others as they would like to be treated. It's a little change, but one that might make a big difference. And all it takes to put this new mindset into practice is understanding, curiosity, and compromise. Stay centered, stay tuned in to the patient you're trying to help or the client you're trying to help. Realize you're a tool, but you're not doing something to someone, you're doing something with someone. This is so simple, so obvious, and so for some people in some situations, so hard to continue to adhere to. The patient comes before the prophet. This is a business endeavor where there are frequently opportunities to save a little money by providing a little less service. You know, it's so easy when you're providing a service that you can't increase the price of to decrease the cost of providing it. And I understand the impulse. Very quickly, you will degrade the quality of the care you're providing with substantial decrement in the benefits. If everybody thinks that 60% is a good benefit, then maybe they don't have to be so meticulous in providing a set and setting, in providing the comfort of a recliner, in providing eye shields, providing really good noise-canceling headphones, but with the ability to give music that is suitable for that particular patient. That's what will drive your results from 60-odd% to 70-odd, maybe into the 80s. It's all there and available, and you can achieve that, but it requires that you put the patient before the profits. Know your own limitations. The Health Insurance Portability and Accountability Act really matters. It has teeth. Violating it is a felony. It's also subject to a lot of civil response by patients who feel betrayed by sometimes a very inadvertent disclosure. Remember, once you alter someone and they're in a non-ordinary state of consciousness, you can't change your agreement with them. By that I mean, it's common for patients to say, oh, could you turn it up a little? I'd like a little more. You might choose to do that. Don't think you have a defensible consent. Patients cannot consent after you've altered them. They can, however, decline to go forward. I highlighted, bolded, no physical intimacy. There's all kinds of nuance here. Touching a hand, a foot, a shoulder can be very acceptable if it's explicitly consented prior to altering the patient. But all interaction must be in the service of the patient. All must be consented. And when in doubt, don't touch. When someone is in an altered state of consciousness, they're in a super high state of suggestibility. What you may know to be innocuous and intended in a nurturant or even loving manner can be distorted by someone else based on things that you may have no concept of in terms of their past experience. It doesn't mean to hide from patients or stay away from them, or the old analytic, don't touch, but it does mean if you're a flamboyant person, if you like to hug and you like to be, touchy-feely with people, don't be doing that professionally. Be very cautious about touching your patients. Any doubt at all, don't. It's one of the major Donnybrooks in the field. So many otherwise good people have rightly or wrongly no longer practicing because they were inappropriate with a patient. Whether they were inappropriate or the patient thought they was inappropriate becomes very difficult to sort out. Know your own limitations. When you give something that causes a non-ordinary state of consciousness, there's a power shift. You're not a peer. You'll see patients all the time really enthralled with you. You have really helped them to get where they couldn't get without your help. But it's not you entirely that deserve the credit. It's not the ketamine entirely that deserve the credit. It's the patient that's done the heavy lifting. Be transparent about this. Be appreciative of people's gratitude without getting any delusions about your powers. If you induce a non-ordinary state of consciousness, you're responsible for helping that person to get back to earth. That's why it's so important that you understand the mechanisms, the details, that you are grounded yourself, that you've done prep work, that the patient has done prep work with you, that you're totally relaxed and comfortable with the set and the setting. Timothy Leary in, I think, 1962, way back before any of this happened, wrote about set and setting, and I would say in our clinic, set, setting, and anxiety level account for more than 90% of the benefit. If the mental set of the patient is right, and the setting is really a safe container for the patient, and the anxiety level is just right. And this is where benzos or not benzos come in. Too much benzos really attenuates the benefit. Enough benzos to take the edge off, to defang that tiger, will go a long way for people having a really beneficial, useful, and non-off-putting experience. You've got to comply with all the legal and regulatory requirements. Now you're giving ketamine, it's an off-label use. Ketamine is an approved drug, but whenever you change the population, the indication, the dose range, the route of administration, it's not on label, it's off label. It's perfectly fine to give off label medicine. In fact, in psychiatry, almost a full third of all prescriptions are written off label. However, for the practitioner who chooses to give a medicine off label, the burden of making sure that it's really in the patient's best interest is higher than with an on-label use. So don't be afraid of the fact that it's off-label. Lots of prescriptions are off-label. They do lots of good, but it puts more of a burden on you to have a understanding of what you're doing and why. Ketamine is the tool you've chosen to facilitate transformation. I hope you've also explored the possibility of the patient getting psychotherapy, either in your situation or by referral in other situations simultaneously with the treatment. I think it really facilitates it. The medicine is not the transformation, it's a tool to the patient transforming. The psychotherapy tremendously helps the patient to transform in a good direction. As has been pointed out elsewhere, and I agree, the medicine is an amplifier. What gives it vector or direction is you and other associated assists. And in our clinic, we use sleep hygiene, nutrition, exercise, a close interpersonal relationship, and talking therapy as the keys to making use of that amplification to go in a constructive direction. The ketamine is not the care and not a substitute for it. It's a facilitator. If growth occurs, we acknowledge it's the patient who did the growing. Your commitment, knowledge, and the provision of a safe container was beneficial, perhaps even crucial. But if transformation occurs, it's the patient who did the transforming. They get the kudos without being too elaborate about it, and they get the guidance in using this transformation constructively. Because getting amped up and enlightened and non-ordinary is not necessarily, doesn't necessarily guarantee you're going to go in a constructive direction. In order to facilitate going in a constructive direction, psychodynamic understanding helps prevent aimless wandering or squandered non-ordinary states of consciousness. You don't want to leave your patient or yourself in the wilderness. Learn one or more of the psychological approaches to understanding emotional organization and how to use it. Are you a sitter for a tripper, or you're a facilitator of growth? The difference is going to be whether you know and can apply. You don't have to be a journeyman. You don't have to be an expert, but you've got to have a working knowledge of something. Internal family systems, cognitive behavioral therapy, acceptance therapy, a system that you are comfortable applying to the non-ordinary state that you've helped to bring about. Online mail order ketamine providers responsibly providing this medicine is very difficult. Providing it remotely is absurdly difficult. I suppose it's possible. Responsibly providing the care that must accompany this medicine if it's to be therapeutic is more difficult still. Incidentally, while I was preparing this morning, I looked through headlines, and sometime late last night, the FDA decided that ketamine could no longer be provided without an in-person visit. I haven't read the article, but it's very hopeful. This is an interpersonal medicine. You can't give these pills out or throw them in the water and just hope that it will be facilitatory. You will have some benefit, but it's going to be way less than it could potentially be, and there's going to be a lot more harm. Now, in the Lancet, which is one of the most prestigious journals in the world, just a couple of months ago, a group of people representing a great many different indigenous interests got together and developed some ethical principles. These people are very distressed that their tradition, which goes back millennia, and their ability to make use of this medicine in their culture without problems with commoditization or abuse, is just being ignored. And it's not that they're complaining that we're not paying attention to them. It's that we're trying to reinvent the wheel. These folks, many of them, have been around this block for several thousand years now. And this is their consensus statement. It's a long and very worthwhile article in the Lancet. I've put the citation up there, but this is what they've come up with after really quite intense collaboration among themselves. This is reverence, respect, responsibility, relevance, regulation, reparation, restoration, and reconciliation. In the interest of time, I'm not going to go over all of these. Ethics is something you need to learn by asking yourself questions about what's appropriate, about where you fall on the spectrum from taking care of yourself to taking care of the other person. But this article is a really great jumping off point for thinking about that.
Thank you, Dr. Mandel, for your second presentation of the day, speaking on ethics of the business of the clinical care model. We look forward to hearing from Dr. Wilkinson. She's going to be touching on some interesting topics. The first topic will be ketamine, psychedelics, and the Oregon Ballot Measure 109. She will also be touching on the regulations for naturopathic prescribing rights across the U.S. and how those vary. And she will close out with charting and recording ketamine sessions best practices. We look forward to your talk, Dr. Wilkinson.
Okay, so we're talking about ethical considerations for naturopathic doctors in prescribing ketamine. Let's go to the next slide. Topics of discussion for this portion of the presentation are ketamine, psychedelics, and ballot measure 109. This is a huge topic, so I've narrowed it down just for the scope of this short presentation. We will go over regulations for naturopathic doctors across the US and a few charting and recording ketamine session considerations as well. Let's go to the next slide. I don't have any conflicts of interest to disclose here. Let's go to the next slide. Okay, let me just make sure. Yes, we're on the same one. Okay, so clinical pearl. I would argue that we need to start thinking about ketamine as a psychedelic medicine first and foremost. Although we now know that the clinical applications of ketamine are so broad in terms of route of administration, reasons for dosing, and dosing range itself, the possibility that patients are going to experience some degree of the psychedelic properties of this medicine are quite significant. Either intentionally, like they're coming in for that portion of the treatment too, that psychedelic journey experience, or inadvertently where patients are taking too much at home, dosing gets confused, human error, all of that. And so if we can, in our mind, be thinking about ketamine as a psychedelic medicine to start off, that will help us to stay safe and also to keep our patients safe, because we have an extra added layer of ethical considerations, of HIPAA considerations, and informed consent that goes around these kinds of medicines. Okay, let's go to the next slide. So we're talking about psychedelics and ballot measure 109. So ballot measure 109 is now in effect 2023, and this relates to the therapeutic use of psilocybin or magic mushrooms by licensed facilitators within a certified service center only in the state of Oregon. And there are several other states who already have ballot measures with additional considerations, stipulations, improvements from ballot 109, but we really are the pilot study for the whole country in terms of psilocybin used in a therapeutic setting. Let's go to the next slide. So when we're talking about ethics and how ketamine relates to psilocybin and ballot measure 109, the way that I've narrowed down for this presentation is what are the helpful guidelines and recommendations that we can take from all of the research, all of the meetings that were done to create and form Ballot Measure 109 and apply them to working with ketamine in naturopathic practice. Because ketamine, although the quality, there are differences in how the psychedelic experience unfolds with psilocybin versus ketamine, we can still take some of those ethical guidelines that came through with Ballot Measure 109 and apply them to our own practice with ketamine, especially as we're beginning. Let's go to the next slide, please. Okay, so here are a few bullet points. There are many, many more. I know there are holes in this presentation because we narrowed it down for time, but I do really strongly feel that clinicians need to seek out additional training, mentorship, and resources to continually improve their skills in working with patients in non-ordinary states of consciousness. And you can do this with psychedelic medicine. So you can do experiential ketamine trainings, which are wonderful and very important. And you can also get into a non-ordinary state of consciousness with something as simple as breath work. So holotropic breath work. There's lots of different ways to access non-ordinary states of consciousness if you're not able or not interested in working with ketamine or other psychedelic medicines and substances specifically. But I do really feel like there's extra training outside of the scope of this presentation that should be sought out by clinicians who are going to work with ketamine in a psycholytic or psychedelic dose range. I also believe that emphasis needs to be placed on supporting clinicians in adopting and implementing social equity and inclusion plans. This is a huge portion of Ballot Measure 109, and many of the guidelines regarding social equity and inclusion plans, both for the business side as well as the clinical side, the patient experience, the provider experience, all of that comes from the cannabis industry. So there's some really great resources. If you look at the Oregon Health Authority OHA website and you look at Ballot Measure 109, you can follow that down and find specific recommendations and businesses, mostly in the cannabis industry, that are implementing really high quality social equity and inclusion planning. And so you can take those ideas and narrow them down and make them work for you in a single person or a few provider naturopathic practice and still be addressing this concern of social equity and inclusion. Okay, let's go to the next slide, please. It's also important, one thing we can get from Ballot Measure 109 is that lived experience by the clinician and by the medical provider or the mental health provider in non-ordinary states of consciousness is vital for effectively understanding and holding space for others in those states. There are many clinicians that probably wouldn't agree with me, but if you're planning to work with psychedelic medicines, having that lived personal experience to be able to empathize, understand, talk about, is really, it's vital. Okay, we've talked about informed consent a lot, and this is just going to be a part of the conversation in every aspect of working with ketamine, controlled substances, and psychedelics now and into the future. So we have to account for informed consent at every step of the process. If you do, in my practice, we do it as part of the medical intake and the questionnaires that the patient fills out ahead of time before they come into office. We talk about it during their office visit, and we also talk about it before and during each session, depending on what's needed at that moment. And there are special ethical considerations when patients are outside of their normal conscious awareness. And also, really, this comes up a lot with somatic touch and body work. So Dr. Mandel alluded to that we have to be very explicit and understand what our relationship is with the patient and how we can or avoid incorporating touch in those sessions as well. Let's go to the next slide, please. It's also key to understand and differentiate providing physical safety for patients who are going into a psychedelic journey space or an altered state of consciousness, as well as something that has been termed psychic safety. So physical safety is, do we have the appropriate equipment, including furniture? Is the furniture close to the ground? So if a patient rolls or falls over, or are there mats that we use on the floor? How are we setting up the space to promote safety for the body and the mind? Do we have an emergency plan in place? Do we know, for example, like an incident report, if a patient does have a hard experience, how are we documenting that appropriately? Do we have our basic life support training? Do we have suicide training? All of those things are a part of keeping a patient physically safe and precautions that should be taken and thought about ahead of time. And then also we have the psychic safety piece, which adds a whole different level of training and guidance and resource that needs to happen. And that's including things like, how do you handle the dissociation quality of ketamine? For some people, that's very disorienting if they feel that they have no grounded connection to their body. For some people, that's healing and therapeutic, and for some people, that's very frightening and disoriented. How do you handle that? Have you been appropriately trained for that? Are you trauma informed? And how do you deal with a trauma recurrence if it comes up during or after a session? Informed consent, dealing with the basic anxiety or panic attacks, all of that is part of that psychic safety piece that we should be considering as well. I'm just going to emphasize again that you will need ongoing additional training to be able to provide these safety measures with patients. This is something that if you want to offer psychedelic medicine in your practice, it should be a personal practice to continue educating yourself and refining those skills over time. Okay, let's go to the next slide, please. Okay, if you are considering starting to offer ketamine in practice or expanding your dosages, your protocols, your routes of administration, just ask yourself, am I in integrity? Am I staying in my lane, as Dr. Rakesh was discussing, when I'm offering these treatments? This might feel like a no-brainer, like, of course, I'm doing this to benefit the patient, and so I'm in integrity, but really, are you aligned with yourself? Are you able and available to hold space for that patient? Are you recommending this treatment out of a sense of integrity for that it's going to be the most beneficial option for the patient? Have you considered other treatment options for this patient? Have you discussed those options? So really, really slowing down and taking time to determine whether you yourself are in integrity when offering ketamine to a patient. And then, do I know enough to feel comfortable working with this patient or to deal with issues as they come up? How to troubleshoot challenging cases or side effects, things like that. And how would you feel if you were your own patient visiting your clinic? How would you want to be welcomed? How would you want the space set up? Really thinking about what that would feel like if you were in the patient's shoes is helpful. Okay, let's go to the next slide, please. All right, ketamine prescribing for naturopaths state by state. In Oregon, we now have the most comprehensive scope of practice for prescribing and administering ketamine in the United States. We're just going to take a quick look and remind ourselves of the current state of ND licensure across the US. Let's go to the next slide, please. This is current and up to date as of 1/22, but there might be updates even from this. This is just the state of naturopathic licensure, not in regards to ketamine. And so this has it broken down slightly differently. Where are NDs licensed and registered? And then is there some degree of insurance coverage? Where are the advocacy initiatives going, et cetera, et cetera. So just taking a look and reminding ourselves of where do we have a scope of practice at this moment in time. Let's go to the next slide, please. We went over a little bit of this with Dr. Hillary's presentation. We're talking about ketamine, which is a Schedule 3. It's a non-narcotic Schedule 3 medication. This includes other anabolic steroids such as testosterone as well. Interestingly, we find that Xanax, alprazolam, a benzodiazepine, is a Schedule 4 and is supposed to have less of an abuse potential than anything in a Schedule 3, but I often see the reverse of this, that ketamine in practice actually has a lower rate of dependence than something like Xanax does. So interesting to note. Let's go to the next slide, please. This is that document I was talking about in the presentation earlier, which is from the DEA. Here's the link. I also have the PDF. You can totally email me if you want a copy of it, but it shows you exactly state by state. Our designation right here, naturopathic doctors, we're right there with the green arrow. Let's go to the next slide, please. And this is just a general breakdown. So I've done it by the states that do have some level of DEA prescribing rights as mid-level practitioners. So in Oregon, we have the most comprehensive formulary, so we can prescribe, administer, dispense, and procure Schedule 2, 2N, 3, 3N, and 5. And then 4 medications only as directed on our state formulary. Arizona also has really open prescribing rights. California has some prescribing rights, et cetera, et cetera. So California, DC, Montana, we don't need to go through all of those. You have the slides in front of you. You can take a look at the document as well. Let's go to the next slide. And then I did list out the states that have no prescribing rights as of right now. In Washington, there was a question in the chat about whether Washington-based naturopathic doctors can prescribe ketamine. And it sounds like the consensus answer is no at this point. Let's go to the next slide, please. Okay, so we're going to move really quickly to documenting and charting considerations. The number one thing to remember is, what is your role for this patient in this appointment? Are you just prescribing the medication and they're going to be doing the ketamine-assisted therapy in office with a counselor? Are they just doing microdosing with you? What is their other support system? And this is going to change how you chart the visit. So medical charts include things, right, like medications, allergies, physical exam. We know that. Let's go to the next slide, please. We know that counselors and mental health providers have a different level of release of information that's required for therapy and counseling chart notes. And so you want to establish a release of information with a mental health provider early on, and you want to try to establish that connection if you're going to be in the prescriber role and the patient is going to be doing the ketamine-assisted therapy in office with their mental health provider. That will be very helpful. Let's go to the next slide. Okay, so this is what I was talking about. Sorry, those slides got a little bit out of order, but there is a different, higher level of HIPAA regulation that's required for mental health and therapy notes. Psychedelic integration is considered a total gray area, and there are no standards, no guidelines for what an integration chart note should look like or what it should include. And so we have to be really careful about what role we're playing. If you're going to be the medical prescriber, sticking to the medical information is the most important. If you are doing some of that counseling and integration work, we'll see later on that it would be a better idea to have a separate chart note and even maybe a separate EHR system in order to keep those notes separately and only release those chart notes with that elevated level of release of information. Let's go to the next slide, please. Okay, so these are some examples of how you might change your charting based on what role you're playing. So ketamine intake, this is a medical chart, very simple. Ketamine assisted therapy in office. In my office as a prescriber, this is a medical chart. So I'm including things like what medications they took that morning, when they had food, what their vital signs were, are there any symptoms that are popping up that I should take of note, et cetera, et cetera. And for me, my ketamine-assisted therapy integration notes are kept separately. And the reason for that is it has a heightened level of vulnerability and patient insight and information that's very personal. So we have to be making sure we're taking that into consideration. So for me, this is a totally separate integration note, not related to the medical chart. Let's go to the next slide. So this is a clinical pearl. We already discussed this a little bit, but you could consider using an entirely different, very simple charting system for your psychedelic integration or counseling support. This can reduce human error when you're transferring patient chart notes to other medical collaborating providers. They would be kept totally separately. Some examples of that would be Osmind, Simple Practice. These ones are nice because they're typically set up for mental health providers. Documentation and charting. Let's go to the next slide, please. I think it's really great to have a specific ketamine intake template in your EHR system that helps you not to leave out important information. Because this is a controlled substance, you want to have a standardized form or protocol for everything that you do that you go over and over and over. That way it's less likely that you're going to miss something important. The way that I typically do that in my initial ketamine-specific therapy intakes is I'll kind of just hear the patient's story. Like, why are they seeking treatment? What are their goals for treatment? Tell me a little bit about the history and background of their anxiety or depression. And then I have a template specific for ketamine that I use and incorporate after that to make sure that I'm crossing my T's and dotting my I's and have all of those very specific contraindication questions written out and documented. Let's go to the next slide, please. Okay. So we know that regular use of ketamine is going to induce tolerance. You should expect to need to increase the patient's dose over time. There are some exceptions in special populations, for example, patients with chronic kidney disease, liver disease, patients with certain medications that are inducers that are going to potentize the ketamine. You don't necessarily need to increase your dose very often. So make sure you have a clear and easy method in your practice for keeping track of what your starting dose is and then how you're tracking that and changing that over time. It's really easy. I've seen a lot of ketamine infusion clinics have just a very standardized infusion form. It states very clearly the dosages, which will change over time. And you could easily do that with oral ketamine. You could do that with microdosing, but having a simple and clear form to track that is helpful. This also really reduces the abuse potential for ketamine because you're aware, you're keeping very close track of any dosage changes that you're making for patients. Okay, let's go to the next slide, please. Okay, so here's the summary. Just know your role in this patient's care at all times. That role may change over time. I have lots of instances where someone comes to see me for naturopathic care. Maybe we start with ketamine microdosing. Eventually, they feel ready for doing ketamine-assisted psychotherapy in office. That's going to change my role and add an additional layer of protection for them and for myself as well. So just reminding yourself of that. You will need a team approach. If you're going to be doing psycholytic or psychedelic dosing of ketamine, you'll want to have a team, a web of support for these patients. And maybe that includes their chiropractor, their acupuncturist, their counselor, their primary care doctor, and you as the ketamine-assisted therapist. Whoever's on their team, just make sure that everybody's aware that they may need support as things come up and are available for processing in the psychedelic space. Create systems that are easy for you to use and practice and that are consistent over time. It's going to save yourself a lot of time. And it's going to keep your track record very clear. It's good to have specific protocols and documents that you use over and over again and not change it every time. Seek out additional training and mentorship. There's lots of opportunities out there. Stay in your lane to start, get really comfortable if you want to start with microdosing and then start increasing that dose to psycholytic or psychedelic dosing. It's very easy to do, but you should have some additional training and some mentors that you can call and ask questions to as concerns or issues arise. Start small, increase your treatment options and considerations as you feel ready. Don't step outside of your comfort zone, collaborate and refer. Let's go to the next slide. I have added some additional resources for training and collaboration. So these are some local ones in Portland area. And then if you go to the next slide, general resources for training with ketamine. There's some that are online, some that are hybrid, some that are experiential in-person only, like retreat type settings. Lots of great opportunities to learn about this for yourself. These are resources on the next slide for psychedelic equity and inclusion, resources for equity and inclusion in the psychedelic space. There's a few that are free. There's a few really interesting articles right there at the bottom, lots of websites to look through and start this process. For me, this has been an ongoing, evolving process over time. And again, I'm committed to making it better and better as I get clearer and clearer in my practice. But it's really nice to have these resources as a place to start that equity and inclusion process. And then the next slide is acute suicidal mental health crisis resources. Again, these are local to the Portland area. Not everybody's in Portland, not everybody's in Oregon that's watching this, but at least there's something to get you started there. And the next slide, feel free to reach out to me at any time. Thank you so much for letting me present today. And I'm happy to answer any questions now or later on after as well. Thank you.
So thank you to all the presenters. It was just an amazing team. Everybody put a lot of work into it, brilliant material and brilliantly presented. And I hope that all of you people who are watching are able to make use of it, taking the words again wisely of Dr. Jane, that think about everything you do and say matters as far as we want to protect the medicine as well as our patients. So don't try to be saying that this is a medicine that can do anything for anybody. Recognize its limitations, but also try to offer it in ways that will be helpful to your patients. Thank you again.
Thank you for joining us for the educational content. We hope you found it insightful and applicable for your patient population. Please scan the QR code listed here to be taken to the quiz. Upon completion of the quiz, you will be emailed a CE certificate. Please note the email address in case you have any questions or concerns, susieconsulting@gmail.com. We're also happy to provide you with turnkey and progressive protocols referenced in the educational materials today. Thank you again for your investment in your education and your patients' outcomes. Take care.
Thank you so much for attending Ketamine Across the Dosing Spectrum. We hope you found the information insightful and will bring value to you and your patients. Please do note the email address on this slide. If you need any additional support or additional resources in regards to the protocols referenced in the discussions today, or supporting documentation or resources in general, please don't hesitate to reach out to the email address noted here. Thank you again for your time, and hopefully this information will go a long way towards improving outcomes in your practice. Take care. Thank you so much for attending Ketamine Across the Dosing Spectrum. We hope you found the information insightful and will bring value to you and your patients. Please do note the email address on this slide. If you need any additional support or additional resources in regards to the protocols referenced in the discussions today, or supporting documentation or resources in general, please don't hesitate to reach out to the email address noted here. Thank you again for your time, and hopefully this information will go a long way towards improving outcomes in your practice. Take care.